Iowa ACC. This is going to be the first annual Iowa ACC chapter meeting. We had meetings some time ago, but haven't had for quite some time. So hopefully we can start the tradition this year. We were planning last year and the plans got changed because of the pandemic, but hopefully we can start the tradition this year and keep it going. This will give a good opportunity for our own faculty and our trainees over here to present their talent and share their success stories here. So this year, I want to thank the planning committee who has been very helpful in guiding me in the right direction. We plan to have a session mainly on COVID and on keeping up with science. We're going to have 2 long talks. One is Dr. Jeopardy, who's the ACC president, and negotiations, not just in contracts, but also in daily life. How do we deal with that and stuff like that? So I'd like to start with the first session, cardiovascular complications of COVID. The cardiac complications of COVID have been termed almost as the cardio-oncology complications, the variety of complications it can cause. So I'd like to thank all the speakers for doing these talks and for the moderators for doing this. This session is going to be moderated by Dr. Christodoulos and Katie Helmer, our nurse practitioner. Georgios, as many of you know, is an assistant professor at the University of Iowa. He's an imaging cardiologist and he specializes in multimodality imaging along with cardiac CT. His favorite for the fellows for all the education he gives. So he's going to be moderating along with Katie. Katie is our nurse practitioner who's very active in a lot of areas in cardiology, including the COVID clinic and hypertrophic cardiomyopathy clinic, genetics clinic, and so on. So I will let Georgios and Katie take over from here.
Good morning, everyone. Mahi, thank you for your kind introduction and thank you for organizing this. So I guess without further ado, I want to start with introducing our first speaker. Our first speaker is going to be Dr. Ian Law. Ian is the Division Director for Pediatric Cardiology at the University of Iowa Children's Hospital. He's a professor of pediatrics and has served as clinical director of pediatric cardiology since 2006. He has also served as the director of the pediatric electrophysiology program since 2003. He's also the head sports medicine cardiologist for the University of Iowa Department of Athletics and represents University of Iowa on the Big Ten Cardiology COVID-19 Sports Group. Ian is an internationally renowned cardiac electrophysiologist who has published extensively in his field and was elected to serve as president of the Pediatric and Congenital Electrophysiology Society. Ian will be speaking to us about myocarditis and the athlete.
And make sure you can see my screen here.
Yes, we can.
Okay, I just need to change this right here.
I think you're on the last slide, though, yeah.
Yep. Well, take a look. This is what this talk's going to be about. So I'll try to cover more details on that. So this is an interest of mine. Actually, it's been was kind of demanded by the Big Ten, but looking at myocarditis in the athletes, I have no disclosures, and thank you for the kind introduction too. So as you pointed out, COVID and the pandemic has created this tidal wave of literature. And back in May of 2020, there were more than 5,000 articles a week being published about COVID-19, and many of them focused on the cardiac effects of this, as that was a key driver in the morbidity and mortality. So there's a lot of effects COVID can have on the heart, and this group is going to discuss many of those. What we're going to focus on is the direct viral myocardial invasion, or at least we think the direct myocardial invasion, but you can have effects from lung injury causing effects in the heart, the type 2 MI. You can have indirect inflammation, you can have coronary artery rupture, you can have microvascular thrombosis, then you can have just stress cardiomyopathy. Our focus today is going to be on the viral myocarditis and the otherwise healthy individual. So, why is this important? Well, back in Wuhan early on, we recognize that if you had cardiac injury, and when we say cardiac injury, this was determined by if your troponin, your high sensitivity troponin is greater than the 99th percentile, your risk of mortality went up dramatically. So 20% had a cardiac injury, and the mortality was 51% in that group versus 5% if you had no cardiac injury. And this is the work by Shi. You can see here if you have the cardiac mortality rate, if you have injury, which is manifest by high troponin, this is your mortality rate versus no cardiac injury. A follow-up study showed that the cardiac injuries manifest in almost 30% of the patients, and the mortality rate was 60%. And then there's an interesting observational study in Germany where they looked at cardiac MRIs, and we'll cover this a little bit later, 71 days out from a COVID infection, and they saw cardiac involvement by cardiac MRI in almost 80% of the patients. So this raised a lot of concern in the general population. If you know that almost 2 months, 2.5 months out, you're going to have 80% of the patients having some cardiac manifestations. So, what we're looking at, I think this is a slide that will refresh many of us. What is a troponin? Troponin is a portion of the sliding filament, so it's on a thin filament. And when we get inflammation, this troponin gets leaked into the bloodstream. Now, I think as you read the literature, you'll realize that not all troponins are equal. And back in 1995, back when I was in medical school, we are using a much less sensitive troponin. And over the years, we've got the troponins become much more sensitive. What's important to point out is as you get more sensitive, you also get less specific. And if you have significant renal disease, you can have an elevation in troponin that may not necessarily represent cardiac injury. We are currently using a very high sensitivity troponin. And even with this high sensitivity troponin, there are different cutoffs for different age ranges. So if you're under 19 years of age, the troponin, a normal troponin for males is less than 14, for females less than 11. If you're over 19, it's less than 22 or less than 14, except if you're in the emergency department, we use over 100 as a more worrisome value. So if you have cardiac injury, when is your troponin going to peak? And I think this is an important slide because, as we point out, it isn't necessarily from a STEMI, which you'll see a peak right around 24 hours, and it can wax and wane, or non-STEMI, but you can see it in myocarditis, which is what we're concerned about today. But last week I ran the Des Moines Marathon, and I knew about this slide, but here I am a day out from my marathon, and my troponins are peaking, and then slowly, gradually dropping back down again. I didn't check my troponin, thank goodness, and I don't want to know what it was. So the take-home message here is, if you have an increased troponin, you need to suspect myocardial injury. May not be, could be something else, but myocardial injury should be higher on your list. So when you think about myocarditis in the athlete, what's the data behind this? And this is a study done back in 1964, 1 year before I was born. And a lot of the data we have of myocarditis and the restrictions we have were based upon this data like this. So what they did is they took 108 mice and they put 36 mice into each group, and they had 4 groups. And what they did with these mice is they preconditioned them. So this column right here was a group that was preconditioned with exercise, whereas these 2 groups did not get exercise. And after 2 weeks, they inoculated the mice with Coxsackie A9 virus. So they injected this virus into the peritoneal cavity. So these 2 columns had myocarditis, this viral infection. These 2 didn't. So once you've got a group that's exercising, they got inoculated, a group that's not exercising, got inoculated, and 2 groups. This one's exercising, not inoculated. This one's not exercising, not inoculated. And then they exercised them for 3 days vigorously. And how do you make a mouse exercise? You drop them in a bucket of water, and they'll exercise vigorously. And so this group with myocarditis exercised, this one didn't. These 2 were not, of course, injected with the virus. And what they found is those mice that were injected and were exercising vigorously had much larger hearts and had a much larger viral load of in the cardiac specimens, whereas the ones that didn't exercise had smaller hearts and didn't have a higher viral load. Of course, those that were exercising that didn't have the virus had bigger hearts, and then the ones that had no exercise and no virus were the smallest hearts. And so a thought was, if you have myocarditis and you've exercised vigorously, you put yourself at a much higher risk for a higher viral load and possible ill effects. Now, it's important to point out that the definition of myocarditis is often overused. And we throw around the definition of myocarditis saying, well, if you have inflammation, if your troponin up, it must be, and you don't have an infarct, then it must be myocarditis. And that's not necessarily the case. And early on, they thought that only less than 7% of the cases of COVID-19 related deaths were attributed to myocarditis. But in order to make the diagnosis of myocarditis, you have to have histologic findings. So you have to have inflammatory, lymphomonocytic infiltrates, and myocytic necrosis, not typical of ischemic injury. You also have to have the SARS-CoV-19 genome in the heart tissue, which makes sense. But you also have to see viral particles in the cardiac myocyte. So if it's just in the bloodstream, it doesn't count as myocarditis. In addition, you also have to make sure they don't have another virus, such as a Coxsackie virus, enterovirus, in the heart tissue that may have been causing. You may have a myocarditis that you think is attributed to COVID-19, but it may be due to Coxsackie. So you have to exclude that virus too. And obviously, the vast majority of cases that we call myocarditis have not gone through this vigorous workup. So the point here is myocarditis will cause inflammation, but not all myocardial inflammation is myocarditis. And myocarditis is a subset of this myocardial inflammation. And so the diagnosis of myocarditis cannot be based only on troponin levels, or MRI for that matter, and additional evidence is often lacking. So this will be covered later on, but one of the things we want to focus on is how we're going to make the diagnosis. If a troponin in itself is not important, what else can we look at? We can look at the EKG, and this is a study out of a Presbyterian hospital in New York. And what they found is they looked at survivors and non-survivors of COVID-19 infections and look at EKG findings. And these were the EKG findings that were seen in those that were non-survivors. And the PACs, conduction delays, abnormal access, MI changes, T-wave inversion, were those that were associated with a higher risk of mortality. These were not. And the elevated heart rate in itself was not. ST elevation in itself was not. The problem is that if you're looking to use this as a tool with athletes, there's a big overlap between what we're going to use as a harbinger of a bad outcome and what can normally be seen in an athlete. So a left axis deviation, right axis deviation, T-wave inversion, and up to V4 is often seen in athletes. And so looking at the EKG criteria, these were normal findings. If you have two or more of these findings that put you into a higher risk category, if you have any one of these that put you in a high risk category, this is just looking at athletes and cardiac disease. But there's an overlap of what we see in COVID-19 and what we view as risk factors. Looking at the echo, this is a study out of Tel Aviv, looking at patients that were hospitalized with COVID-19. And they got echoes on admission if they had deterioration, or if they had subsequent deterioration during hospitalization. They did an echocardiogram to see what the effects were of COVID-19. And the most common effect from COVID-19 was our right ventricle dilation and dysfunction, which was seen in more than a third of the patients. Interestingly, a third of the patients also had normal echoes. LV dysfunction was less commonly seen, and diastolic dysfunction was a component of that. So how does that affect, how do we use that as a tool to evaluate our athletes? Well, RV dilation and LV dilation is actually quite common in athletes. So if we're going to use that as a tool, it may not be the most specific tool. So this is a study done by Barry Marin back in 1986, but I think it still adds value. And if you look at non-athletes versus athletes, and these are ventricular wall thickness, LV diastolic dimension, RV diastolic dimension, you'll see that the athletes have larger and thicker hearts. And this is the percent difference between the normals and the athletes. So if you see an athlete who comes in, who's had a COVID infection, who's got a large heart, one can assume that it's due to the COVID-19 infection. And this is that study out of Germany where they looked at cardiac MRIs. This is done on average about 2.5 months out from COVID-19. And they had a nice study here because they had healthy controls that were not infected with COVID-19. And they had those that had COVID-19, those that never required hospitalization, those required hospitalization. And this is looking at the troponin level. Now, this group's important because this group had risk factors like congestive heart failure, diabetes, other things that would put you at risk for having an elevated troponin. And so they said what they have here is the troponin levels are elevated, but not nearly to the extent that you see if you have COVID-19, either at home or hospitalized. And these are looking at your MRI changes. And what you see once again is those that have are normals have a low risk of having MRI changes with either T1 and T2. And those that were either hospitalized or non-hospitalized had a higher T1 or T2 changes on cardiac MRI. And this was once again 80% more likely to have changes after COVID infection. So when you look at these criteria, you have to have some basis for what you call myocarditis. And these studies have used the Lake Louise criteria. And I'm not going to go over this because Mahi's far more knowledgeable about this, and I'd only embarrass myself. But in the studies that have been done, the vast majority use the Lake Louise criteria. The problem with, just like with echo, if you look at athletes and you're trying to look at an MRI, athletes have on average larger hearts. So this is a group looking at MRI values for just thickness and dilation. This is focusing on dilation. These are non-athletes, these are regular athletes, and these are elite athletes. And what you see is the left ventricle volumes in athletes are much higher. Same thing with, and this is for both men and women, and these are right ventricle volumes. So a large heart does not necessarily, if you're an athlete, mean you had a COVID-19 adverse effect. So now this goes back to the myocarditis in athletes. Early back, as is probably July and August, these publications came out primarily based upon these German studies looking at the effects of COVID on the heart and the long-term effects. And Penn State did a study, and they said 30 to 35% of their Big Ten athletes had positive COVID-19 had myocarditis symptoms. Now, this was subsequently disproven, but at the same time, there's a Nigerian-born basketball player that died suddenly after a COVID infection. There's another one that died in Florida. And so this started raising some red flags. So why is that? Well, we know from very recent study looking at an autopsy theory that 5% of those that have a sudden cardiac arrest had myocarditis. The most common cause was hypertrophic cardiomyopathy, but this is the subset we're looking at. And in this subset, half of these patients that died of myocarditis had no symptoms before they died. And so this is a group that we have to focus on when we're looking at COVID. So September 11th of last year, the Ohio State group published a letter to the editor in JAMA, and they said, and they had 26 Division I athletes, and they found that of those that had COVID, 15% had MRI changes suggestive of myocarditis, and 30% had late gadolinium enhancement without T2 elevation suggested prior myocardial injury. And so what the conclusion there was to conclude, cardiac MRI may provide an excellent risk assessment for myocarditis in athletes who have recovered from COVID-19 to guide safe competitive sports participation. Soon after that, a group of people wrote a letter to the editors saying, we are a group of clinicians, researchers, and imaging specialists concerned about the presentation, interpretation, and media coverage of the role of cardiac MRI in the management of asymptomatic patients recovered from COVID-19. In light of your society and our society standing in the community and advocacy against low yield testing, we request that you offer clear guidance discouraging cardiac MRI screening for cardiac COVID-19 patients. So here we have two diametrically opposed approaches to this. The Big Ten saying we should be getting cardiac MRIs. Another society saying don't get cardiac MRIs on asymptomatic patients. The reason why it's important in athletes is if you get diagnosed with myocarditis, based upon those early studies in mice, you have to be restricted for no less than 3 to 6 months after the initial illness. And if you have a scholarship player and you have to restrict them for 3 to 6 months, this is a big step to take. And then after you restrict them, you have to go through a clearance protocol. So there were around this time, they had these protocols for saying, if you have an athlete under age 15, what should you do if they have a COVID infection, if they're asymptomatic, if they're mildly symptomatic? And if they're under age 15, they basically said, you don't need to do any testing at all. If you had moderate symptoms to severe symptoms, you could consider formal testing. Now, if you're over age 15, which is our college athletes, you follow the adult protocol, asymptomatic, no testing required. Mild symptoms, cardiovascular testing unnecessary, but could be individualized. Moderate symptoms, it's evaluation with ECG, troponin, and echocardiogram. And if it's severe symptoms, obviously you're going to get a full evaluation. So what did the Big Ten do? They said in September 16th of last year, all COVID positive athletes will have to undergo comprehensive testing, including troponin, EKG, echocardiogram, and cardiac MRI. So September 16th last year, all Big Ten athletes had to undergo a cardiac MRI, and they had to receive cardiology clearance from a cardiologist, which turned out to be me. Now, we classified Big Ten sports differently, and in this case, high contact sports were those that had the highest rate of transmission, which included football, obviously, with both high contact from contact and from viruses, but also you also have wrestling, volleyball, field hockey. These are other high contact sports because of the COVID-19 infection spread, whereas swimming, diving, bowling, track and field were not. So this was a Big Ten protocol: educate the players, identify by rapid testing, then PCR, isolate them, evaluate them with H&P, troponin, EKG, echo, cardiac MRI. All this data got entered into a Big Ten registry on an IRB approved study. You go through a management protocol, which may be a gradual return to play, educate, and if they have symptoms, you go back to this evaluation. So with this, what was the result of this study, which is the Big Ten athletes, compared to other pro sports? And if you look at the study that published in March of last year by the pro sports, and this was NFL and Major League Baseball, basketball, women's basketball, soccer, they had 789 athletes that were COVID positive. We don't know what the denominator was here. The vast majority were males, mainly based upon the sports that were tested. 60% were symptomatic. The testing protocol was based upon the American College of Cardiology return to play protocol. They did this testing and they did a cardiac MRI if they had symptoms or abnormal triad of a test in the triad. Their myocarditis rate was 0.6%. And all their myocarditis athletes had symptoms. The NCAA did a survey of 42 different colleges, and of the 20,000 or nearly 20,000 athletes that were included at these universities, 17% had COVID. This is the breakup of the population or breakdown. The protocol for testing was institution specific, and what they found is the myocarditis rate was 0.7%, but if you had to get a cardiac MRI, based upon cardiac MRI, 3% had myocarditis. And in the Big Ten athletes, the surveys, 13 institutions were included. Here's the reference. Our COVID positive rate at that time was 30%, 60% of the people were male. We had mandatory testing, as I outlined before, and in this study, 2.3% of the athletes were found to have cardiac or myocarditis, mainly based upon cardiac MRI. If you just base it upon symptoms, it was 0.3%. If you did the triad testing positive, if any test was positive, myocarditis was 0.8% based upon cardiac MRI. If either the symptom, if they had symptoms or the triad, and you did a cardiac MRI, is 1.1%. So, and then if everyone got a cardiac MRI, it's 2.3%. So the current Iowa process is based upon this. We've modified it somewhat. We do this, right now we're not doing a mandatory cardiac MRI. We're just doing this screening with H&P, and if they have concerns, they get one of these or symptoms, they get a cardiac MRI. All this data is still going to the Big Ten registry. So I looked at our data, and out of our data, what were the things that would indicate a risk of cardiac MRI? Number one is if you had symptoms lasting more than 9 days, you're much more likely to have a cardiac MRI that shows myocarditis. And also we showed that if you had an abnormal EKG, there was a trend towards a higher myocarditis rate, and the p-value there was 0.83. And this is an EKG on one of our patients that had a myocarditis, and he had these inverted T waves over here. So an EKG may have been a predictor of an abnormal cardiac MRI in our population, but this is a very small number out of the total Big Ten study. So what I think we need to do now is continue this. One of the problems we have is we're drawing a troponin well after they've gone through their isolation phase, right? So 14 days, 10 to 14 days later, we're drawing troponin. If we get a troponin early on, we may have a better indicator of myocarditis. And then all these studies that we're looking at now need to be adjudicated. We need to have the MRIs adjudicated, EKG adjudicated. and echo adjudicated so we can get a better handle on what are the predictors for myocarditis. So I want to take a little side step here, just looking at myocarditis from the infection and myocarditis from the vaccine, because a lot of people are saying, well, I'm an athlete, I don't want to get the vaccine because I'm worried about vaccine-related myocarditis. Well, the infection rate from, or myocarditis rate from the infection is about 0.6 to 2.3%. If you look at the other studies out there, the Israeli military, there's 2 studies on the Israeli military, and there's one out of the Ministry of Health, the US military and adolescents. The myocarditis rate from the vaccine is somewhere between 0.0008% and 0.01% versus 0.6 to 2.3%. So based upon this, I'm telling the athletes, you should get vaccinated. You shouldn't wait for an infection. So on that note, I know that was a lot of data in a short period of time. I want to make sure I give time for the other speakers to talk. One of the take-home points is COVID-19 can affect the heart due to multiple mechanisms. Myocarditis, fortunately, is relatively infrequent. A troponin is an important biomarker, but it's not perfect. And just because you have a normal troponin doesn't mean you have no myocardial infarction. A lot of actually all of our athletes that had myocarditis, none of them had an elevated troponin at the time of the studies that showed myocarditis. Cardiac injury can persist after symptom resolution. So we've had some patients that went through the testing, did fine, then later on we found out that they had some smoldering myocarditis. The return to play recommendations are, it's a moving target, but significant myocardial injury obviously warrants restriction based upon that mice data. And there's much to learn about the cardiac diagnosis and management. What we don't know is if you had a myocarditis, what's the effect going to be, not now, but down the line, a month down the line, a year down the line, 10 years down the line. And of course, that's something we'll just need to track these athletes for. That is my talk, and I think we'll probably have time for questions later on.
Okay, thank you, Ian, for an excellent talk. I sure have some questions for you, but we'll do the questions at the end after we finish the whole session. So we're going to move along to our second speaker. Our second speaker is Dr. Sandeep Sahai. Sandeep is an assistant professor at Houston Methodist, where he also serves as the co-director of the pulmonary hypertension and chronic thromboembolic pulmonary hypertension programs. He previously completed his residency in internal medicine at the Cleveland Clinic and fellowship in pulmonary and critical care at the University of Texas. His area of expertise are pulmonary arterial hypertension and chronic thromboembolic pulmonary hypertension, and he has published numerous articles in these fields. He's also the associate editor at the Respiratory Medicine Journal. He will be speaking to us about thromboembolic complications in COVID.
I'm sorry, can you hear me now?
Yes, we can hear you and see your slides.
Okay.
Yes.
Okay, great. Thanks, Georges. Thank Mahi for the kind invitation, and I'm glad to be here. Let's start. Can you see my slide? Or let me make it full screen. Can you guys see it?
Yep, perfect.
Okay. Morning from Houston, and let's start. So this is an interesting topic, and as you know, for the last couple of years, we've been struggling with COVID-19 and with different waves. And I still consider that this topic is sort of evolving. We have understood quite a bit, but there is a lot more which we are not really sure. And I'll discuss some of the trials in this presentation, which has recently come up actually within the last couple of weeks, got published. And we'll discuss briefly about them, that how that will impact care and what's the role of those. And then since it's a thromboembolic complication, so I know I'm speaking to all the cardiologists, these complications do not just limit to the cardiology. or only to the heart. They're basically systemic complications and involving different organ systems. So the cumulative evidence is from different, it's sort of a multidisciplinary approach when we are managing these patients. So with that, let me start my presentation. These are my disclosures. I have a lot of active research going on with industry partners, and I serve on their committees and advisory roles. I will not be discussing any off-label use of any drug, and which would none of these conflicts is related to this current topic. So as we know, it's a viral illness, and majority of mortality is related to the ARDS, and so that's why most of the damage as the virus gets introduced into our bodies is affecting lungs, and but there are manifestations which are beyond the pulmonary parenchyma, and we'll cover some of those in this topic today. COVID-19 compared to other viral illnesses was sort of unique from the very beginning, that there was a lot of attention towards the thromboembolic complications, although the exact mechanism is still not very clear, that why we are noticing sort of higher incidence of these complications in COVID-19 versus other virus illnesses. And there are different mechanisms suggested, like hypoxia, excessive inflammation, platelet activation, endothelial cell dysfunction, and stasis. Now, we certainly know that the hospitalized patients have a higher incidence, and the current guidelines recommend anticoagulation in these patients. This is just a nice infographic showing what are the risk factors to develop coagulopathy and thrombosis in COVID-19, what are the hemostatic abnormalities, and what are the clinical outcomes, that is the organ system affected by this disease. So not surprising, acute illness, bedridden, these are general risk factors for even non-COVID illness related thrombosis, and then sepsis, liver kidney injuries, and if you are high risk for any other high-risk candidate because of any other cardiac or malignancy, which is what we have observed, that our high mortality in COVID-19 is in this patient subgroup. And when the virus gets introduced, it generates a robust inflammatory response, which leads to endothelial dysfunction, and which is clinically characterized as lymphopenia. As we know, it's pretty standard now to routinely monitor these patients for inflammatory markers, their IL-6 level, their CRP level. And in terms of the hemostatic abnormalities, what we believe, all the evidence we have so far, that there is pulmonary microthrombi, also intravascular coagulopathy, myocardial injury, and I will talk a little bit about that shortly, which leads to increased cardiac biomarker. And I think Dr. Law just discussed about that in his myocarditis talk. And then clinically, we also notice these are the markers for associated with these are elevated D-dimer, FDPs, and PT, and lower platelet levels. And clinically, we notice venous thromboembolism, myocardial infarction, and DIC. So this slide, actually, I put this just to go over this to really understand the difference between what we see in our commonly associated DIC conditions like HLH or MAS, which is versus the pulmonary intravascular coagulopathy linked to the COVID-19. The reason to do that is why we should differentiate, because in both the conditions, there is a robust systemic inflammatory response, tremendous amount of cytokine release. So we're trying to just sort of differentiate that how COVID-19 related illness is different from our HLH kind of syndrome. As you can see in the clinical feature, you notice more hepatosplenomegaly in HLH kind of thing, because there is generally some underlying condition there In COVID-19, you do not see that. Lung involvement is significantly higher compared to the DIC-related illnesses. Thrombosis is seen in multi-organ in DIC-related illnesses. In COVID-19, it's mainly lung or the peripheral thrombosis, but it is sort of not very clear as of now. We believe that there may be more, but based on what the evidence we have. As far as the bleeding is concerned, in routine DIC, we see generalized bleeding. If you have a sick patient in ICU, you may have noticed that they have nose bleeding, GI bleeding, and maybe petechia. In COVID-19, we generally see more of intrapulmonary or what you can call alveolar hemorrhage sort of thing. And obviously, we have to consider for any acute infection. In terms of the laboratory parameters, the classical DIC has decreased synthetic function, including fibrinogen and other clotting factor, which raises transaminitis, which is actually not very commonly seen in COVID-19 related illness. Anemia is profound because of consumptive coagulopathy, which is not very classically seen in COVID-19. Thrombocytopenia actually can be seen in both, but it is profound in DIC related illness versus COVID-19. And troponins are, this was, I'm sure this is of more interest to my cardiology friends, that troponin T was more higher related, reported in COVID-19 related illness compared to the DIC. And part of it could be maybe what Dr. Law just mentioned, maybe myocarditis plays some role. Hemophagocytosis is generally not seen in the COVID-19 related illness. Now coming to the coagulation and immunological markers, PT or APTT is significantly higher in DIC. We all are familiar with that, but not so much in COVID-19. Fibrinogen level is normal or increased, but it is decreased in DIC, and FDP is increased in both conditions. CRP, ferritin level, we are familiar with. Ferritin is generally not that high in COVID-19 compared to the DIC. And then cytokines are definitely elevated in both the conditions. So from the very early, there was an interest, and I think the early on, I think this is one of the landmark paper or study which sort of brought everyone's attention towards this coagulopathy or sort of inclination towards the prothrombic condition. And in this study, which was an autopsy series early on in the pandemic, that lungs from patients with COVID-19 showed distinctive vascular features consisting of severe endothelial injury associated with the presence of intracellular virus and disrupted cell membranes. Histological analysis of pulmonary vessels in these patients showed widespread thrombosis with microangiopathy. Alveolar capillary microthrombi was 9 times higher in COVID-19 versus influenza. And the COVID-19 lungs, the amount of new vessel growth was predominantly through a mechanism of intussusceptive angiogenesis was 2.7 times higher from influenza. What they did in this study, they had patients who died with COVID-19, they took their lungs and histopathologically analyzed and compared that with the influenza lungs, and also had controls, which means people died because of non-pulmonary or non-viral illnesses. And starking difference was the pulmonary vasculature thrombosis as reported by the authors. So this sort of got traction in the very beginning, and it got further evaluated. And initially people believed, and early on in the pandemic, we all are familiar, there were so many reports that these patients are more profoundly hypoxemic, but they are not sort of, they're still breathing without the vent, and but progressively they get worse. And so that also sort of clinical and physiological dissociation in the early on in the clinical presentation, when we did not know how this virus is behaving in the clinical arena, sort of led to these hypothesis generating studies. Further on, this is comparing thrombosis in COVID-19 versus influenza. And I have listed some of these studies on the right upper top here. You can see the incidence of VTE in patients with influenza is actually very low. In 119 patients, there were just 4 patients with VTE. In another case series, there were just 7 PEs. In a multi-center observation, they found the association odds ratio of 0.74. So these are just representative some studies, but the idea was that it was not very, so far whatever evidence we have, it doesn't show that it is very significantly associated in influenza. So the question is that, is COVID-19 somehow different, that it predisposes people to develop thrombosis or has some sort of affection to the vasculature to cause thrombosis. Now, other thought is that we have never that investigated influenza illness, because I think this pandemic is a one in lifetime event for all of us. And before that, another pandemic was 100 years ago. And another thought is that it was just not investigated, and influenza doesn't cause that much of mortality and morbidity every year to warrant this much of evaluation or examination. However, that doesn't rule out that there is definitely predisposition to have thrombosis, and it needs to be further evaluated. Now, one interesting study here was there are some investigators who have really looked into association of MI with influenza, and they have postulated different hypotheses for that. And in this study, they found actually odds ratio of around 6 that patients after influenza who had MI, some say there is a local inflammatory response, some say because of the inflammation caused generated by the virus illness leads to the plaque rupture and predisposes these patients to have MI. So myocardial infarction is certainly reported with influenza, so maybe there is some clue, but as far as we know, that COVID-19 has much more association with venous and arterial thromboembolism than influenza. Venous has been more reported, but I guess that's likely because it's been actively looked for in ICU situations. One of the theories here is that, as we know, COVID-19 internalized into the human cells using ACE2 receptors, and these are highly expressed in lung alveolar cells, cardiac myocytes, and vascular endothelium. And that's why we believe that COVID-19 probably causes more thrombosis just because of having overexpressed these receptors in the pulmonary vasculature. And elderly people with comorbidities are at higher risk, but younger people can also develop this. But we do not have any evidence that if these receptors are overexpressed in elderly population to cause more thromboembolic complication. And laboratory abnormalities, we discussed about lymphopenia, elevated LDH, inflammatory markers. IL-6 early on was used as a sort of standard of care. It is still standard of care in COVID-19, but early on it was used to assess the severity, but over the last couple of years, it has been clearly established as a marker for severity of illness, and procoagulant profile, which we do in these patients, like mild thrombocytopenia and increased D-dimer is associated with a higher risk of mechanical ventilation, ICU admissions, or death. Disease severity is variably reported with prolonged PT and INR and thrombin time. This was one very interesting study, and I will discuss this short little bit more detail, that there were in 183 COVID-19 patients, almost 11.5% who died had increased levels of D-dimer and FDP, which was 3.5 to 1.9 times respectively compared to those who didn't die. And PT prolongation was at least 14% higher in those who died. So 71% of those who died, they fulfill the criteria of DIC as established by International Society on Thrombosis and Hemostasis, and compared to only 0.6 who were survivor. So clearly, coagulation abnormality, thrombosis plays a role in the outcome of this illness when people contract this virus. This table, this is basically a pooled analysis from different studies done over the last couple of years, and clearly shows that these coagulation abnormalities really play a role, at least in predicting the outcome. And you can see here, I would like to highlight the D dimer. You can see in severe versus non-severe level between, these are different authors have reported in different studies, 19 point versus 2.1 level. And then you can see ICU versus non-ICU, significant correlation, odds ratio significantly higher in ICU. Patients who survived and who did not survive, there is significant difference there too. In all of these studies, clearly that the outcome is so much strongly related to the D dimer level, which clearly indicates that there may be some role that thrombosis intravascularly throughout the body, venous, arterial, may be playing some role in determining the outcome in these patients. And other abnormalities like platelet count and prothrombin time and troponin also have shown similar trends, but they have been sort of a little bit more variably reported. However, D dimer has been very strongly correlated with this. This is very recently published, I guess last week or last month, just came out. Very interesting study. What they did in this, it's a systematic review and meta-analysis by Dr. Jimenez from Spain. What he did is he pooled all the data from the whatever is the published data to find out what is the exact incidence of venous thromboembolic condition in COVID-19, and also bleeding to get us to understand what is the burden of the disease. And in this pooled analysis, there was a 17% overall in patients where they in the published literature, 17% incidence of VTE. 12.1% of those were DVT, 7% were pulmonary embolism, roughly 8% patients had bleeding incidences reported, not because of anticoagulation, bleeding just because of the disease itself, and 4% for major bleeding. When they did a subgroup meta-analysis, VTE was higher in screening versus clinical diagnosis. And again, that's not surprising that when you are actively screening for a disease, you would have a higher incidence of that, which is what is reflected in this data. And among ICU patients versus on the floor or non-ICU patients, again, in ICU patients, you are more actively looking for the causes if someone is getting hypoxemic, not responding. So they found higher incidence of VTE in those patients. Prospective studies versus retrospective studies, which is very interesting finding, because again, this is very intuitive data, but this clearly shows that if you are looking for VTE, you are going to find it more. And that actually really reflects about this illness, that we are probably just not looking for it, and we probably have a higher burden of this disease in these patients. And highest pooled incidence estimate of bleeding was reported for patients receiving intermediate or full dose anticoagulation. Now, this is a subgroup analysis for those who were receiving anticoagulation, and they found more bleeding incidence. And but the lowest in only the prospective study that assessed bleeding events, which was 2.7%. Now, for acute coronary, moving on to the acute coronary syndrome, elevated troponins have been associated with poor outcomes in COVID-19. And I'm going to go back to this slide here. So in the bottom here, we didn't talk much about here, but you can clearly see that ICU illness and non-ICU illness and dead or alive and ICU and non-ICU and severe and non-severe, clearly the troponin levels had correlated with the poor outcome. And that's what has been validated in different studies that they've been associated with the bad outcome in patients. And I think Dr. Law just mentioned about that. But like he mentioned, the elevated troponin in COVID-19 doesn't really mean that the patient has obstructive coronary disease or something like that, but it could be as simple as a non-specific myocardial injury. Some patients may have impaired renal function, myocarditis, PEs can cause. There could be type 1 and type 2 MIs. Elevation of BNP is also non-specific, and consideration for thrombotic event should only be raised in appropriate clinical context, like if you have a patient who has unexplained hypoxemia or which is not responding, or the CT just doesn't look like that there is significant pneumonia or alveolar opacities, but patient is disproportionately hypoxemic, you should consider looking for it. But if you see in the absence of all other conditions, the troponin levels are not very highly reported, but whenever they are highly reported, that's associated with the poor prognosis. And severe elevation is seen in roughly around 8 to 10% of COVID-19 patients. Anecdotal cases of patients with COVID-19 presenting with ACS due to plaque rupture have been described, which we call as type 1 MI. I discussed this earlier about influenza and ACS. This has been reported. It could be because of localized plaque inflammation or systemic inflammatory response. If a COVID-19 patient gets ACS, the current recommendation is dual antiplatelet therapy and full dose anticoagulation as recommended by ACC, and I'm sure you all are very familiar with this. In patients with bleeding risk, regimens with less potent antiplatelet agents such as clopidogrel should be considered. In STEMI, PCI is preferred, but obviously the risk of COVID spread should be considered. And individual institutional protocol should be followed, which I'm sure you all have been doing for the last couple of years. And one important area I would like to highlight this last point here about drug and drug interaction, because as you know, drugs like clopidogrel, they are cytochrome P450 metabolized through this CYP450, and many of the COVID investigational drugs are metabolized through the same pathway. So spatial attention should be paid to their interaction, because this can increase the bleeding risk in your patient. And this is just a table showing the possible interaction for some of these experimental therapies which have been either approved or being used in clinical care for COVID-19 patient. I don't think we are using, this was a little early in the pandemic, but I don't think we are using, at least in the United States now, lopinavir or ritonavir, because the trial didn't show any benefit. Remdesivir is still used, but I do not see any major interaction where you need to consider any dose reduction or dose adjustment with any of the antiplatelets therapies. Similarly, tocilizumab is used routinely in COVID-19, but there is a caution, but no change in dose recommendation is suggested, and serilimab also is being used, but it is more an experimental right now. But again, no dose recommendation. But this is just to highlight that we should be paying attention to what medication or treatment we are giving for COVID-19, and it may interact with the treatment for ACS. Now, this is just a risk stratification, and I'm sure you all are very familiar with this. And if you have the sort of each patient, when we are seeing them, we should divide them into high risk for ACS or VTE, or low risk for COVID versus high risk for COVID and low risk for ACS or VTE. And based on that, we triage their therapies. Now, I would like to discuss a little bit about high risk for COVID-19 and high risk for ACS or VTE, a goal-directed medical therapy as per the ACS algorithm. I'm sure you all have institutionalized protocols for COVID-19 patients. The stress is based on the data. The stress is that we should be considering these patients for PCI if they have something like STEMI, but considering the COVID-19, and if this cannot be done safely, we do not want it to be spreading to the healthcare providers. Fibrinolytic therapy can be considered. And obviously supporting these patients with the hemodynamic support or whatever they need. Anticoagulation is recommended. Catheter-directed or surgical therapies, in case they are not suitable for systemic fibrinolysis, consider need and safety of hemodynamic and supporting monitoring. So these are just standard recommendations from ACC and other European college. How do we approach these patients? But again, these can be tailor-made to the individual institute based on the resources and the safety of the healthcare providers. Now, moving on to the management of these conditions, and because from the very beginning, this was a big question. There were two big questions: whether we should anticoagulate these patients, and if the answer is yes, then what dose? And that was something, this has gone, I can tell you, back and forth many times, because many trials showing different kind of results and findings, and sort of was very confusing whether we should do full anticoagulation, therapeutic dose, or a standard. But I'm going to talk in 2 slides, 2 different major trials. Literally, I think this came out last week, I guess so, and the other one in NEJM we're waiting for almost whole year, came out 2 weeks ago, I think, and both the trials showed some promising results here. So in this study, the study was basically efficacy and safety of therapeutic dose heparin versus standard prophylactic or intermediate dose heparin for thromboprophylaxis in high-risk hospitalized patient. So 124 patients in standard dose, 129 patients in therapeutic dose. Primary efficacy outcome was venous or arterial thrombotic events or death. And there were 52 events in the standard dose heparin versus 37 in the therapeutic dose low molecular weight heparin, clearly indicating that the therapeutic dose heparin is superior to the standard dose, including a reduction in the thromboembolic events from 29% to 10% in the therapeutic dose, which was statistically significantly higher. Bleeding incidences were slightly more, 4.7 versus 1.6, but they were not statistically higher. This primary efficacy point was met in the non-ICU patient, but not in the ICU patient. So I think 2 things to learn: definitely that the therapeutic range heparin or anticoagulation is helpful, and probably we should consider that early on when the patients are not very sick, and especially when they're in ICU, they did not observe significant difference. Now, this was the Act 4. We've been, I guess, probably whole year, we've been waiting for this trial. It was an adaptive, very nice study design, open label, and pooled like 2,000 patient, multi-center study, and just got published in NEJM. And it was adaptive, controlled trial, randomized. It was in non-critically ill patient to receive either therapeutic dose heparin or usual case dose, which is the standard dose they were talking about. Their endpoint was organ support 3 days. That means patients not needing any ventilatory support or something like that. And number of free days from cardiovascular or respiratory organ support up to 21 days. The good thing is this trial was actually prematurely stopped because it just showed so much benefit that they did not feel the need to complete the whole duration. And because it met the superiority criteria of therapeutic dose anticoagulation. 2,219 patients with therapeutic dose heparin increased organ support free days as compared to the usual care. As you can see, 98%, and it met the odds.
Sandeep?
Yes.
You know, this is a great topic and a great review, but we might have to wrap it up in the next few minutes.
Oh, I'm sorry. I'm actually on the last slide, last few slides.
Sorry, thank you.
Oh, sorry.
Oh, you can finish up. Yes.
Yeah. So thank you for the reminder. So So this basically showed superiority of the heparin clearly in non-critically ill COVID-19 patients. These are just quickly additional consideration in DIC patients, and that the laboratory monitoring with platelets, BT-D dimer, and fibrinogen should be continued. Low molecular weight heparin prophylaxis is now recommended, and I think with the new data, we have even more evidence favoring that. Here, I would like to mention a little bit about in patients who have ACI or high risk patients because of the dual antiplatelet therapy. If they had PCI, it is reasonable to continue dual antiplatelet therapy if platelet count is more than 50, single platelet antiplatelet if between 25 to 50, and discontinue if it is less than 25. This is based on the current European and ACC recommendations. Management of bleeding should be as per your standard of care. In future, we obviously there are studies going on in outpatient settings if they need to do VT prophylaxis. Now we clearly know in non-critically ill, therapeutic dose heparin can help in preventing the thrombotic events. However, we do not know anything about in the sick patient population. The studies are ongoing. Low molecular weight is preferable. We do not know anything about DOACs patient, DOAC medication, so studies should further be investigating into that. And with that, I will end, and I'm sorry to take a little bit extra time.
All right. Sandeep, thank you for your excellent and detailed talk. We're going to move along to our next talker, which is Dr. Christine Yumul. Christine is a clinical assistant professor of cardiology here at the University of Iowa. She previously completed her residency in internal medicine and at the Johns Hopkins University Sinai Hospital in Baltimore. She subsequently completed her fellowship in cardiology at the University of Arizona, and more recently completed an advanced heart failure and cardiac transplant fellowship at the University of California, San Diego. Her clinical interests are heart transplant and LVAD, and she's passionate in teaching our fellows in this field. She will be speaking to us for COVID and cardiomyopathy. Christine, please go ahead.
All right, thanks, George. Let me just share my slides. All right, just kind of warn everybody, it's my son's second birthday today, so if you hear somebody yelling at the background, that's my little boy. All right, so I had broken down my talk into 4 different parts, just and I've also deleted a lot of slides, so I think if some of them doesn't seem, like you needed more information, please let me know. And then the other thing that I want to say is that, since about the pandemic started, so at least 3 important papers came out, so ISHLT on February of this year, led by Dr. Saima Aslam, who was one of my mentors when I was in San Diego, shared the paper for COVID-19 and for people with advanced lung and heart disease. And then a paper came out defining the having a new definition for heart failure, at least did not acknowledge COVID. And then the heart failure guidelines were written in 2013. There has been no update except for a consensus pathway paper that was published early this year. And again, I think just because we're trying to get more information, at least COVID-19 has not been mentioned in those 2 papers. All right, so I think Mahi definitely selected the topics great, and the speakers great, because as you can see, I think, the slides might be a little bit blurry, but I think at least each one of the potential cardiovascular syndromes associated with COVID-19, and we've had or will be having a speaker for this, are illustrated in this slide. So the first question that I want to ask and answer is that, in heart failure and cardiomyopathy, what is the mechanism of action as to how people have heart failure after COVID-19 infection? So the 3 pathways that I'm going to mention here is a result of several papers that I've seen. So the first one is what we call the pathway 1, which is as a result of the cytokine storm. So what happens is that there's a surge of pro-inflammatory markers that essentially leads to myocardial injury. And in conjunction with that, which is related to pathway 3, is that multi-organ dysfunction can happen. And as you can see, each of the organs on the right side of the slide basically are showing some laboratory findings showing that the organ has been affected. And then for the second potential pathway for COVID, really when I was, when I was preparing for a similar talk early this year, I found myself having a lot of questions unanswered during the first part of the year, as opposed to when I prepared for this talk. But the question when I prepared for this talk on January was that, is the heart directly affected by COVID-19? So this was actually an early paper in cardiovascular research, which basically what they said was that they wanted to address if the if the COVID-19 infects heart tissue by using living human cardiac tissue slices, which they obtained from explanted hearts. So as you can see on the right side, what they see is that there was a spike protein expression shown from the different samples derived from the 3 explants. And then with infection, what they see is that there's morphologic signs of tissue injury, such as loss of the sarcomeric actinic signal, and the structures seem to be more disorganized. And another topic of interest for the heart failure world is, and actually I remember that a very brief statement about ACE inhibitors and ARBs were put out by the ACC and AHA because of the concern for the ACE2 receptor, for which we know mediates the process of infection and transmission, of the COVID-19 virus. So, and I have a slide about that, but that was one of the early statements that the association of by the ACC that they released, early last year. And then the third pathway that we're thinking of, aside from the cytokine storm, aside from a direct infection of the direct mechanism for the heart, is actually in the setting of the primary organ that really is involved initially with COVID, which is the respiratory damage. And the algorithm that we're thinking of is that there's hypoxia, and then there's supply-demand mismatch. And because of the oxidative stress, then consequently, then there's damage to cardiomyocytes. So those are, at least for the most part, these papers are saying that one might predominate over the other, but it is also likely that these 3 pathways can actually affect a normal heart. All right, so I think this slide is just mostly to summarize what I've said in terms of the different pathway, and eventually they can lead to myocardial injury, resulting into heart failure. All right, so this slide is actually taken from the paper Redefining Heart Failure. We thought we all knew how to define heart failure, but they came up with this, and I'm highlighting this slide because in most of the papers defining, as Dr. Law had said in his slides, what is myocarditis? So even so, in most of these papers, they actually say, what is heart failure in the setting of COVID-19? So they, for the most part, most of the case reports, case series, and one systematic review that I've seen, they basically obviously said that there should be signs and symptoms of heart failure, and then they should be corroborated, which obviously I think we have all seen, by elevated biomarkers, and there has to be evidence, or there has to be evidence of volume overload in the setting of heart failure. So this is the new definition. I mean, I think for the most part in practice, I think we think about this, but late last year, 14 people from 14 countries actually sat together and basically wrote this paper to ensure that we have a universal definition of heart failure, which I saw was applied when people were defining what is cardiomyopathy in the setting of COVID-19. All right, so moving on to signs and symptoms. So looking at this, I do not think that I can pick out a specific symptom that will say that, yes, this is COVID-19. I mean, these are symptoms that I basically see in my patients every day, be it inpatient. I was just coming off inpatient yesterday, or in the outpatient clinic. So I think for the most part, these are signs and symptoms that are, very common to us, but obviously it's perhaps an exposure and a positive exam that will make you think more, especially for somebody who truly never had heart failure before. So the interesting thing that I want to point out is that now they're calling this more severe syndrome. So as you can see here, I think this was initially thought about in kids in April of last year, is that there's an overlap with the Kawasaki disease and multisystem inflammatory syndrome in children. So now what they're thinking about in adults is actually they started calling that multisystem inflammatory syndrome /A in adults. And just to kind of go back to what's going on with the kids. So as we know, for the most part, the common presentation of COVID-19 is severe infection for the most part initially, with severe acute respiratory syndrome that truly just evolves from like a viral pneumonia to an inflammatory mediated acute respiratory distress syndrome. So I think even so, even after some papers were written, so for the most part, this multi-system involvement and even the acute COVID-19 cardiovascular syndromes, are definitely, I would say, less common than the respiratory presentation. So for kids, how they define this syndrome is that they present with elevated troponins. Some kids present in cardiogenic shock, biventricular failure, but such cardiac complications are probably not very common in Kawasaki disease. And then many children actually have no history of a symptomatic respiratory infection. And some of them may even test negative for, by PCR, but have developed some antibodies, which should make us think that maybe the initial infection happened even before, the development of this syndrome. So hence, we have seen some people that they were fine for a period of time, and then they ended up coming very sick in the hospital with an antecedent infection, they did not positive the day before, like they were positive or had symptoms maybe a couple of weeks before. So the thought process of this and why we're thinking about this is because, and I have a slide on this in the prognosis aspect, is that really long term, I think, maybe 2 years is not enough for us to figure out if what's really the eventual effect of this in people with heart failure. But we are worried that this post-infectious inflammatory state can truly, overburden the heart failure world in managing these patients in the future. So, but this MIS-A adults, they come in very, very sick. And then, so I just quickly went through the signs and symptoms because I like what I said. Clearly, cardiogenic shock is different and a separate topic, but I think, in terms of signs and symptoms, I don't think they present any different than any of our heart failure patients. In terms of diagnostic, I read a quote before that says, muddy waters stand clear, muddy waters let stand becomes clear. So I chose this picture because what happens is that when they were trying to figure out, and I think again, Dr. Law had a similar slide to this, is that people, at least in the heart failure world, really don't know, do we redefine what's the cutoff for the biomarkers in the setting of COVID-19. And I think we wanted to see if we should do that because they are prognostic and we can say, is my patient going to get better, or, it affects their survival curve. So what happens is that I think initially in the excitement and the uncertainty surrounding COVID-19 and cardiac biomarkers, I think we must remember, especially in the concept of the cytokine storm, that the inflammatory environment is very heightened. Multiple organs are injured and critical illness is often present. So because of this, the waters are muddy. However, I think with the understanding of the caveats mentioned above, meaning the increased cytokines and then the organs, multiple organs are injured, critical illness is present, then together with our clinical judgment, I think the interpretation of the cardiac biomarkers will often become clear. So I kind of associated that quote with this because really you just cannot think about these numbers as numbers per se. There's truly a lot of things that has to be considered when making an interpretation of these numbers. So here, I'm not gonna belabor the slide, but basically it's just to further demonstrate the mechanistic cause of cardiac injury in COVID-19 patients. And as you guys can see, there's a significant difference in people with heart injury, without heart injury, and what their outcome's gonna be. So it is very interesting though that outcomes from COVID-19, a disease like what I said has been associated primarily with the lungs, are also very well predicted by cardiac biomarkers. So one of the things that they said, actually, especially in this recently published systematic review, is that which was honestly limited by the fact that when they eventually narrowed down their studies, it was a bunch of case reports and case series, is that the most common comorbidity from the cardiac perspective is hypertension. Hypertension, like heart failure, is an inflammatory state. You might have heard of the word cardiac cachexia. People lose weight without them doing anything just because of the inflammatory nature of heart failure. So what they said is that people with hypertension, be it as benign because it's very common, is actually very inflammatory and can make heart failure worse. So the other thing, and I think here below, what I'm just saying is a sort of a reiteration of the different biomarkers and how they're elevated in people with COVID-19. And then here, I'm not gonna belabor this again, but I think I ended up choosing this because I tried to see if there were more recent studies that were published after I had to do like a very similar presentation about 10 months ago. And this is one of the things that I've found. So for the most part, again, what I skipped in this part of the diagnostics is actually the MRI, which I'm glad Dr. Logan, he highlighted a lot of key points for that. And then the other thing that I did not mention here, but I would briefly like to talk about, is actually the utility of endomyocardial biopsy. So I think for the most part, there was a paper that actually said, when do you perform an endomyocardial biopsy and when do you perform that together with the MRI? But in our clinical practice guidelines that were published about 14 years ago, and we have done, I can count them in my one hand, people who presented with cardiogenic shock in our CV-ICU and endomyocardial biopsy, just because the feel of doing a biopsy on a native heart is definitely very, very different from a stiff transplanted heart. So I think all of our interventional staff and our heart failure people, we better have a good reason, just because you want to justify the potential risk of perforation with the answer that you can get to save somebody's life. But the really endomyocardial biopsy is indicated if in 2 weeks you don't have a diagnosis, or if and then the patient is getting worse, or in 2 to 3 weeks, you may potentially you don't still have a diagnosis in spite of treatment, and then now you're seeing things such as heart block. And then it becomes a little bit more muddy if you have somebody presenting with new heart failure after 3 months. But again, I think for the most part, the people that we have seen in the hospital, they presented within less than 2 weeks, very sick people, ended up opening an evaluation for advanced cardiac therapies, ended up getting a cardiac endomyocardial biopsy in the cath lab. All right, so I think I've got 75% of my slides done. But this slide is just to say that in the end, how it affects people with heart failure doesn't really matter, whatever your EF is. In our world, if you're a reduced ejection fraction, EF is less than 25, is less than 35%, and then the mid-range will be from 40 to 50. This was again redefined by the same paper, and then preserve would be something about more than 50. So basically, this slide was just saying, sure, the EF truly does not matter, but I think what significantly matters more is the comorbidities of the patient. And I think for the most part, I think with all honesty, and even in our practice, I think people with preserved ejection fraction are much more difficult to treat, because unlike people with reduced ejection fraction, we basically do not have guidelines for that, in terms of like a checkbox that I can put my patients on. It's basically treat their comorbidities and you can manage their heart failure, which is definitely harder than just putting them on meds. All right. So I'll just quickly go through, I'm not gonna give specific ideas about management, but what I'm just gonna say is that this is the most recent, again, in this systematic review, this is what they said, that for the most part, people have found, in treating patients. I'm not gonna comment about this because I think for the most part, even in our practice, when we get these patients in the hospital, we are more there for deciding if they need advanced cardiac therapies or not, and also to put them on guideline-directed medical therapy. At the end of the day, for the most part, what we do is we put them in guideline-directed medical therapy. I did not include this slide yet, but there was a paper published in December that basically now what they say is you actually start your guideline-directed medical therapy, not just with an ACE, ARB, but an RD is actually preferred in Entresto, but you can start the patient on an SGLT2 inhibitor. All right, and again, this is just a quick slide to say that like what I said, because of all the confusion, some doctors taking their patients off this class of drugs. So the Heart Failure Society of America, ACC, and AHA basically said you should continue the RAS antagonist for your patients who were prescribed those agents for indications that these agents are known to be beneficial. So I remember after sort of the lockdown, this paper came about in about 5 years because there was so much confusion of people being taken off it, such as heart failure, hypertension, or even ischemic heart disease. And you only make an individualized decision based on their hemodynamic status and presentation. So I think winding down to the last slides of my presentation. So I'm just going to say, so this is the guidelines that was published for our use. I believe the most recent update that I've seen was on February of this year. So it guides us basically on what to do with our patients who are listed if they are exposed, they get COVID and they have symptoms, or if they have COVID-19 and they do not have symptoms, when do we reactivate them on the list? And also for the most part, it tells us when can you accept a donor, if they've had COVID-19. I'm just going to tell you guys that we have never accepted a donor, honestly, with a recent COVID-19 infection. What happens when we get when we are on donor call is that our program can essentially say, we're not going to get donors like this. So let's say we're not going to get donors about 45 years old. So basically what we just say is that we're not going to get donors which had a recent infection with COVID. But like what I said, so for the most part, for our patients, they become downgraded for about 21 to 28 days if they have symptoms and COVID-19. And then if they're asymptomatic, it can be as short as 14 days. What's a hot topic right now that I just got an email on is that, will we require the vaccination, before listing people? And that's something that I'm not even going to talk about, but something that is definitely being talked about in our group. All right. So lastly, I think the way that we should think about these patients, just so we try to do something for them, is that, when people are stable, instead of saying that they're stable, we call them, and this applies to people with COVID because not all of them get worse. Some of them are stable with whatever EF they have. They may or may not have symptoms in therapy. But the reason why they said that you should call them in remission, because if you call them stable, you're just going to write stable in your note. But remember, each of them still has a risk for hospitalization or sudden cardiac death. And then refractory are people who are worsening. Please let us know about them. They're declining despite escalation of therapy. They might need palliation. They benefit more from that if they are involved early, or advanced therapies such as an LVAD or a transplant. All I'm going to say is that right now, if somebody has cardiogenic shock in the setting of COVID-19, at least in our program, we will not transplant them. So what's going to happen is that they will most likely get an appropriate mechanical circulatory support or an inotrope if their rhythm allows that, as a bridge to recovery, and not even as a bridge, not even as a bridge to decision, meaning will they be transplanted or not, and definitely not as a bridge for cardiac transplant. And then eventually, we do have people, and I have seen as young kids recovered after COVID-19 with resolution of symptoms and normalization of LVEF. This is one of my favorite trials, TRIDE-HF, published in 2018 in The Lancet, basically saying continue your guideline-directed medical therapy even after your EF has recovered so that the patients will remain stable. And lastly, just a slide that I'm going to share. that, these are just still some of the things that even in our end, we don't know what's going to happen to patient, but we foresee that because of the prolonged side effect of this inflammatory course, potentially we will see more patients with COVID-19 cardiomyopathy in the future. And with that, I thank Mahi for the invite. And then like what I said, happy to take any questions later on. Thank you.
Thank you so much, Dr. Umel, and very grateful for all the speakers we've had so far. To continue with our theme here, I'm going to introduce Dr. Brian Olshansky. He's Professor Emeritus at he is at the University of Iowa and adjunct professor at Des Moines University. He's triple board certified clinical electrophysiologist and practiced here in the VA in Iowa City, Covenant Hospital, Waterloo, CGH Medical Center, Sterling, Illinois. Prior to this, he was tenured professor of medicine at the University of Iowa as an electrophysiologist from 2000 to 2012. He served as director of the electrophysiology program and fellowship training program for 7 years. He has written 4 books, numerous chapters, over 340 peer-reviewed manuscripts, many non-peer-reviewed manuscripts, and been involved with numerous clinical trials over the years. His area of interest include autonomic dysfunction, atrial arrhythmias, cardiovascular conditions in athletes, syncope, ventricular arrhythmias, ablation, and arrhythmia device therapy. He has a background in complementary and alternative medicine, but nevertheless, he considers himself a simple country electrophysiologist who only wants the best for his patients. He's on 12 editorial boards and the editor for ventricular tachycardia section of VSC Cardiomed. He has been an editor for Up to Date since 1992. He's a widely recognized international expert in clinical cardiac electrophysiology.
Good morning. For some reason, I'm having a hard time sharing the screen since I think, first of all, I thank you very much, Katie, for that wonderful introduction. I cannot share my screen because the other presentation is still on, so.
Dr. Umel, can you hit stop share, please?
Christine?
Okay, hold on for a second, too, sorry.
Yeah. No worries, thank you. Brian, I think.
Okay.
Done.
Okay, I think I can. So let me just start off by saying that I think we know very little about this topic of COVID, no matter the fact that there are thousands and thousands of publications and a variety of different pieces of evidence. But the issue of arrhythmias and COVID, I think, is a substantial one, and I'd like to discuss it in the next few minutes. Here are my disclosures. And I want to start with one of the cases I saw this week. I saw a couple, and each one has its own implications, but I thought this one in particular raised quite a few questions. This is a woman who about a year ago developed COVID, and then about a month later started getting palpitations, dizziness, lightheadedness, and near syncope, and she's had that ever since she had COVID. And this is what the rhythm disturbance was that she had, certainly a very concerning one. And one that never occurred before COVID. So questions arise from this. Is COVID responsible, or would this have happened anyway? And this question arises because many patients that have arrhythmias now may develop arrhythmias due to subacute COVID, due to occult COVID. It's not necessarily manifest COVID. We don't even know what the effect of the vaccine is on improving or worsening the risk, whether or not cardiomyopathy, myocarditis occurs. So we don't really know if COVID caused or exacerbated her problem. We don't know what the prognostic significance of this arrhythmia is, or any arrhythmia. And we don't know anything about long-term treatment for these arrhythmias or for the COVID problem itself. So there were many different analyses, I could have gone through about 10 different databases looking at the risk of arrhythmias and COVID. And this is just one international registry showing the relationship between atrial fibrillation, SVT, non-sustained VT, et cetera, bradycardia, VF, and COVID in patients who are hospitalized. And as you can see, hospitalized patients frequently had some type of an arrhythmia that occurred at the time of the hospitalization. Now, why the patients were hospitalized, unclear. Whether they're hospitalized because of syncope, because of atrial fib, and were then found to have COVID is also unclear. But what is also known is that patients that have this problem tend to have underlying comorbidities that are significant. So they're at risk anyway. I mean, they've either had AFib before, they've had hypertension, diabetes, congestive heart failure, coronary disease. And so there's some interplay between all of these conditions and the presence of COVID. And as you can see here, when looking at the presence of atrial fibrillation, you can see that there's a relationship in terms of acute survival between those patients that have atrial fibrillation and those that don't. And as you may expect, those who have more comorbidities that have atrial fibrillation, those patients who do, are at greater risk for at least an acute mortality risk, whether it be in hospital or early following the hospitalization, whether the episodes are recent, new onset atrial fibrillation, or a history of atrial fibrillation that occurred at the time of the hospitalization. But when doing a multivariate analysis and looking at the risk of atrial fibrillation, there does appear to be the case, and again, publications vary, but it does appear that there is an independent effect of atrial fibrillation on risk of total mortality in patients that have had obvious apparent COVID. Now, you've heard something about other viral conditions and risk, but here I just want to point out that there's a study that looked at the risk of mortality in patients who have atrial fibrillation or not, and have influenza or not. This is a post hoc analysis versus COVID. And as you can see here, those patients who had COVID and atrial fibrillation are at greater risk than those who don't, and are at greater risk than those who have influenza. So something unique is going on here. It could be the severity of the illness. It could be something specific related to COVID. It could be that patients who have atrial fibrillation are at greater risk for thromboemboli and thrombosis, as you've already heard about. And perhaps that's the mechanism, but it's not clear what that mechanism may actually be. And so this is true for new AFib as well. So it's not just all AFib who presents with AFib, but also patients who never had AFib before and then come in with AFib and COVID. So there's something unique here and concerning because the mortality is way higher. Now, this of course does not mean that treatment of the atrial fibrillation will change the outcome, but it just means that we have a red flag here, a risk marker for bad outcomes in patients with COVID. Now, what could be going on behind this? Well, it may be related to inflammation. And here are just some of the markers that we tend to measure in patients that have had COVID. Troponin CRP. Recently, I just saw a patient this week who had a D-dimer. I've never seen a D-dimer as high as this, and had thrombosis and pulmonary emboli, and had atrial fibrillation. So again, this may be an acute precipitation of atrial fibrillation due to all other kinds of explanatory causes, whether it be hypoxia, thromboemboli, pulmonary embolus, etc. But the inflammatory markers are higher in those patients who have atrial fibrillation. And as you may expect, the survival is also going to be less in patients who have had atrial fibrillation and flutter, whether it be newly detected or have had chronic problems that are exacerbated at the time of COVID. But again, these patients have greater inflammatory markers than those patients who do not have atrial fibrillation. Similarly, data has been accumulated looking at interleukin, a variety of different ones, 2, 4, 6, and 10. And as you can see here, the incidence of the arrhythmias that occur, and this is all arrhythmias, is related to these inflammatory markers. So cytokines are very much important in terms of the precipitation of these arrhythmias. Again, we don't know what the long term of this is going to be, and we don't know if the atrial fib is going to go away. We don't know if the arrhythmias that we see are going to go away, or things are going to continue on and on and on. And as you can see here also, there's a difference between these interleukins and the type of arrhythmia. So conduction block seems to be related to different interleukins than, for example, ventricular arrhythmias or atrial fibrillation. So maybe there's something we can learn about this and better understand and predict what the future is going to be for these individuals. So you can see here, those patients that have arrhythmias, again, are going to be at greater risk than those who don't, and this is related to the inflammatory markers. A couple of the things about arrhythmias. Again, this is on the more broad picture that we have to consider. And that is that there's a relationship between those that have seroconversion of SARS-CoV-2 antibody tests and the risk of out-of-hospital sudden cardiac death. And sudden cardiac death, of course, is an arrhythmia. And of course, ventricular fibrillation is one of the possibilities that can occur related to COVID. And so perhaps one of the issues is that COVID increases the risk of sudden cardiac death. And of course, maybe it also increases the risk of cardiac death for the same reason. if you take a look at some of the data, here are some data from New York City, and you can see the relationship. Of course, New York City had a very high incidence for a period of time of COVID infections, and the relationship between infections and the risk of sudden cardiac death skyrocketed. And of course, now we're in a time when we're going to be seeing more sudden cardiac deaths and more cardiac deaths. And whether this is directly related to COVID or indirectly related to COVID needs further evaluation, but certainly there is a relationship. As you can see here, looking at the deaths per 100,000, comparing 2019 to 2020, the risk of death from ischemic heart disease actually skyrocketed at the time of COVID. And this didn't include necessarily heart failure deaths, but hypertensive deaths were increased, but total ischemic deaths were increased. And the reason for this, again, is not completely clear. But if you look at the New York City population, it just totally went up a huge amount at the time of the COVID infections. And so this mortality during the first wave of COVID, in part, is related to the risk of cardiovascular mortality, but importantly, to the risk of out-of-hospital sudden cardiac deaths, or potentially ventricular fibrillation that could be due, if not directly to COVID, in some way due to COVID. And this increase is quite substantial compared to what was seen in terms of the sudden cardiac death rate the year before. One of the reasons could be we're just doing less procedures on patients, or that we're not seeing the patients as carefully. We're not managing their problems as well. That is certainly a possibility.
I just got on. Okay, don't keep running around. Just stay up there.
Okay, so I'm going to continue, and that is that the number of cardiac procedures performed has plummeted, at least in some places. And therefore, perhaps one of the things is we're not able to care for our patients as well. That's one possibility. Another possibility is actually the COVID itself. My suspicion is it's actually a combination of different issues that are going on here in our patients. And therefore, the cardiac mortality is going up. And a lot of this is due to sudden cardiac death. And a lot of this is due to ventricular fibrillation. As you can see here from these data, the amount of hospital cardiac arrest has gone up during the time of COVID. And that actually the CPR time has changed. The bystander CPR, it's not surprising, has gone down, and that the response time to cardiac arrest has gone up. Perhaps this is part of it too. So we have to think about all of the issues that are going on in this time of COVID that could be increasing the risk of out-of-hospital sudden death, and how much of this is due to ventricular fibrillation, and how much of it's due to COVID itself, or even subacute COVID, or even COVID that isn't diagnosed as COVID, or even what is the relationship between vaccines and how much benefit do we get from vaccines? All of this stuff needs to be further evaluated and has not been carefully assessed at this point. But what can be said is that there is now excess cardiovascular deaths, and a lot of these deaths are due to out-of-hospital cardiac arrest. Some of these are indirect, and some of these are direct, but we have to pay careful attention to the fact that we're having increased risk of death that's not directly due to COVID, but it's due to cardiovascular disease and due to out-of-hospital cardiac arrest. And it could be looked at specific populations that need to be more carefully evaluated than has been at this point. I want to point out one more thing before I end my talk, and that relates to other issues, and you've heard a little about this in terms of arrhythmias and autonomic issues. And that is something we reported on was on post-COVID, or the so-called long-haul COVID POTS. And this is just a woman that we presented about a year ago, actually a little bit less, who had an example of this. And we've seen this, of course, many, many times in patients that have now this post-COVID or long-haul POTS. That presents, as you can see here, with an increase in heart rate. Actually, this is during the tilt, and this is with active standing, seeing a marked increase in heart rate. And this brings up a whole nother discussion about, what's happening with the autonomic dysfunction that's occurring during COVID. So let me just finish by saying that during COVID, many things are happening. Of course, we're having changes in the inflammatory response, hypercoagulable state, autonomic changes. We're having, just the anxiety and the psychiatric issues that are going on because of COVID. We're having increases in stress, effects on the patients not being seen as carefully, being evaluated as carefully. And we're seeing some myocardial injuries, some of which can be measured and some of which can't be when it comes to the atrial arrhythmias. And therefore, this, as well as everything else, hypoxia, the hypercoagulable state, can lead to a variety of tachyarrhythmias, bradyarrhythmias, and then again, some of the drugs actually increase QT, which could also lead to potentially Torsades. And then there's the problem of sudden cardiac death that we need to better understand in this time of COVID. So I just want to conclude by saying that COVID is associated with serious and life-threatening arrhythmias, and that the risk of sudden and cardiac death is actually growing, and perhaps due to arrhythmias caused in some way by COVID, but that the reasons for and the long-term implications of arrhythmias due to COVID are uncertain. And therefore, I think, ladies and gentlemen, we live in a brave new world. Thank you very much.
Thank you, Dr. Olshansky. That was excellent overview of our arrhythmias with COVID. And these are all great talks, and we appreciate the speakers. We are going to do a few questions here with our panelists we've met so far, and we'll return to our fifth after our keynote speaker, Dr. Dekema. First, I'll start with kind of a question for Dr. Sahay. Could you please comment on DVT-PE noted many months after COVID, and any concern for thromboembolic complications related to COVID vaccine?
Thanks for your question. For the COVID, let me take the second part of your question. The COVID vaccine risk is currently not well known, or I should say published so far. I mean, we know there are some initial reports from the J&J vaccine have been reported, but those incidences are very low. So currently nothing is sort of recommended that if you're getting vaccinated, you need to go on to thromboprophylaxis or anything. It's been very minimum. And for the other vaccines, it's not been widely reported. So overall incidence is very low, which makes it pretty safe. And right now, really nothing that we can sort of recommend. What was your first part of the question about?
Yeah, so Dr. Corrine had asked if we see DVT-PE many months after COVID.
So, yeah, could it be because of COVID? Is that the question? Okay. Very hard to say. And it goes actually both ways. And many times we think that when we see that patient with COVID, let's say mild illness, and we find DVT and PE in them. Now, it's very hard to say that, well, mildly elevated inflammatory markers, now this is provoked by COVID, or is that being just like that this patient had predisposition and had that event. The management of something found 3 months later is purely as per your incident PE or DVT, like 3 to 6 months anticoagulation. There is no strong data right now to suggest that there is a correlation with the prior incidence of COVID, especially when the acute inflammatory phase is over. So if someone is 3 months, 6 months out of COVID, I would assume their inflammatory phase is over. There is no elevation of CRP, IL-6, those kind of things. And D-dimer may be elevated because now they have an acute PE or DVT, but very unlikely for it to be related to the COVID illness, unless there is some other specific. So really not known in the long haulers as of now that the new event of PE DVT is related to that.
Great, thank you for clarifying that. And I think Dr. Christodoulides has a question as well.
Okay, so I have a question towards Ryan, and maybe Ian can also add to this question, mostly to our EP colleagues, I guess. So we see a lot of these post-COVID dysautonomia / POTS, and it's pretty difficult to manage. I mean, right now I have quite a bit of patients in this area. I've been trying, the usual lifestyle modifications, increased fluid, salts, maybe some isometric exercise, maybe some compression stockings. In regard to medications, I have tried low dose propranolol with some success. I have thought of ivabradi, but I haven't, and I just wanted your opinion. Have any other suggestions, any other ideas?
Brian, I'm going to let you address this first if you're still on the line there.
Okay, thanks, Ian, and thanks, George. This is a really tremendously important problem, and we don't have good answers. I think you're trying the right things, and this becomes more of a trial and error since there are very little in the way of good data on this. We don't know what the long term is going to be. We don't know how much of this is vagal and how much of this is really sympathetic. We don't know how much of this is, a venous pooling or some other problem. I think only time is going to tell, but I think, non-pharmacologic approaches with exercise, especially supine exercises, fluid, low-dose propranolol and ivapritine are a reasonable first choice. We don't have a magic potion at this point, and it's going to be very difficult to know until we get some better studies to evaluate this problem.
And I'll just add that I think the difference between what the population that Brian's seeing, that I'm seeing, is I'm dealing with a highly motivated, competitive athlete. And, the last thing you want to do is put them on a beta blocker. Whereas, exercise, water, and salt, they're doing many of those things, although many can drink more water and salt on top of their basic intake. But I've actually had some luck with even just putting them on midodrine to give them a little more vascular tone. And I had a recent athlete who had a dramatic improvement on a very small dose of midodrine. Of course, the problem is that this can show up as a positive performance-enhancing medication in athletes, so you have to be a little careful about using it. Now, you can use it during the training, but during the competition, that may come up as a positive drug screen, so you have to taper them off it in some conferences. So.
Yeah, I would agree with Ian, and midodrine does seem to help in some cases. I've also seen even low-dose fludrocortisone, although the data on fludrocortisone in general is not very good. It's true for all these medicines. We don't have great data, and it's just going to really be kind of trial and error. And I would say with the propranolol, my use of it is usually low dose.
So Ian, just a question for you, kind of a follow-up for the midodrine. If it's, because I've seen mostly like no changes with the blood pressure, I mainly see changes in the heart rate. That's why I was kind of going away from midodrine. What is your thought in that regard?
It's interesting, and I exercise all these athletes because a lot of them are symptomatic during their exercise, and they typically have a fairly appropriate blood pressure response during, but afterwards they have a dramatic drop in their blood pressure. So, but their heart rate response has been appropriate. So the midodrine, I think, has been working well for me. We have seen the increase in heart rate, and I've been surprised by put on midodrine, even though their blood pressure is fine, they actually feel much better. So, as Brian pointed out, I don't think we really know the mechanism behind this. And maybe that you give them enough blood pressure, don't have to have quite as much of a heart rate response. But I think I get more questions and answers as I continue with this population.
Sure. Thank you so much for your excellent response, both of you. Thank you. So Mahi, I don't know if you're going to go ahead with the next section now.
Yes. Thank you very much, Ian and Sandeep, Christine, and Brian. Excellent reviews, excellent summary. Thank you, Georgios and Katie, for moderating the session. In the interest of time, we'll do Dr. Dikima's talk after the keynote address, and thank you all for accommodating and understanding. I'd like to move on to introducing Dr. Deepti Ichiporia, who is our ACC president. She is just coming off of coffee with the ACC president, so we appreciate her joining us in this conference and giving us this talk. I'm going to let the two fellows, Farhad and Michael, take over. They are both first-year fellows at the University of Iowa, and they'll be moderating this session. Thank you very much, Deepti, for joining us.
Thank you for having me.
Good morning, everyone. Thank you for joining. My name is Michael, like Dr. Ashwath mentioned. I'll be moderating the session with Farhad. Sammy is one of my co-fellows. And we have the distinct honor to introduce our keynote speaker, Dr. Ichiporia. Dr. Ichiporia is the ACC's 70th president. She's an interventional cardiologist. She's the Eric and Sheila Sampson Endowed Chair in Cardiovascular Health, Director of Disease Management for Hoag Heart and Vascular Institute, and Associate Professor at the University of California, Irvine School of Medicine. Dr. Ichiporia completed her residency in internal medicine at Stanford Healthcare, as well as fellowships in cardiology at Georgetown University and interventional cardiology at Stanford Healthcare. Her professional interests include quality measurement and improvement in cardiovascular disease prevention in women. Dr. Chaporia has a long history of involvement and leadership with the college. In addition to serving on the Board of Trustees as Vice President and Secretary, she was also Chair of ACC's Board of Governors and President of the ACC's California chapter. Dr. Chaporia also served on ACC's Lifelong Learning Oversight Committee, Science and Quality Committee, Governance Committee, among others, and has helped to inform ACC's innovation program efforts. Dr. Chaporia chaired the ACC's Task Force on Health Equity and served as co-chair of the ACC Middle East Conference in 2019 and 2020. Most recently, she is focused on technology and innovations that can propel digital transformation and disrupt care delivery, ultimately improving the lives of clinicians and patients and helping achieve health equity worldwide. For anyone interested, she actually has a great paper on population health, which is titled Intersecting Technology, Data, Health Equity to Achieve Healthcare Transformation. And I imagine some of it will be in the talk potentially. Dr. Chaporia is the college's first president of South Asian descent. And while she's the college's 5th female president, she's the first in college history to assume the presidency from another female president. And without further ado, I'd like to present Dr. Chaporia and her talk on digital transformation in healthcare.
Thank you so much, Michael. And Farhad, I'm looking forward to being with the Iowa chapter this morning. I want to thank Mahi Ashwat, the president of the Iowa chapter, for inviting me. This is such an honor. So I'm going to go ahead and share my slides. Let's see. So what I'm going to talk about this morning is digital transformation. What does that mean for medicine? I'm going to introduce this concept of quintuple aim, which is something that's going to appear in my leadership page coming up, and the promise of health equity. It's a lot of concepts, but a lot of the stuff that I've been thinking about for a long time, and I want to share some of these thoughts. So I have no disclosures for this talk. So I'm going to really address what is digital transformation and why is it important? What has the COVID era done for digital transformation? And how did health equity come to the forefront? I want to talk a little bit about how much health matters and discuss how health and the economy are truly linked. Discuss this quintuple aim and the imperative to achieve health equity and really achieve good health for everybody. And then what is our role as clinicians and what is the role of healthcare organizations in these sort of trends? So I like the Simon Sinek book that says start with why. What is the motivation? What's the process and what's the product? But, you know, we read this book early on in this year in my presidency for the Board of Trustees, and it's Adam Grant's book called Think Again. And what I hope is that by the end of this talk, I do make you want to say, think again about what we know and how can we rethink it. So the first thing is that I think it's absolutely imperative that we remember that the advances in cardiovascular science and cardiovascular medicine over the last 60 years have really been nothing short of remarkable. We've gathered amazing insights about the pathophysiology of myocardial infarction to seeing development of statins and VADs, and we have to be proud and know that we can deliver excellent care. Additionally, we have to remember that cardiology is an inherently high-tech field, and we as a profession are really tech-friendly. And when we have new technology, we adapt it quite quickly, assuming that there's evidence. We're inherently tech-avid, and we also have great science. Now, and as we've made progress, unfortunately, the system has not evolved. The problem is not how we deliver care at the system level. The problem is that we have not made advances. In terms of, and it really isn't that we haven't made advances in technology and science, but it's that we're outliers when it comes to cost and outcomes. And that is a real problem when it comes to efficiency. And we're really losing ground both at the macro level in terms of our life expectancy and certainly at the micro level with acute myocardial infarction. So we have to take responsibility that cardiovascular disease is at the top of the list when it comes to the cost of care and increasing in prevalence. We're seeing a huge increase in cardiovascular risk factors, and all that is doing is setting up the potential for a global epidemic of cardiovascular disease. So no matter how good we are at the clinic level, we're not really optimizing care longitudinally. And we really don't know how to optimize care at home. At the end of the day, we end up with this sort of sense of, variation that's beyond our control. And this unnecessary variation that can affect the quality of care, risk factor management, and really ultimately outcomes. So everything that I have said is really the reason that we're ripe for digital transformation. Now you may ask, why digital? Is the answer to our problems in terms of outcomes, health equity, cost, all of that, is that digital? Well, maybe, probably not the only answer, but could it be the answer? So now let's go back to 60 years, the same 60 years of advancement for the care of acute myocardial infarction. This is what IBM had to do to load a 5 megabyte hard drive. Now, we all know now that our smartphones are how much? Say 256 gigabytes or more. The exponential growth in computing power, digital data, and the way that we move digital data over the internet has really transformed all sectors of the economy, including finance, entertainment, transportation, but not really healthcare. So all of those fields have experienced some form of digital transformation. So I forgot to show, so 2021, how much progress we've made in the 60 years. But now if we go to, let's look at healthcare. This is how we delivered care almost 60 years ago. And then what about now? And if you look at it, it's fundamentally the same, right? So when you think about that, this is the imperative for digital transformation of healthcare. But I want to pause and say, what do I mean by digital transformation? And when I talk about it, I'm talking about successful digital transformation. Successful digital transformation means adopting digital technology that makes you better at what you do, makes you more efficient. It takes away tasks, or if it adds tasks, it makes you better at what you do. Otherwise, it's not considered digital transformation. And I want you to keep that in mind. Because when you think about the electronic health record, I would say to you, this is not successful digital transformation. Now, it is digital technology, right? But unless your metric of success is a better billing platform, I would argue strongly that this is not successful digital transformation. If anything, it's kind of held us back from a bigger digital transformation. Now, we're about, what, $36 billion into a reporting system that once promised us that we were going to improve efficiency and cut errors. But studies have shown that EHR has actually perpetuated medical errors instead of reducing them. And there was a study out of the Annals of Internal Medicine that said for each hour a cardiologist spends with a patient, we spend 2 hours on the electronic health record. So it doesn't really fit with our definition of successful digital transformation, correct? Now, there's a little cartoon I like, says, are we all aligned at our top priorities, digital transformation? Of course, absolutely 100%. So what exactly do we mean by digital transformation? And everybody leaves because nobody can say it. But I really want you to know the definition. Truly successful digital transformation should enhance our professional lives. So what is digital transformation? It really refers to a disruptive improvement process, that is in changes in information management, computing, connectivity, all the technologies that can help with operational. And sometimes people think that digital transformation is just about technology, but really it's a framework that can improve the clinical process, that can collate the vast amount of data that we get, can support clinical decision-making, and can ultimately increase satisfaction, both on the clinician as well as the patients, and hopefully have increased engagement. So think of digital transformation in a slightly different way. Now, this is data from Cisco, and it shows that digital transformation matters. I know that this is outside of medicine, but Cisco looked at multiple sectors of the economy and said that if you successfully achieve digital transformation, you can get major increases in customer satisfaction, employee engagement, revenue. Now, I know that this is not medicine, but theoretically, this could also apply to medicine. So now look at what would happen if we were to have digital transformation in healthcare. Well, the promises of increased system efficiency, increasing patients' engagement and satisfaction. As I mentioned, clinician efficiency and satisfaction, and ultimately health as well as health outcomes. And I think that's the promise that we're all looking at. Now, Silicon Valley has been telling us since 2009 all the way through 2020 that we're in the middle of digital transformation. This is easy and seeing a bunch of the headlines. And although we've seen little pockets of this, we really had not been seeing a lot of this in our clinic setting. But interestingly, the investments were growing like crazy. $7 billion in 2017, $8 billion in 2018. Silicon believes in digital health. And if you look at the first half of 2020, it shattered all the first quarter VC funding records with $6.3 billion in new investments. And that was 24% higher than what it was the year before. So what we're seeing is this sort of frenzy because they believe that we should be in the middle of digital transformation and they believe in digital health. Now, we know this because there's been a massive number of startup companies. This is a kaleidoscope of technology. And, you know, it's difficult to know really what problem that they're trying to solve. Now, we need digital transformation. We want digital transformation. The technology seems to exist. There seems to be a lot of money out there. So why has it not gotten in the front lines of clinical care? And really, there's not one answer. So maybe the issue is that the tech, you know, there's some things that need to happen. First, there are too many technology solutions in search of a problem. How is this going to help me take care of my patient? So there seems to be a gap there. There is a lot of data, but it's data versus information. What am I going to do with this? We need synthesized, actionable information. And then there's a lack of clinical insights and integration that seems to be missing. And I think all of these things are important. So again, I think that a lot of, you know, one of the things that's important for digital health investment, it should really address a health need. It should not duplicate existing digital tools, right? It should improve our outcomes and make us more cost efficient. So lots of different things that it needs to have. And unfortunately, we haven't seen these elements. Why? Because in the past, physicians really hadn't been at the table to co-create most of this. The other problem has been that thoughtful people like Eric Topol and others have really investigated digital interventions, and the evidence has been sort of neutral or maybe not as positive as we thought. So we really need, you know, evidence to adapt these technologies. And that's why when you see clinical guidelines, it says evidence is mixed, variable clinical trial results. So this is an area that's growing. Certainly many, many smart people are looking at this and are trying to provide us with the data so that we can use this. So if digital health is here, the future is not here yet, is what the headlines had been. Okay, now the ACC had really seen this trend and believes in digital transformation. And so actually hired John Rumsfeld in 2017, I believe it was 5 years ago. And we embarked on saying that ACC should have a strategy for innovation and digital transformation. So there was a roadmap in 2017 that was published, Roadmap for Innovation, ACC Health Policy Statement on Healthcare Transformation, Era of Big Health, Big Data, and Precision Health. And so they started to look at, what does that mean for cardiology? And I can tell you that there were 3 components that were thought about. Now, remember, digital transformation is a lot of things. There's the internal facing piece in terms of the college and what it needs in terms of technology to deliver this. But there's the patient facing or the clinician facing piece, which is the one I'm talking about, which includes virtual care. So it would replace or augment our visits. And we're going to talk about this a little bit more because COVID changed this. Remote patient monitoring, utilizing data that we didn't have before to inform prevention, care management, and health promotion. I would say to you that most of the care we provide is sick care. But what if we got data on patients when they were well, so that we could tell when they were no longer well, so that we could actually make some meaningful changes early on? And then the last piece of this is AI-driven care. This is taking analytics that improve image interpretation, risk prediction, diagnostic, therapeutic care, but they can take the data, comb through it, and give us some actionable information. So AI-driven care is the other piece. So we looked at it as a continuum. Virtual care, remote monitoring, and AI-driven care is sort of the way that we think about digital transformation for the clinician facing. Now let's talk about virtual care. What did COVID do? Well, we all know that it disrupted our professional lives, certainly our personal lives. But what did it do? Well, digital transformation, many people thought was years away. And what COVID did was really, shattered that and really started to bring in what we thought about for digital transformation, at least a component of it. So let's talk about the story of telehealth. It's projected to be a $131 billion industry by 2025. But when you look at what happened in March of 2020, we were really only at 5%, prior to COVID-19. And then look at what we did. We all actually went up to 90%, sort of propelled by this new normal that we were going to have. We didn't have a choice. Now, usually innovation occurs because there's an interest and we look at it, but this was by necessity. We needed to see our patients that could not come to the clinic. We needed to reach some of those sick patients that really needed care. Now, what's happening now? Well, going back, what we're seeing is that 90% has leveled off to about 40%, and which is where it's at. Now, there are many reasons for that. And one of them is we did have that telehealth moment. And the question was, would it last? Well, we needed a payment model. We needed regulatory changes. And we also then needed to work towards true virtual care. Now, I would say to you that virtual care for us is not just a platform for us to communicate. So the video and telephone was not enough. We need augmented data. We need sometimes ECG data. We certainly need vital sign data. So all of that would help us to really provide virtual care. So wouldn't say that telehealth is virtual care. I would say that virtual care requires other components that we really need to think about. Now, we did get some regulatory changes. In fact, we got 80 new services that were greatly expanded through CMS. Now they're temporary and we're hoping that they're going to make those long lasting. I will tell you, just coming off the legislative conference, that there are some concerns by legislators, which is that we need some, guardrails. We don't want every doc in the box corner thing that does telehealth. There's also a huge setup for fraud. So a lot of issues, even though we see all of the benefits for telehealth. So I think from a cardiology perspective, going to virtual care would mean some platform, either audio or digital or a video. Now, remember, in a lot of rural areas, we do have bandwidth issues so that not everybody can get on, a video call, so audio. And then having some remote patient monitoring so we can get some data from when patients are actually well, to then creating management pathways and therapeutic pathways. So I think that's the sort of continuum of virtual care that we would like to see. Now, what else did COVID do? Well, I think the pandemic really brought to light a lot of the health inequities that existed in society for decades. And it really exposed and amplified the healthcare inequities in America. I mean, we certainly saw COVID-19 and how it affected the Black Americans. And there was a lot of discussion about health inequity. And of course, there were many papers, the New England Journal, talking about the fundamentals of US health policy, saying, are we finally going to be tackling this health equity? Michelle Evans in that paper said the United States, one of the richest countries, has failed to achieve health equity. So of course, it has become top of mind. But I will say that the pandemic did several things. The pandemic really underscored many existing issues in our healthcare system. Number one is how much health really matters and how health and the economy are really linked. And the imperative to achieve health equity is there because we really want to have good health for everyone. So what's the data? Well, it's estimated that the impact of the pandemic on the economy is about 4 to 11% reduction in the GDP. The McKinsey Global Institute research reports that prioritizing health can present an economic opportunity of about $12 trillion by 2040. And it was estimated by the Institute of Healthcare Improvement that health inequities cost the United States $83 billion, and it's anticipated to grow to $300 billion by the year 2050. Those are big numbers. And we talked about us taking responsibility for the cost at some degree, given the fact that cardiovascular disease was number one in terms of not only prevalence, but just its frequency in terms of the population. Now, this isn't news. This is business case for health equity. That's been around. This is data from 2018. So we know that health disparities are costly and there would be a positive economic effect if health equity is better implemented. So this is one of the things that I would say. We need to rethink our focus. In the past, all discussions about economic growth focused on controlling healthcare costs and not promoting health. But we know that poor health results in premature death and lost productivity, costing the United States about $3.2 trillion. That's 60, and we spend about 16% of our GDP annually. So given this, maybe we need to rethink health as an investment rather than just as a cost. And I'm not sure we've really done that in the past. So in my leadership page that will be coming out for this next month, I will say that it talks about the quintuple aim. Now, we had the Institute of Healthcare, Outcomes looked at the triple aim, and that was in 2007. And it said that the systems need to look at improved patient experience, better outcomes, lower cost. But what we found out is the 7 years that went after that we really weren't able to get the triple aim. And why? We weren't able to achieve it because they forgot about the clinician, the people providing the care. And what we realized is in order to achieve the triple aim, we had to put the clinician there in that equation. So if you added clinician well-being, then that evolved into the quadruple aim, which was introduced in 2014. But if you really think about it, have we really achieved quadruple aim? We're still talking about clinician wellness. We're still talking about patient improved experience, better outcomes, lower cost. So we really haven't even achieved the quadruple aim. And maybe it's time for us to rethink and think about the quintuple aim. And that is putting health equity there for better health, improved economy. And maybe we have a better chance to achieve that. So last year when George Floyd's death came, people talked about social justice. And that's when Athena Pappas, the president at the time, said, let us stay in our lane and talk about health equity. I was fortunate enough to be the chair of that health equity task force. And I put in the ACC 2019 to 2023 high-level strategic plan. And I want you to look at the third bullet point, advance in the blue box, advance quality, equity, and value of cardiovascular care. Equity has been part of our strategic plan for many years. This was the first time in our history that we actually sat down to say, how can we really tackle this and actualize this? So we talked about diversity and inclusion at the college, but we've never meaningfully talked about equity. And so we talked about equity, saying we want to improve the access of care for underserved patients. We want to reduce the system, the systems that cause really health disparity. And we want to address the social determinants of health because those are important. So we created this pictorial that said that the college's 3 pillars are advocacy, education, and science. How can we leverage those organizational structures and functions to support health equity with the outcome being that we want to ensure quality care for all, ultimately achieving cardiovascular care, which is really at the core of our mission vision. And so one of the things that we did was that we created a strategic plan for health equity. And I will tell you, because I just came off the board of trustees meeting, we have married this strategic plan for health equity and married it into the big overall strategic plan for the college so that it can be part of all of the activities that we do. So one of the early things we also did was we defined health equity from a cardiovascular lens. So we defined what health inequities were. What are health disparities? What does it mean to have a health equity in cardiology? And really, what are the social determinants of cardiovascular health? Now, we don't have time to go into this in detail, but you'll see more of this in print. But let's focus a little bit on social determinants of health. These are the conditions in the environment where people are born, live, learn, play, work, worship. And these all affect a wide range of health, functioning, quality of life, outcomes, and risk. And they're really grouped into 5 domains, right? Education. How does that help with access and quality? Healthcare, economic stability, because that certainly plays a role. And what is your physical environment? Where do you live? And then the social and community context. Now, I really like this particular rendition of the impact of social determinants of health, because I want you to look at on the person. If you look, 20% of the dollars is on healthcare. So healthcare affects 20% of the social determinants of health. Health behaviors are 30%. The physical environment is 10%, but socioeconomic factors, right? Education, job status, income, community safety is 40%. Interesting, right? So 20% of the person's health and well-being are related to access of care and quality of services. But all the physical environment, social determinants, and behavioral factors are 80% of health outcomes. Now, interestingly, I want you to look at the US health and social care spending. So we spend on healthcare about 16%, right, of the GDP. What is our social care spend? About 9%. So, you know, it's just something for us to think about and look at, because I think these are important things for us to understand. This is why I wrote this paper, Paving the Way for Health Equity in Cardiology, and Why Does It Matter? I touched on some of these points, and I hope that you do look at this. So if the goal is health equity, well, how do we achieve that? Because that seems so daunting. I mean, lots of people have been looking at this and they haven't achieved it. What's the issue? Well, I think we definitely need to understand data of the individuals and the populations we drive. In fact, interestingly, the barriers to health may be just defined with a zip code, right? They say zip code influences more of the healthcare than our genetic code. 70% of health outcomes are based on social determinants of health and personal behaviors. So interestingly, I think we do need to look at the data of all the patients. We need to start collecting the data on social determinants of health. We have to target prevention through multiple channels and looking at all the intersections of different diseases so that we can do prevention maybe more upstream, you know, more early on. We need to be diligent about removing implicit bias and structural barriers so that we can provide this care. But really today's talk is about how do you harness technology to move healthcare from that episodic siloed sick care to that continuous integrated healthcare. So I really do think there's this marriage of innovation and technology and healthcare. But that's technology and innovation has to be about digital transformation and successful digital transformation. Now, when we all did telehealth, you know, during the COVID pandemic, we did see that the patients really liked it. There was an ease of care for them, right? They liked being on their tablet, their phone, their computer, or their phone. I think they didn't need to worry about waiting for a bus. They didn't have to wait for parking in the crowded parking lot or, you know, anywhere that they go. So they didn't have to rush. They could be in the comfort of that own home. And for a lot of people, that was originally a barrier for seeking care. So I think that was important. I do think as we think about digital transformation, we have to recognize that technology is getting cheaper. So the number of smartphone users in the world has really increased significantly in billions. That makes it easy because now we have a platform which is going to be easy for us to utilize to provide care. And it really has become a digital world. If you look at July 2021 data on the right-hand side and you look at, you know, what's the urbanization, what's the population, and what's the internet users. If you look at unique mobile phone users, it's 5.27 billion, right? Internet users, 4.8 billion. I mean, these numbers are staggering, right? So we know that there are 4.27 billion unique mobile phone users, and there are 4.8 billion internet users and 4.48 billion active social media users. So now we have a platform by which we can reach a huge number of people, which we weren't able to do before. And we also know that population health-based approaches by utilizing digital technology as a strategy for equity work. So can be one tool for addressing health disparity and improving population health, right? Because that could be a way that they can access health information. Now, organizations can use certainly digital technology for data collection and for learning and sharing. And if you can combine all of this with sound policy strategies, emerging scalable digital technologies can become powerful allies for improving our health and really reducing health disparities. And I think this is really important. So there's also more data that says digital health interventions can improve cardiovascular outcomes in global health disparity populations. And if you look at do a rapid review of curated evidence from 2008 to 2020, and a lot of these studies focused on race and ethnicity and low socioeconomic, and they assessed the impact of digital health interventions in the populations when it came to atherosclerotic related cardiovascular disease. And it showed that digital health interventions improved health or healthcare delivery, you know. And so now, you know, at least in 63% of these patients. But again, remember, this was going as far back as 2008. I think we've come a long way. And I think that we can see better numbers if they're more current day data to look at. Now, I'm going to bring up this barbershop because this was a study that showed that when you go to people where, if we meet them where they are, that we really can impact the difference. So if you look at the blood pressure reductions in Black barbershops, this study was really elegant in the fact that it showed that we really could make a difference if we went to that. And we know there's data that says there's improved outcomes if you have web-based prevention tools, right? Some of the health, the weight loss, Noom and all those other, that's what that is. And some of the data has been quite good. So I do think it's about meeting people where they are. That may make it easier. This was some data from a paper called Yentl's Bikini, Sex Differences in STEMI. This showed the use of artificial intelligence in STEMI outcome, and it said artificial intelligence may be able to use predictive modeling of features of STEMI and provide a standardized approach to care, which can help eliminate implicit bias in the care of women and improving STEMI care and eliminating sex disparities. And then, of course, there is this article about gerotechnology, about how we can marry digital health technology as an approach for elderly patients in terms of cardiovascular health and, helping them circumvent not only barriers to transportation, but a lot of other issues that we can do to improve their care and their lives. So let's look forward and say, where are we, right? What do we need to think about? So one thing we do know is that the technology post-COVID spend is just increased. So this is industry specific. The first box is IT, media, manufacturing. The last one is healthcare. The blue box is the acceleration of monies in terms of technology. And if you look at it, healthcare had the biggest spend in terms of money for technology. Why? Because we believe that that's where things are. This is a slide from Cheryl Pegas, who is the chief medical officer at Walmart. And she had given a recent talk at the Quality Summit and talked about the 4 main drivers influencing healthcare innovation. And I think these are important to see. So government funded programs and employers are still the largest purchaser of healthcare, and their fundamental needs are still unmet. Value-based care has started, but needs to accelerate. Why? Because there's been so much more increase in the number of consumers in a value-based arrangement, but yet 80% of healthcare spending remains traditional and effectively fee-for-service. Consumerism and demand for digital and telehealth solutions to manage healthcare has increased. And then, of course, we've identified about the zip code. So I think COVID has been an accelerator for us to really understand these trends. And this goes back to Clay Christensen's concept that disruptive innovation is what we need, right? So innovation is a process. When you have new players, which are less accessible, less expensive and more accessible, they're going to beat what's been existing, which is even if you improve current products and services, I don't think that that's going to meet our needs in the long run. So this time is so prime for our disruptive healthcare. And of course, I mentioned value-based care. So I wanted to just review what value-based care is. Value-based healthcare is a concept that was coined by Michael Porter that entails transforming healthcare systems with the primary goal to maximize value to care. So while digital transformation is not seen as a panacea for all vulnerabilities of healthcare, it is regarded as a foundation of a future modernized healthcare system, and really a pivotal step for us to facilitate the transition to value-based healthcare. So you really are not going to get true value-based healthcare, but yet you see all these patients are going into these value-based arrangements. How is that going to happen? And again, another slide from Cheryl Pegas, which says the success of value-based care is leading to shift in care models to focus on outcomes. So it comes back to health equity. If you don't take care of this outcomes, we're never going to, that's how you're going to judge these value-based care. So we need to make sure the underserved population. So Medicaid managed care plan enrollment went up from 26 million to 56 million between 2010 and 2018. The aging population, 219% growth in Medicare Advantage enrollment between 2000 and 2019. Legislation, 35 states have acted to expand access to government insurance. So again, I think the trend is going in the direction that we are going to be responsible for outcomes. So the focus on healthcare, on health equity, is health improvements that translate to tremendous economic growth also. It's estimated that 2 million more people could join the labor workforce and about 5% of greater workplace productivity for 25 million adults. That's huge. So these, labor impacts could add up to a huge number of an increase of $3 trillion or a 10% increase in the GDP by year 2040. So again, that link of health and economy. So when it goes back to answering why does health equity matter? Well, I think we need to rethink our approach to healthcare. I think the quintuple aim is here to stay. We do need to harness digital technology. I really think the quintuple aim with the pursuit of health equity is an investment, and it has the potential for being not only a societal, but an economic game changer. I have to touch on digital divide because I know that comes up. And we know that the digital divide was evident even in the pandemic because it showed decreased access to care for some of our society's most vulnerable because of the lack of ubiquitous technology, digital literacy, and internet connectivity. And I do think digital health technology really interacts with social, cultural, and economic realities, and certainly with the social determinants of health, and it contributes to health equity. So I think that we need to make investments to bridge the divide in access to use, to lower, especially for those that are in the lower socioeconomic group, the elderly, and those with language and literacy barriers. I think we need to design and research agendas to incorporate diverse set of users so we can scale and promote health equity for subsets of populations that were underrepresented in larger studies. And I do think that we need to support multi-directional communication amongst patients, provider teams, digital devices. That is going to require some data governance to harmonize and protect our real-time exchange of data. So at the end, even though I'm a proponent of digital transformation, I really don't think innovation should reinforce that social gradient of health, where people in less advantaged socioeconomic positions have less access. I think that's why I'm saying that we need to really put health equity with it and think about the quintuple aim, because I don't think digital transformation where that we're thinking about all of these things is going to work. Now, what does that mean? Well, I believe that means that the health systems have to be involved. I think that moving the dial on health equity, including digital health equity, requires looking beyond individual factors. So it's not just about us, but about the systems. And the systems are going to have to look at not just quality, which is what we've been hammered recently, but also about equity as well as resource optimization. I think most systems are good about resource optimization. They focus a lot on quality, but they haven't really looked at equity. And I think that's the sort of missing piece. And so I think that the use of technology extends into and is really shaped by our individual social, cultural, and economic position. And I think the social determinants of health should be considered when developing institutional health strategies for funding, payment models, and working with vulnerable population. Otherwise, I think that the quality of care will suffer. And so here's my charge. I think our true north needs to be that cardiovascular professionals would have to lead the way for innovation and digital health development and adoption, and couple this with our strong desire to help our patients be as healthy as possible. And that really is health equity. And so we need to shift to that quintuple aim, which I believe is a true investment in our future. And I think all of this really aligns nicely with what the ACC mission, a vision is, which is a world where innovation, remember we added that, and knowledge optimize cardiovascular care and outcomes. So Franz Grodel, one of the founders of the college, said, we'll meet the future not merely by dreams, but by concerned action and inextinguishable enthusiasm. So I do think that we have a lot of dreams. I think we are a membership organization with members that are very much moved by concerned action. And we certainly have a lot of enthusiasm. So I'm going to stop here. Thank you so much, but I'm happy to take questions. So thank you.
Thank you. Thank you so much, Dr. Echavarria, for the excellent talk on the digital transformation of healthcare, and especially its links with health equity, which is certainly a new perspective, which may be overlooked at times. So I can think of a few questions myself, but I would like to open the discussion to the audience. Whoever has questions, they can either speak up or write in the chat box, and I will try to moderate the discussion. So Dr. Echevarria, while the audience is thinking, maybe I can come up with my question. So one of the things that I appreciate that because you stress on the importance of digital healthcare, and then it has the potential to transform healthcare in the coming years. Maybe it will take longer than what we expect ourselves, but then there are certain implications of like cybersecurity and like HIPAA violations in these patients when we eventually move to that large scale digital transformation, how that has like potential for liability for the institutions or the clinicians. And then what do you think about that?
Yeah, no, I think it's a really good point. And it's certainly something as we're undergoing digital transformation at the college level. So what I've talked, the internal facing, the college is creating platforms that can interact with the membership on a digital platform. We certainly had a long discussion about the cybersecurity issues and how are we going to manage all of that. And I do think that as we think about digital transformation for healthcare in a wider way, these are issues we're going to have to grapple with. The digital divide we're going to have to grapple with. I mean, I agree with you, Farhad, that there are no easy answers, right? But if we don't start to have the conversations and really come up with all of this, then I think that, we're never going to find an answer. I mean, I think even from 2007 to now, we've really moved our thinking. Think about, would you have thought about a chief innovation officer for the college 5 years ago? I mean, I remember when John came on, nobody, and now think about all of the younger people, like you guys thinking about digital health and really embracing it in a way. I mean, look at all of how cardiology is infiltrated. John is now at Facebook. There's so many cardiologists going into this because they're realizing we need to co-develop all of this. So it's a great question.
Thank you so much. So we have a question from Keaton. So the question is, could you comment a bit more on integration of artificial intelligence in cardiovascular care and what the future entails, and also what we need to be careful about in this regard?
Well, so let me start with the latter part, which is what do you need to be careful about? Well, I think there's always concerns that somehow artificial intelligence is going to replace us. So I want to first say that I don't think artificial intelligence or anything is going to replace you and me. I think it only augments what we do. AI has made the most amount of headway in imaging. So there are lots of ways that AI can be incorporated into imaging modalities. But I also think that AI could be utilized. I was at the European Society of Cardiology meetings earlier this year. Paul Friedman from Mayo gave a really wonderful talk about artificial intelligence and talked about how they had trained artificial intelligence, machine learning basically, to look at ECGs to predict disease. So he gave an example of a young man that had come because his sister had died of sudden death. And there was a family history. And he said, he showed the ECG and said, okay, what would people do? So everybody said an echo and maybe a Holter, but there was really nothing on the EKG. But then he showed how they had trained this set, and this ECG predicted LV dysfunction in this patient. And what happened was that a patient did end up having cardiomyopathy. And so it was a really interesting way for us to maybe utilize it to augment our care. Maybe it could help us figure out patterns where we can't see it, obviously. But I think there's still a lot more work to be done with AI. Imaging is not the only area, but there's certainly all kinds of other areas that we need to look at.
Mm-hmm. Thank you so much. Any other questions from the audience at this point?
Yeah, it's a great talk. In the world of electrophysiology, we're getting a lot of these patients that are wearing smart watches. There's these new, you can track almost everything in your daily life, and you can send it to your doctor. And we're faced with this technology. First off, it's not billable, but it's being incorporated on a regular basis. And a matter of fact, it's much more convenient for my AMAS population. I can either give them a $1,000 event monitor, or I can have them buy an $89 app, and they can give me the data fairly quickly. How do you see this evolving over as we try to incorporate this telehealth?
Well, I think that is a great point, because we are starting to see people wanting to send their data, right? Their Apple Watch data, their, Alive Core data. And so do we have time to really go through all of those pieces of data? And then we have legal responsibility if we miss something on one of those pieces. And that's really the issue, right? And then you added the other piece, which is we're not getting reimbursed for any of this. And so this is where I think something like AI, it would be nice if there was some way for that program to go through that and give us kind of a bullet version saying, okay, we've looked at all this data and hones in on the important pieces, right? And that's really what we need. We need synthesized, actionable knowledge. This is where I think AI can play a role. But this goes back to the consumerism, right, that I mentioned. Patients want this. They want you to look at this data. They want to come in, and boy, it's the most interesting thing to them. And we're just thinking, oh my gosh, I don't have time to look at all of this, right? So as important as it is, it's just not what we, so I think this is where either we're going to let the market forces and technology companies decide how we're going to deal with this data, or we're going to all sit down and say, this is what we need, and this is how we are going to do it. That, to me, that is a better solution, because everything has come to us. People, administrators tell us how to practice medicine. Insurance companies tell us what, how we do this, what we can prescribe and all of that. I think that the time has changed for us to sort of take more of an active role in all of this. So I think that, I've talked to Fred Kusamoto from HRS. Maybe HRS and ACC should partner as to how do we deal with this data? And we have some guidance about all of this. This is where the innovation program at the college really is looking at some of this thing. We're actually having an artificial intelligence symposium coming up in this week, actually. This is a third one that we're doing, and each time we tackle different areas of how do we manage some of this data and all of that. So I think participating and really coming up with some of the solutions. If you have solutions, bring those forward.
Very good. Thank you very much. That was a spectacular talk.
Oh, thank you very much.
I just have a comment. I want to say thank you to Diti for everything that you do for the ACC. Actually, I've seen your leadership at multiple levels, and your commitment to equity in healthcare, to clinician well-being, for telemedicine. This is all really appreciable. It's also I also wanted to mention a little bit about your breakfast with the ACC president that you do every Saturday. Thank you for giving up your weekend time for that. Those are very popular. I watched a few of those sessions, and I would encourage everybody here to consider attending those sessions, or at least watching them afterwards. Those are very important topics being discussed at a very high level, so very informative. So I would encourage everyone. And again, thank you very much for everything you do for the ACC. We really appreciate it.
Thank you, Mahi. And actually, the Coffee with the President is once a month, and it is on a Saturday morning. So I'm on the West Coast, and it's 7 a.m. from those of us on the West Coast, and 10 a.m. on the East Coast. So Central Time would be 9 a.m. on a Saturday, once a month. And the next one is November, I believe 14th. If that's a Saturday, and we have Dr. Heyer, who is the Vice President of Medical Affairs for Moderna, as well as Dr. Vincent Covello, who is a world expert on stress communication. And we're going to talk about how do you communicate under times of stress, and maybe even touch on vaccine hesitancy and how do we manage that sort of communication piece. So I think it'll be really excellent. So, but thank you and I made that shameless plug for my Coffee with the President. But, in times of COVID, I think the hardest part has not been to be in person with the membership. One of the highlights of ACC presidency is being able to travel internationally as well as domestically. And in 2 years, I've had 3 chapter meetings in person. And typically at this point, I may have had 20 or 30 of them. And so what I miss is the interaction face-to-face with the membership, because I think there's a lot we can learn from each other, and certainly things that we can take back. So that's why I put my email at the end of the talk, so that if somebody wants to send me a note or something, certainly you can also send it at ACC President, that there's a President email that you can send it to. But anyway, I really enjoy this has been a phenomenal opportunity. Wish that it had more of the face-to-face time, but I think that Mahi, you're doing great work for the Iowa chapter. I see a lot of the initiatives that you're doing. So I think that the Iowa chapter is doing very well with you at the helm with leadership. So, and it's so nice to see the fellows involved with this conference. And I want to thank Farhad and Michael for their involvement in this moderating this session. So thank you.
Thank you so much.
And as a small token of appreciation, we sent a box of chocolates. I think Autumn just ordered that over the last few days. So hopefully it should be coming your way soon.
Thank you.
We hope you and your family enjoy those. And again, I know how busy your schedule is, so really appreciate it. If everybody could consider turning their cameras on for a brief minute, we'd like to get some pictures that we can share on the website.
Dr. Ashworth, do we have another quick time for a quick question? I wanted to let everyone kind of ask their questions first.
Yeah, I actually had a question about telehealth. I know it's part of our agenda with the, with the legislation and stuff, but virtual medicine and, digital transformation, I think telehealth and the reimbursement by the insurance companies was probably going to be critical. I know we are advocating for that. What do you foresee? I mean, do you think it's sustainable in the future, or?
Yeah, I think that as they said, the genie's out of the bottle, right? And I don't think you can go back. I do think that as we do that, we also have to add some guardrails and some, so that we really don't have erosion of that particular technology by utilizing it with anybody that, I mean, we've seen a lot of doc-in-the-box shops opening up that want to do telehealth from 9 to 5, and then they're gone, and then you're taking care of those patients because you're on ER call. I don't think that's the answer, so we really do need some guardrails there.
Mm-hmm. That's awesome.
Do we have one question, Dr. Jeopardy? I just had one quick question I wanted to ask. So you mentioned health equity, and I know that barbershop study was interesting, actually. And Dr. Yancey and I know Dr. Ibrahim are very passionate about health equity in the lower socioeconomic patients. So I was kind of wondering, what do you predict, or what is kind of your solution to fixing that? I know being present in those communities is probably one of the big ways to change that, but what do you think are some potential fixes for it? If you had an unlimited fund of money, what kind of approach would you take to fixing that?
Well, what would be nice is if we can provide some of the digital technologies in some of these communities as a means of accessing these people and providing care. They may be less likely to come and seek care because they don't have either the transportation issue or financial issue, or maybe just some reluctance or inherent, mistrust of professionals, and so if you could sort of reach them that way and maybe use some community workers. I think we are going to have to link with local community people to be able to provide this, and really where they are, that may make a difference. And like I said, our focus ultimately is going to have to be to target wellness care, right? Prevention. So we're going to have to start early, and that'll also help build trust, but it also will help us to know when they're getting sick earlier. And so we're not spending all that money at the last few years of their life, but hopefully earlier.
Awesome.
Thank you.
Autumn, if you want to grab a couple of quick screenshots when everybody has their cameras on. On a count of 3, 1, 2, 3. We'll do one more on a count of 3, 1. You ready, Autumn?
Yes.
Yes, okay. 1, 2, 3.
Okay, thank you, everyone.
Great,
right.
Thank you. If you could send me that, I'd love to tweet it.
Yes. Thank you very much, Deepti.
Thank you very much. Bye-bye. You guys have a great rest of your conference.
Thank you. We will continue with our COVID session. I'm sure a lot of people have a lot more questions, especially probably for Brian and Ian about the POTS syndrome, which is a major issue for a lot of us and our patients. But we will go ahead and continue our session. We'll continue with Dr. Dikima, and I'll let Georgios and Katie take over.
Thanks, Dr. Ashworth, and thanks for being so flexible, Dr. Dikima. So we'll finally introduce him. He is he's a professor of internal medicine and pathology at the University of Iowa. In the Department of Internal Medicine, he serves as a director for the Division of Infectious Diseases. He did his residency in internal medicine at the University of Virginia and fellowships in infectious diseases in medical microbiology at Iowa. Also, while at the University of Iowa, he received his Master's of Science in Preventative Medicine. As a hospital epidemiologist, infectious diseases clinician, and clinical microbiologist, he has studied and published extensively on epidemiology and antimicrobial resistance and healthcare-associated infections. In 2014, he was elected president of the Society of Healthcare Epidemiology of America. He is also a member of the CDC Healthcare Infection Control Practices Advisory Committee. He is an associate hospital epidemiologist and an associate clinical microbiology laboratory director at the University of Iowa Hospitals and Clinic. We are looking forward to hearing about his talk on COVID vaccines and variants.
Thank you very much. Can everyone hear me?
Yes, we're good and we can see your slides.
Great, great. So thanks very much for the invite. I hope to spend the next 20 minutes or so chatting with you about COVID-19 variants and the effectiveness of the COVID-19 vaccines. So the objectives are, I want to help you understand what we mean when we talk about a variant of concern, or VOC, and then talk about the most recent vaccine effectiveness data, including, importantly, during the surge of the latest variant of concern, the Delta variant. I'm going to discuss briefly the most common adverse events associated with the 3 vaccines that are currently under FDA approval or emergency use authorization, and then review some of the existing data on the impact of COVID-19 vaccine boosters. So when you sort of step back and think about where we are now, it's really quite overwhelming. The global scope of this epidemic is really remarkable. We're approaching 5 million total deaths now and over 242 million cases of COVID-19. The spread of SARS-CoV-2 is just hard to get your head around at this point. These are also likely gross underestimates. And as has occurred with previous pandemics, this one has occurred in sort of surges, and we are coming out of the most recent surge, depending on how you count, the 4th or 5th surge of SARS-CoV-2 infections worldwide, this one being driven by the Delta variant. So this represents a whole lot of viral replication. And as we know, anytime an organism replicates, there are mutations, there are changes, there's evolution, and those changes can increase the fitness of a virus. And I thought this was kind of interesting to look back at this opinion piece in Nature from over a year ago, where the title said the coronavirus is mutating, of course, to no one's surprise, and then followed by, does it matter? And it was interesting that even several months into the pandemic, it wasn't quite clear how much these changes, these emerging variants of SARS-CoV-2 were going to change the situation around the pandemic. This particular article was just talking about how quickly one particular mutation in the spike gene had emerged and become dominant around the world. So as these variants began to emerge, a sort of categorization scheme developed where first, if a variant looked like it might be more transmissible, cause more severe disease, impact diagnostics, et cetera, it was termed a variant of interest. And then if more data accumulated, they were termed variants of concern. And the variants of concern were identified as such based upon changes that impacted any of these factors. As I mentioned, is it more transmissible? Is there good evidence of that? Does it cause more severe disease? Does it affect the performance of our diagnostic testing? Or does it affect the effectiveness of therapy? And so far, we've seen variants that are clearly more transmissible. We've seen at least 1 or 2 variants that appear to cause more severe disease. Fortunately, we haven't seen a lot of impact on our diagnostics yet from emerging variants. And we have also seen variants that have an impact on the effectiveness of some of our therapies. For example, some immune escape from some of the monoclonal antibody treatments. So that's also a very important thing to keep an eye on. So as we think about how we're tracking variants, fortunately, our ability to do surveillance for emerging variants is improving really literally every day. And the CDC now has a really nice variant of concern surveillance system, and they publish these data and update them regularly on the website, and this is where these images are from. So this goes from July through just last week, looking at which variants are dominant in the United States. And the one thing that's obvious here is that we're talking about one variant being pretty much the whole story here in the US and largely also around the world. And this is the B16172 variant of concern, which is the Delta variant, and currently accounts for almost every single virus that's being sequenced in the US. And of course, this was kind of redundant to put this figure in because in every region, Delta is dominant. So it's all about the Delta variant currently. There are also notably some subvariants of Delta. And one in particular, you may have read about in the news recently, the AY4.2 variant of concern. And you've read about it because in the UK, for some reason, the AY4.2 subvariant of Delta seems to be emerging and becoming more common, now accounting for 10 to 15% of the infections in the UK. That variant really has not been successful in the United States. There were some isolates of this variant. It seems actually to have potentially gone down in frequency. So I think that story has yet to be told. We're really not sure whether that subvariant AY42 that people are worried about is going to become an increasing problem. So why has Delta been so successful? Well, it primarily is due to the fact that it's more transmissible. So if you look at the reproductive number, and the reproductive number, to remind you, is really kind of a theoretical construct. And what it says is how many secondary cases would a single case of an infection produce in a completely immunologically naive population that mixed randomly. So without any kind of interventions to reduce spread. And the reproductive number, or R naught, for the original COVID-19 strain was about 2 to 3, some estimates a little bit higher, but the R naught for the Delta variant is estimated anywhere between 4 and 8. So it really is at least twofold more transmissible than the original COVID-19 variants, in part probably because the upper airway shedding seems to be more abundant for the Delta variant. It has a shorter incubation period by at least a day and a shorter serial interval. The serial interval is the number of days from the onset of an index case to the onset of a secondary case. So when you have shorter incubation periods and shorter serial intervals, that means a virus can spread faster. There's also some suggestion that the Delta variant can more efficiently enter respiratory tract epithelial cells, and that is still being sorted out. So now let's move to the vaccines and the question of whether they are effective against at least this emerging variant and potentially others. This is a table just of the vaccines that are currently available in the US, Pfizer, Moderna, and Janssen, and one that hopefully will be in the next several months are Novavax. Pfizer and Moderna are mRNA vaccines. The Janssen vaccine is an adenoviral vector vaccine, and the Novavax is a recombinant spike protein in the nanoparticle. But the efficacy is what I'm showing on this slide. And I want to distinguish between efficacy and effectiveness. Efficacy trials are those placebo-controlled randomized trials where you carefully follow patients forward for any symptomatic COVID-19 and look at really the performance of the vaccine under ideal circumstances and at an earlier point in the pandemic. And you can see that most of these vaccines, 3 of the 4 are over 90% efficacious at preventing infection, all infection. Janssen is less efficacious, around 70%, but highly, highly efficacious at preventing severe disease as well, including the J&J vaccine, where the initial randomized controlled trial showed really no deaths in the vaccine arm. So these are extremely effective vaccines. However, we are now starting to see that the effectiveness, the real world effectiveness of these vaccines over time does appear to wane when you look at just COVID-19 infection. So these are data from Southern California Kaiser Permanente members. Over 3 million of them have been fully vaccinated with the Pfizer mRNA vaccine. And if you go out more than 5 months from the time since full vaccination, you see the estimated vaccine effectiveness decline from around 90%, as we mentioned, down to closer to 60% or so. So this is of some concern. The reassuring part is that the effectiveness against hospitalization remains highly preserved, right around 90%, and does not seem to decline to the degree that the effectiveness against infection does. And the other reassuring piece is that the Delta surge appears to be driven by the transmissibility of the virus and perhaps waning immunity from vaccine and prior infection, not from immune escape. And if you look at some of the accumulated data out of the UK, and this is from their National Health Survey, where they actually do regular PCR testing regardless of symptoms or vaccine status in the patients or the individuals that they follow. So this is a really nice surveillance program. And what you can see here is the vaccine effectiveness more than 14 days after the Pfizer vaccine. So I just want you to concentrate here, was pretty much the exact same when the Alpha variant was dominant and when the Delta variant was dominant. The other interesting piece from this graphic is that if you look at those who were previously infected but not vaccinated, really the effectiveness of prior infection was pretty much on par, or maybe not even as good as the effectiveness of a 2-dose Pfizer or mRNA vaccine. So I want to point you to this CDC data tracker for monitoring vaccine effectiveness. This has been up for maybe a week or two now, but it's really nice because it aggregates data from several ongoing monitoring systems. 2 of them are monitored for all infections because they regularly test either long-term care facility residents or first responders and healthcare providers. And the other 3 monitor for the effectiveness against hospitalization and death. The University of Iowa, out of interest, does participate in both the Ivy network and also in the Heroes Recover study. So we have some of our data included in some of these data trackers. But again, confirmation here that if you look at effectiveness against hospitalization, it's really been very well preserved, somewhere in the high 80s, close to 90%, even out through August, which is well into the Delta surge. So the vaccines currently used are highly effective at preventing hospitalization. However, confirming again, some decrease in vaccine effectiveness against infection. And the reason that the NHSN numbers here are lower than the Heroes Recover numbers are that these represent elderly subjects, because it is the NHSN long-term care facility surveillance versus first responders who tend to be younger and do have more robust vaccine immune response. But just a few very quick slides really to show you how much this Delta surge has been driven by the unvaccinated population. So this again is aggregate data from 16 US jurisdictions, the number of cases of COVID-19 per 100,000 population. And you can see in the black line, the unvaccinated population during the Delta surge versus the fully vaccinated. So really has been a surge of the unvaccinated. And these now we're looking at deaths. So the y-axis is different here, incidence per 100,000 of deaths between 0 and 10. And you can see the mortality really concentrated among the unvaccinated, as is clear to any of the healthcare personnel who've been working in ICUs over the past few months. So what this accounts comes to is about a 6-fold increased risk in testing positive for COVID-19 among unvaccinated versus vaccinated persons, and an over 11-fold greater risk of dying from COVID-19 in the unvaccinated versus fully vaccinated. Now, just a quick note on the differences between the three available vaccines. Many of you have probably read some of these data already or read about them, but it does look like Moderna is probably the most immunogenic of the vaccines and has had the lowest incidence of COVID-19 per 100,000 population compared to Pfizer and Janssen coming in third. But if you compare it to the unvaccinated, these differences are actually pretty minor. The metaphor that I heard from a colleague was that, Moderna might be like a Rolls Royce and Pfizer like a Lexus and Janssen like a Chevrolet, but being unvaccinated is like being naked and dodging traffic in the middle of a busy highway. So clearly all these vaccines have been highly effective during this last surge. And now we're looking at deaths per 100,000. And again, you see this stepwise increase depending on the vaccine you received, but the highest death rate by far among the unvaccinated. Other good news about the vaccines are that this protection is afforded to all the age groups. So the incidence per 100,000 population among the fully vaccinated, really across all age groups, compared to in the dotted lines here, the incidence per 100,000 among the unvaccinated. Now, it should be noted, though, that those who are of advanced age, and particularly over the age of 80 in these data, when they do get an infection after being fully vaccinated, they are at significantly higher risk of death than those in other age groups. So we are seeing some deaths among the fully vaccinated. They tend to be in either over the age of 80 or have other underlying health conditions that may either reduce their response to the vaccination or suppress their immune system in other ways. And then a quick note, because I've shown you a whole lot of vaccine effectiveness data in a very short time, I want to just remind everyone that there are limitations to vaccine effectiveness studies. The efficacy studies that I showed you at the beginning of the talk, those are all randomized placebo-controlled trials. All the effectiveness data that you see in the literature are observational studies, and they're subject to confounding and bias. And some of those clear issues include that groups that were prioritized for early receipt of the vaccine, as you know, are often at higher risk, either higher risk for getting infected or higher risk for severe COVID-19. So that has to be taken into account in study design, or at least considered. And then the other issues include that people who are fully vaccinated may change their behavior after vaccine receipt, taking more risks or being less likely to get tested because they feel protected against SARS-CoV-2. And then finally, and importantly, I think, as we see more and more SARS-CoV-2 infections as the pandemic progresses, and particularly with this Delta surge, with the Delta variant being highly effective at finding the vulnerable, population-derived immunity increases over time because more and more people get infected. So then you have the unvaccinated population has a level of protection from prior infection that you may or may not be able to measure. So the bottom line is that all these limitations can actually lead to an underestimation of vaccine effectiveness. So the data that I've been showing you, if anything, is an underestimation of how effective the vaccine is. So now let's turn to the issue of booster doses, because we did see now how some of the vaccine immunity, particularly against all infections, can decline over time. So these are the data that were just presented to the FDA about booster doses. They basically did every possible combination of Moderna, Janssen, and Pfizer, giving previous recipients of these three vaccines boosters with the other vaccines, as well as the vaccine that they were originally immunized with. And then they did several immunogenicity studies. And it's important to note that this is not look at infection outcomes. This looks at binding and neutralizing antibody levels, which there is some suggestion certainly that neutralizing antibody levels are associated with protection, but this does not take into account cell-mediated immunity, et cetera, et cetera. And what these investigators found was that booster vaccines elicit very strong serologic responses in all three vaccine groups, whether you receive Pfizer, Moderna, or Janssen. But the highest responses, the highest fold increase in binding and neutralizing antibody levels were when you use the mRNA vaccines as the booster. Moderna, Pfizer, in all of these three groups gave you the most robust increase in antibody levels. I will note that these numbers here, 32-fold and 56-fold increase, this is really based upon the fact that the J&J vaccine was less immunogenic to begin with and was really placed at a disadvantage because it was approved as a one-dose vaccine. It really probably should have been a two-dose vaccine from the beginning, but that's why there's many-fold increase with Moderna and Pfizer. So if you got the Janssen or J&J, it does seem, at least from these in vitro data, that getting the mRNA vaccines would be a better thing to do than to get a second J&J vaccine. And then the other important point here was that the heterologous boosting, or the mix and match, gave you the same or even higher potentially serologic responses than homologous boosting. And so fortunately, we also have some real world data about the effectiveness of boosters. The largest experience so far is from Israel, where they gave over 4 million people booster doses. Some of the earlier preliminary data were published in the New England Journal already, but this preprint is a report across all age groups. And so a note on this graph, which I'm sorry is a little confusing, but the y-axis is the fold reduction in infection rate compared with those who did not get a booster, those who they just used Pfizer in Israel. So those who just had their 2 doses, didn't get a booster, and then compared to those who did get a booster across the age groups from 16 to 29 up to 60 plus. And then this is a 14-day period denoted by this red bar. And what you see here is that by about day 10 to 14, you really start to see a reduction in the infection rate among the boosted population, which was about 10-fold lower infection rate than the non-boosted, 18-fold lower rate of severe illness, and 15-fold lower death rate among those who were boosted versus those who weren't. So very good data on this. And then a recently published study from Sweden that actually looked at a mix and match approach. These were all individuals who had received an AstraZeneca vaccine, which is also an adenoviral vector vaccine. And they compared the response of those who were fully vaccinated with AstraZeneca, who got a second AstraZeneca versus the Pfizer or Moderna. And they found that the vaccine effectiveness against all infection, or symptomatic infection in this case, was 70 to 80% for those who got the mRNA booster, actually a little higher for Moderna than Pfizer, consistent with other observations, and only about 50% for the homologous boost, those who got AstraZeneca. So more data in support of booster doses. And then in the last couple of minutes here, a few words about vaccine adverse events. The summary is here that overall, these are remarkably safe vaccines. Hypersensitivity or immediate type reactions are extremely rare, but reactogenicity, which is really the immune response to the vaccine, is very common. The concerning adverse events that have been reported from the mRNA vaccines mainly is myocarditis or myopericarditis, highest incidence in younger males and largely self-limited, as we'll see. And then with the Janssen or J&J vaccine, this syndrome of thrombosis with thrombocytopenia, which is most common in women between the ages of 18 and 49. And there's recently been what looks to be a rare association with Guillain-Barré as well. But early data on the adverse event profile of booster doses is very reassuring that it's no worse or no different than the prior primary series. So reactogenicity is just actually in some ways a good thing. It's a sign that your immune system is responding to the vaccine. It's most common with the mRNA vaccines. These data are from the Moderna. And what you see here are grade 1 in gray, grade 2 in blue, and grade 3 in red grade 3 are the ones that need to be medically attended side effects. And you can see that over 75% of people will have injection site pain, and over 50% after dose 2 will have fatigue, headache, and myalgias after the Moderna, maybe slightly less after Pfizer, but most of these are the most common time when you see problematic reactogenicity is after the second dose of the mRNA vaccine. Now, in the initial trials, there was no increase in serious adverse events in the vaccine versus placebo arms, but as is usual then, after the approval and millions of people began to get it, is when we started to recognize these rare side effects. And the myocarditis, pericarditis, I would urge you to read the Gargano paper in MMWR that was just published that really summarizes the experience so far with patients who meet the CDC definition for post-vaccination myocarditis, pericarditis. And you can see the number per million vaccine doses per age group. And you can see how the frequency of this is much higher among males between the ages of 12 and 29, and 18 and 24 in particular, 12 to 17 here, and then lower in women. But then if you compare, importantly, these incidence rates with those, the number of COVID-19 cases, hospitalizations, and ICU admissions prevented, it really does give you a sense for why the Advisory Council on Immunization Practices and the FDA feel that the risk benefit here still strongly supports receipt of these vaccines, even in younger males where the number of cases is highest. And in part, what factors into that, and these are data from the CDC presentation, is that most of the individuals who develop this do recover and recover from all symptoms that they experience. I'm sure there is still ongoing follow-up, and you all have greater expertise on what potential long-term sequelae there could be. But in general, the early data is reassuring that most of these cases are self-limited and result in recovery. And then the rare side effect of the Janssen vaccine, the thrombosis with thrombocytopenia syndrome, conversely, is more common in younger women and is at a slightly lower or more rare than the myocarditis, pericarditis that can be seen with the mRNA vaccines. But the exceedingly rare complication of cerebral venous thrombosis associated with this can be very serious, and there have been deaths associated with that rare complication. So in summary, this is my last slide. The SARS-CoV-2 variants are going to continue to emerge as long as the spread of SARS-CoV-2 continues and viral replication is ongoing. Delta is currently the dominant variant by far, is more transmissible than prior variants, but the good news is that the vaccines remain very effective against severe disease. And I should note that there has not yet been a variant that's emerged that the currently available vaccines don't still have some effectiveness against, so there's not been a complete sort of immune escape variant to this point. Vaccine effectiveness does wane against all infection, even though remains highly effective against severe disease, but booster doses do seem to be quite effective at enhancing the immune response and preventing severe as well as overall COVID-19 disease. And then lastly, the current vaccines are really remarkably well tolerated overall. So anyway, thank you for your attention, and I'll take any questions.
Yes, thank you so much. And we'll give you one question, then actually there's been a lot of movement in the chat box. So I'll ask you a question, then have other attendees and other panelists look in the chat box and try to keep that conversation going as we keep moving. And so kind of one of the themes of being concerned with the myocarditis after a vaccine, and what are your thoughts, or what do you know so far as if we should be recommending boosters or subsequent dosing in patients who have had myocarditis after a vaccine?
Yeah, that is a really good question. And I think at this point, I would be hesitant to recommend a booster with the mRNA vaccine after a previous episode of myocarditis. And I think one of the things that I will be interested in is, as we get, for example, the Novavax, and as we get additional data on boosting with mix and match approaches, whether there might be the opportunity to boost if you had mRNA series and then had myocarditis after that, whether it might be safer to consider boosting with a non-mRNA based vaccine that has not been associated to the same degree with myocarditis, pericarditis. But I'd welcome other thoughts from this group. I'm sure you all have thought about this.
Yeah, no, that's a great. We actually had to do that for. We had a student. We actually had to give a letter to his college in Oregon that was requiring it, that he didn't need a second dose because he had myocarditis. Yeah, hard things to deal with.
Dan, is there anyone else you would not give the vaccine to? I mean, we get this question all the time. Is, you know, I know the majority of the population should get it, and obviously I feel the same way about the myocarditis. That's a population I'm very reluctant to give a dose to, and hopefully they got enough immune response with the COVID virus or the vaccine, and that they can fight off another infection. But anyone else you think about, like the thrombosis population? Obviously, that's a rare complication. Or
yeah, I mean, it's rare, despite its rarity, and also because of this decrement in immunogenicity, I think across between mRNA and the Janssen vaccine, for women between the ages of 18 and 60, I would recommend against the Janssen vaccine and in favor of the mRNA vaccine. And there's just been a lot more movement, I think, towards the mRNA vaccines, and will continue to be. And then I also feel that, and I don't know if I can share my screen again, but I'll just try here. Those who have been previously infected after a single dose of an mRNA vaccine appear to have protection that's equivalent to or superior to a full course of vaccination. So if someone has previously had COVID-19, and these data are from the UK, and if you look at vaccine effectiveness over time, those who had really the best protection were, whether they got the adenoviral vaccine or Pfizer, were those who were previously infected and then vaccinated. So I'm not sure it's really necessary to give a 2-dose series to those who have been previously infected.
So I have one last question. I saw the data that you gave from the paper from Gargano et al., and it's very nice there. The one thing that kind of strikes me, and that's one thing that I've been questioning myself, the one patient population, the young males 12 to 17, which obviously has the highest risk for myocarditis. And, the adverse outcomes from a COVID infection is probably, pretty low compared to the rest of the population. Is that an area that you would question yourself to give at least the mRNA vaccines?
Yeah, I think that's a great point. I think the current line has been, still that the risk benefit favors the receipt of the vaccine. But one of the reasons I'm eager to see the data on the Novavax is, first of all, the data that I have seen and that will soon be published. I think it's in preprint right now. is really very impressive for protection closer to what we've seen with the mRNA vaccines. And and the side effect profile, really excellent, less reactogenicity than we see with the mRNA vaccines. So it would be nice to have another alternative for an age group where you do see in incidents that begins to approach what their risk might be from being hospitalized if they get infected. But I think you have to balance more than just whether, the fact that they're at very low risk of being hospitalized with COVID, with the additional benefits of reduced transmission, as well as the fact that at least one would hope that that the vast majority of these cases would resolve. And I'd actually be very interested in this group's view on the extent to which one can be cavalier about, that 80-90% of the cases thus far no longer are having symptoms, and what the experience is with populations who previously had a viral myocarditis going on into adulthood.
So I just shared my data. I'm not sure if you guys can see this. Oh, stop sharing. Never mind.
We did for a second.
Yeah, let me see if I can bring it up here again. Can you guys see this right here?
Yes.
So this is the data I summarized, and I just added another set of data this morning because it's so recently updated. So if you look at the infection of myocarditis, and this is in the younger population, right? So this is the athletes. The lowest incidence was in the professional athletes, and the incidence in the college athletes was 0.9 to 2.3, depending on how you look at the data. That 2.3% is if you get an MRI on every athlete in the Big Ten, whereas at 0.6 was if you use a more directed approach, looking at symptoms and the triad of testing. So that's 0.6 to 2.3%. And then if you look at the other data across Israel Ministry of Health data, and this was the highest prevalence group of myocarditis, which is what Dan pointed out, is 0.01%. 76% were mild. In the Israeli military is 0.005%, and that's 7 out of 138,000. In the US military, it was 0.008%. And once again, this is the younger population. In US adolescents is 0.006%. And then in the most recent data that just came out in Washington, Oregon, Montana, and LA County, the average age of the population they looked at was 57, ranging from 47 to 70 in the interquartile ranges. Myocarditis was 0.00095%. And the average age of that was 36 years of age, ranging from 26 to 48, and pericarditis was 0.0018%. So, these are different types of studies because these are surveys here. Although the data in the Big Ten was a little more regimented, we did have to enter data in, and these are observational studies, as Dan pointed out. But I'd still say in this population, when I see the athletes, I tell them, get the vaccine.
I do have a question. Can you hear me?
Yeah.
So there isn't a plan or those registry to follow up patients after COVID vaccine that develop myocarditis to see if they're going to develop some sort of heart failure or arrhythmias after that. Like, patient may develop that inflammatory process in the muscle. Ejection fraction is normal, everything is fine. And a year after they develop some arrhythmias, PVCs, heart failure. I don't know. Probably we don't know yet, but is any information that we are following that?
So I think that the only way you're going to get that data is by following these patients. And I don't think any registry data looking at myocarditis afterwards is going to track those patients. But I think that's one of the things we're going to do in the Big Ten is we are going to track these patients for as long as they are still athletes at the university. So once they leave the university, we're no longer tracking that data. But the freshmen that got COVID myocarditis, which we've had almost 10 at the University of Iowa, we will have some follow-up data, but then again, it will stop once they exit the college, but at least we'll have some follow-up. I think it'll probably be the best follow-up study. And if you look at across the Big Ten, I think we have about 1,500 COVID positive cases. And then, of course, a subset of those, around 2% have had positive MRI findings. I don't know of any other long ongoing studies.
Yeah, I haven't seen any yet.
I don't either. Yeah.
Thank you all very much. That was a very interesting discussion and very relevant topic. Clearly, COVID has changed our lives and how we operate over the last few years. So thank you all very much for the active discussion and all the education that you provided in this session. Thank you, Dan, for that interesting talk about vaccines and variants. We will move on to our next session, and I apologize for the delay in starting the next session. But we will give enough time to all our speakers. This will be Keeping Up with the Science, moderated by Dr. Ketan Kurani and Shelly McGurk. Ketan is the program director of the Mason City Fellowship, and he is an electrophysiologist. He's also our early career chapter representative for the Iowa ACC, has been very actively involved with all the Iowa ACC activities. So I really appreciate all his help he provides me in organizing all these meetings and conferences. And Shelly is a nurse practitioner, and she's also the CVT representative for the Iowa chapter of the ACC. I will let them take over, but I just want to mention a word about Dhananjay. Dhananjay is actually my senior from med school in Osmania, and known him for a very long time. I'm not going to date myself here, but I've known him for a very, very long time. Either him or of him. He is very well recognized in the EP world and the ACC and in HRS. And his contributions to EP, I will let Ketan go over that part. Thank you, Dhananjay, for doing this again.
Thank you, Mahi. Yeah, thank you, Mahi, and thank you, Dr. Lakhireddy. It is my honor to, we'll move on to this next session, Keeping Up with Science, and probably go somewhat into the lunchtime as well. But it is my honor to introduce Dr. Lakhireddy, who's currently the medical director of Kansas Heart Rhythm Institute at HCA Midwest Health. He's a board certified fellowship trained cardiologist, researcher, and a renowned leader in EP research. He's also an education leader in AFib and complex arrhythmias. He oversees the HCA Midwest Health's robust EP programs throughout Kansas City area, and he leads the National HCA Research Institute's EP research program. He also chairs the ACC EP Leadership Council. He's the incoming chair for the ACC Section Steering Committee and is the board of trustees for the Heart Rhythm Society. He's been a researcher for more than 15 years and has published more than 480 papers in the field of EP. He's a national principal investigator in several landmark trials. And he also is a course director for the Kansas Heart Rhythm Symposium that I personally attend every year and has been a great learning experience. He is also a respected leader in left atrial appendage management, and currently his special interests includes cybersecurity and artificial intelligence. He's also involved in advocacy and healthcare policy. So I'll, without further ado, I'll let Dr. Lakhireddy take over from here.
Thank you, Ketan and Mahi, for the kind invite. I appreciate the opportunity to sort of give you all an update on what's cooking in electrophysiology. All right, looks like my slide doesn't want to advance. Okay, let me go back. So whenever I think of Iowa, many years ago, one of my friends from Iowa sent me this little slide, and I thought I'll share this with you, maybe a few Iowa jokes. So atrial fibrillation, I think fundamentally we understand it to be an important arrhythmia where the pulmonary veins play an important role as the triggers for atrial fibrillation. And where we quickly figured out that by electrically isolating these pulmonary veins, you may be able to stop the atrial fibrillation. This sort of formed the fundamental premise for the explosion of innovative technologies that really helped us change the paradigm for AFib management over the last 2 decades that we've been dealing with them. So we have accomplished a lot of success with the paroxysmal atrial fibrillation in where the pulmonary veins are the primary drivers, and PV isolation really became sort of the gold standard treatment. there are a lot of sort of improvements in technology, whether it is laser balloon ablation or circumferential thermal ablations or contact force and cryoablation. So there are many iterations of these catheter technologies that have come out to really improve the overall durability of pulmonary vein isolation, improve the ablation times, decreasing complications, and thereby overall improving the efficacy of ablation procedures. But what is clearly not very well understood is the role of the miscellaneous things in atrial fibrillation. And some of the advancements in the left atrial appendage area, I think, would really help us to kind of tie these pieces together. So the traditional risk factors that contribute to atrial fibrillation, there are also associated pathological and functional changes that really lead to some of the principal pathophysiologic changes in the left atrium, whether it is upregulation of the renin-angiotensin activation system, activation of the Virchow triad, increasing the thrombogenicity, combined with the loss of booster and reservoir function, with the added contribution of the complex morphology of the so-called appendage morphologies, would really become a contributing factor for the smoke and sludge and thrombus formation, and thereby the systemic thromboembolic risk that come from atrial fibrillation. And also the associated functional and structural changes that happen in the left atrial appendage explain some of the changes in the arrhythmic substrate, making the LAA an important contributor for atrial tachycardia and atrial fibrillation. And thereby, this really became an important target for electrophysiologists and interventional cardiologists equally. So the learnings that we had in the last decade is that when the AFib substrate progresses, the pulmonary veins become less and less important, and the non-pulmonary venous sources really become very important. Whether the formation of scar that relates to macro reentry, and then the activation of the posterior wall, the left atrial appendage, CS, and all these other structures really become an important part of the puzzle. And they continue to become a valuable target, really improving the overall success of ablation. So by the time somebody gets to a second procedure, the pulmonary veins become less important, and the non-PV triggers really take the primary role in these patients. And so as you see here, there are several technologies that have been put in place to target the left atrial appendage, whether you do a circular ablation with a single point catheter, or you cryofreeze it, or you lariat it, and you AtriClip it, or you surgically excise it. You can eliminate close to 25 to 30% of triggers that are present in these non-paroxysmal atrial fibrillation patients, really improving the outcomes in these patients. The results of the AMAZE trial would be presented at AHA in a couple of weeks from now. So that is, again, a very important trial that was part of this. So why does AFib ablation fail? I think pulmonary vein reconnections are an important part of this. And then you have reentry, the electrical reentry in between the scar. And then you have new triggers that really play an important role in this. So by addressing these three factors, you could incrementally improve the overall success rates of this. And that is where the evolution of the disease and the progression of risk factors also come into the play. And this is where the electrical effects of epicardial in a epicardial ligation system really plays a role there, where we have shown that adding the appendage exclusion to the pulmonary vein isolation and the rest of the lesion set could result in a significant improvement in the overall outcomes. So based on that, the CONVERGE trial was conceived. And then again, this was a fantastic trial that clearly showed that, especially in long-standing persistent and non-paroxysmal atrial fibrillation patients, a combination of posterior wall, left atrial appendage, and an endocardial ablation of the pulmonary veins could be a very good strategy that would yield much better results than a catheter technology alone. So why are all EPs going gaga about PFA, right? This is the new technology called the pulse field ablation. So if you talk to any of the electrophysiologists, the radiofrequency ablation is currently being kind of re-looked at, and PFA has really become the buzzword. So PFA is nothing but an energy source that is delivered in high voltage with frequent high voltage, high frequency impulses that are timed in such a way that you could minimize the amount of damage to the surrounding structures. In fact, one of the pioneers in this space that really brought the PFA back into cognition is actually from your place in University of Iowa, Steve Mickelson, a good friend of mine, and truly a thought leader in this area that has really brought PFA into the clinical realm in a big way. So the advantage to PFA is it's really contact is really non-critical as long as you have reasonable proximity to the tissue, which is mostly the electric field dependency. A high voltage would enable the transference of energy to the tissue. It is more myocardium specific, as a result of which the electroporation effects are limited to the myocardium, and it doesn't really impact the surrounding structures like the phrenic nerve or the esophagus or the blood vessels. So because the lesion delivery is more homogeneous and you get a much better isolation, you can ablate a wide swaths of tissue in a relatively short period. I would say it probably each lesion probably takes about 1 to 4 heartbeats as against to several seconds with the RF energy. Collateral damage is very minimal. Your electrode designs could be of varying shapes in order to promote the tissue coverage. Esophageal injury, so far the early stages are very promising. Even though the muscular tissue gets affected, the epithelium and the serosa doesn't really get impacted, and the esophageal blood vessels don't get impacted, as a result of which the ischemic necrosis that causes some of these esophageal fistula is minimized. And we have also not seen the phrenic nerve injury in these cases. So this is an example, the histopathological examples of the PFA. On the right side, you see a more homogeneous lesion. This is an example of the esophageal injury. Where you clearly see that in PFA cases, you don't have tissue injury, even though when you actually burnt the tissue live. Injury to the blood vessels is not there. And again, PV stenosis, when you actually ablate inside the pulmonary veins, the architecture of the pulmonary veins is well preserved, really raising a lot of hope as an amazing solution in cardiac ablations. What are the outcomes in paroxysmal atrial fibrillation? In this limited early human study by Vivek Reddy's group, along with the group in Czechoslovakia, it's very clear that compared to the conventional radiofrequency ablation or the cryoballoon ablations, the success rates are significantly higher because you get a much better, reliable, and persistent pulmonary vein isolation, which results to these effects. And the same thing was observed even with persistent atrial fibrillation. Again, with this basket catheter that has the ability to open up as a basket or really become a flower, depending on which part of the tissue you want to ablate. You can clearly see that by opening up the basket and parking at the pulmonary vein, you can quickly isolate the left atrial the pulmonary veins within 1 to 2 seconds. I mean, what it takes is literally 4 heartbeats, and then you have the pulmonary vein isolated. And similarly, you move around this flower basket catheter in 4 different locations on the posterior wall with 4 lesions. You can completely isolate the left atrial appendage without the fear of damaging the esophagus. This is a nice example of how the posterior wall potentials were completely eliminated after pulse field ablation, while the patient still continues to be in atrial fibrillation. The ability to create a durable pulmonary vein isolation and left atrial posterior wall isolation is pretty dramatic. I just want to show you this video of how this pulse field ablation looks. So you park this basket across the pulmonary vein, and you're applying PFA 1, 2, 3, 4 seconds, and it's done without the fear of clogging of the blood vessels or the surrounding nerves, and without damaging the structural integrity of the pulmonary veins. And you can do that to pretty much the rest of the veins too. And this is the posterior wall ablation, which oftentimes is an important target in non-paroxysmal atrial fibrillation patients. So there are multiple ways of achieving this reversible electroporation, and there are different technologies that are put forth by different companies. This is the direct current unipolar monophasic pulse, very early iteration. And then you have this Farapulse technology, which is a direct current bipolar biphasic train. This is what the two trials that I've shown you earlier are done with. And then this is another company called the Atrian, which sort of has this flat catheter that does the same thing that these other guys do. And then Medtronic's a circular catheter, which is alternating bipolar biphasic train. And each one of them have their own precautions that you've got to take. So number one, some of these things can cause neuromuscular stimulation. So it's important to have appropriate amounts of general anesthesia and paralytics. So, but the modulation of the power source and titration of the energy dosing have helped us to minimize that impact significantly. There are still questions about heating and causing air bubbles and micro bubbles that are being looked at. I think dose titration would be an important factor there. I want to show these 4 different types of catheters that are currently being utilized in different clinical trials. Again, the advantage to some of these things is you could actually deliver radiofrequency energy on off. So this particular catheter, the catheter C, which is the lattice step, the unique nature of this particular catheter is you can turn on PFA, where it can act as a PFA delivery catheter, and then you can turn off PFA and turn on RFA. And so there are areas that you want to use radiofrequency energy, you could actually do that. So that is the advantage to some of the modern catheters that are coming out. You are able to go back and forth between PFA and RFA. So let's spend a couple of minutes on left atrial appendage. Again, this is a science that has been in evolution for almost 20 years. The early work done by John L. Madden in 1949 in recognizing left atrial appendage as an important source of strokes and thromboembolic events, and that appendage elimination perhaps could be a reasonable solution in preventing recurrent strokes. We have the Protect Prevail trials that have gone on for about 10 years, and in 2015 it culminated with the approval of Watchman device. We know that it's a pretty exciting therapeutic strategy that has been very well accepted, and the data in the last 6 years of post-market release has been fantastic. With improved learning curve, this could really become a very valuable alternative in left atrial appendage for systemic embolic as well as stroke prophylaxis. So I had the good fortune of being the PI for the Amulet IDE, where we compared a dual closure mechanism closure device called the Amulet, which has a little lobe and a disc, compared to the Watchman 2.5. And the results have been presented at the ESC 2021 in August. As you see here, for the mechanism of action primary endpoint with the residual jet around the device measured as less than 5 millimeters, you have a significant chunk of these people in the Amulet device that have better closure than the Watchman. So it's 99% versus 97%. And if you really look at a more practical cutoff that a lot of us use, which is the 3 millimeter cutoff, Amulet has the ability to close at 90% compared to 71% in the Watchman device, clearly showing a statistical significance and difference between the two of them. You also notice that complete closure is accomplished in 63% of the Amulet versus 46% of the Watchman device. For the primary safety endpoint, there has not been any significant difference between the two. This is the cumulative safety endpoint that includes procedure-related complications, all-cause death, or major bleeding events at 12 months at 14.5 versus 14.7%. However, there was a slightly higher rates of pericardial effusions in the Amulet on during the early learning experience. As you see here, as most of the operators in the United States that were part of the clinical trial were not exposed to the Amulet before. Like any other medical device, as we see it, in the early phases of the usage, you always have a higher risk of complications. So once the operator reached a 6-case experience, these complications started coming down and they leveled off thereafter, which kind of is seen in the clinical trial as well. And we actually saw that in the Watchman trial as well. In the early PROTECT-AF study, we had a significant risk of increased pericardial effusion rates, which kind of leveled off as the trial went on in the later parts of the recruitment. What is the effectiveness endpoint at ischemic stroke and systemic embolism at 18 months? There's no significant difference between the two groups at 2.8% and 2.8%, clearly suggesting the equivalence or the non-inferiority between the two devices. So FDA approved it in August of 2021, and we now have the Amulet device available. I particularly find it very helpful in appendages that are very large, and those appendages that have proximal lobes where it's hard to get a proper closure. So from that standpoint, Amulet device really provides a very effective alternative and a good competitive device to take into consideration. And also the IFU of the Amulet clearly helps you to not discharge the patients on oral anticoagulation. In fact, you can deploy the device and send patients home on a dual antiplatelet therapy. And that is a specific advantage that I find with that particular device. A couple of highlights on the myocarditis. Again, COVID really brought myocarditis to the forefront in a big way. But again, as electrophysiologists, we have been looking at myocarditis and the connection between arrhythmogenic myocardial inflammation and premature ventricular contractions and ventricular tachycardia for a very long time. This was a paper that we presented as a late breaker in 2018 at HRS, where we looked at patients who have high burden PVCs. And it's interesting to see that about 51% of these people actually had underlying myocarditis as an inciting factor in it. And aggressive early immunosuppressive therapy actually helps to prevent progression of the disease and also mitigation of symptoms. And a large number of these patients even do present with significant LV dysfunction. And what we found was therapy leads to improved outcomes in these people. Again, this is a case of cardiac sarcoidosis with associated myocardial inflammation with a FDG PET scan lighting up dramatically, presenting with an EF of 10% at the start of the therapy, evolving to 30 to 50% as the myocardial inflammation resolved with aggressive immunosuppressive therapy in these patients. So at our institution, when somebody presents in with significant PVCs, especially the polymorphic ones are clearly important to really pay attention to. If they have multi-chamber arrhythmias, both atrial fibrillation and PACs, the index of suspicion for myocarditis is significantly higher. We offer cardiac FDG PET scan and a cardiac MRI with DHE and T1, T2 weighted imaging. If there is positive for inflammation, we draw a myocarditis panel to understand the underlying pathophysiology, and then we start them on immunosuppressive therapy and follow up with repeat PET scan after a 3-month cycle. And similarly, in patients who have continued inflammation or significant ventricular arrhythmias and severely depressed LV function, and ICD therapy really becomes an important strategy. And sometimes, even after the inflammation resolves, because of the flaring of the His-Purkinje system, you can have residual PVCs that can still impact. And those are the cases where radiofrequency ablation would be a very viable strategy. So this is a classic iceberg phenomena where we are only seeing a fraction of these cases that have underlying myocarditis. I think a lot needs to be learned, and a very high index of suspicion perhaps is very, very important. I think COVID really brings in a true glimpse of the cardiotropic viruses that are very commonly prevalent during the flu season. A lot of times you come across patients in the emergency rooms with chest pains, early signs of flu, with a little bit of a troponin elevation, but we never really give it much thought on those. And I bet hundreds of those patients that have that type of a presentation have underlying myopericarditis that oftentimes goes unrecognized. And perhaps there needs to be a renewed interest in looking at these patients more closely. And perhaps an early intervention and an effort to really identify myocarditis as an inciting cause could really help us minimize the progression of many of these so-called non-ischemic dilated cardiomyopathies and really change the disease paradigm going into the future. So inappropriate sinus tachycardia. Again, this is a lot of work that we did in this particular space, disease of young women, especially medical professionals. This really devastates the lives of many of these young productive members of the society. There are many hypothesized mechanisms, whether it is supersensitivity of the sinus node or the resetting or of the sympathetic and the parasympathetic inputs, or whether it is viral infection mediated supersensitivity to the sinus node. We don't know how, but a lot of these people do end up with the sudden onset dysautonomic problem called IST. The current therapies, coronor, beta blockers, calcium channel blockers, yoga, they really don't work that well. In a vast majority of these cases, we used to take these patients for a radiofrequency sinus node modification, which oftentimes is associated with phrenic node paralysis. Multiple procedures later, you end up destroying their sinus node. They all end up with a pacemaker. And in the end, you lose and the patient loses. So this is where a very exciting hybrid thoracoscopic approach that has been very helpful for us. And this was actually a technique that was pioneered by a group in Brussels, Belgium, which we adapted. And through the Susrita IST registry, we followed these patients more closely. In patients who are resistant to multiple medications, we offer an epicardial thoracoscopic SVC RA isolation, IVC RA isolation, and then a sort of a crista terminalis lesion epicardially, and then we fill in the gaps endocardially if there is a gap in it. The idea being the sympathetic nervous system innervation at the level of the right atrium. I mean, what you're essentially doing is sympathetic denervation at a regional level, really taking out the inputs into the sinus node and the superior sinus node as well as the inferior sinus node cells that you come across, and thereby promoting relative denervation without impacting the sinus node itself. This compared to the conventional approach of where you modify the lower half of the sinus node until you get a 30% drop in heart rate. So the results are actually pretty amazing. In these 50 patients in each arm that we looked at, the heart rate improvement is pretty dramatic with the hybrid approach. Long-term heart rate improvements is also pretty significant with a dramatically reduced risk of phrenic node paralysis and the need for pacemakers. Close to 50% of the patients in the sinus node ablation require pacemakers, and the overall need for pacemakers in the hybrid approach is actually 2 to 3%. There is a significant improvement in their quality of life as well as anxiety and depression scores as well. So this is something that need to be further evaluated in a randomized controlled trial fashion. And this therapy definitely has a lot of promise going forward. So I once again appreciate the opportunity to allow me to present some of the new things that I've been working on. And again, I'm always impressed by this tailgating that you guys endear on. So thank you very much and have a wonderful rest of the day.
Thank you, Dr. Lakkareddy. I have one quick question. You also, thank you for this update and your talk. With your interest in cybersecurity and artificial intelligence, if you can comment on what things are you excited about with EP with regards to artificial intelligence, and what do we have something to look forward to in the next coming years? Absolutely,
very timely. In fact, the ACC EP Council is actually going to put out a pretty nice state-of-the-art paper in the next few months. I think the AI and machine learning in electrophysiology, I would say, is like throwing a kid in a candy store, right? So the entire realm of integrating EKG, pre-procedural imaging, intra-procedural electroanatomic mapping, and electrograms, mixing it with the demographic and epidemiological data to really create an upstream and a downstream predictive modeling is the most amazing thing, right? So if you took that facet of it and you apply it to whether it's atrial fibrillation, sudden cardiac death prevention, or inherited arrhythmic conditions, right? I mean, the implications are far-reaching and they're just incredible. And again, we have only scratched the very surface of what is there and what could be done, right? So there are at least 30 or 40 companies that have actually sprung up in the last 3 years that are trying to solve this problem. Nuvera is another new company that's specifically targeting atrial fibrillation. Their goal is by creating a platform that could accurately predict what type of lesion set could be useful for a given patient's condition. You could offer a tailored ablation strategy for a given patient in order to produce the effective results that you can, right? It's a very ambitious project, but I think they're making some headways into that. So that's kind of an example of that. So I said the applications are innumerable. So, and then the field is wide open. So for anybody that wants to get into it and become a contributor to that, I think here is the opportunity in front of you.
Thank you very much. For the questions, then we'll address at the end of this particular session. So next, we'll be going on to keeping up with science in the imaging section with Dr. Prompthorn. And I think Shelley, I'll hand it over to Shelley, who will be doing the introduction for this session. Thank you.
Thank you. So Dr. Suksaranja is going to talk to us next about what's new in imaging. Dr. Suksaranja is an imaging cardiologist and clinical assistant professor of medicine at the University of Iowa and Iowa City VA Medical Center. He completed his cardiovascular medicine and advanced cardiovascular imaging fellowship from the University of Utah. He is passionate about helping fellows achieve the educational goals they need to succeed. And his research interests include or focus on cardiac MRI and clinical outcomes in atrial fibrillation. When not working, he enjoys reading and spending time with his family. Thank you, Dr. Suksaranja.
Thank you, Shelley, for a kind introduction. This is my extreme privilege to be here in this session. And a great pleasure to present what happened in the imaging during the last couple years. Let me start here quickly. I have no disclosure to this talk. So for the talk today is not aiming for the comprehensive review of what happening, but rather show you what's out there during the last couple of years. And a lot of what we do as an imager is to provide diagnosis and risk stratification to guide the therapy and management. So the data that I will show you would gear toward that direction. So we involve multiple specialties, and with limited time, I will try my best to fit all the topics in. And first and foremost, which is unavoidable, and a lot of publication has been out from COVID eras, including imaging. So I'm just going to touch base a little bit on that. Hopefully it's not redundant on what you guys already hear. And also going to touch on the other topic as well in terms of other subspecialty. So I'll start with COVID. So this is the paper that come out kind of guide us on how we navigate the imaging service in the midst of COVID pandemics. And basically this is the emphasis on balancing the safety of patient care as well as optimizing the test selection. So we mainly emphasize on the safety of patients and imaging team, and basically testing the COVID status of the patient, as well as provide the appropriate PPE for a healthcare provider, as well as optimize test selection, maximize clinical benefit, minimize risk, and reduce the resource utilization. So in terms of balancing the safety and patient care, basically we proceed with the general precaution with the hand hygiene, social distancing, as well as putting masks and limited visitors that come to the labs, especially in echo lab. And in terms of procedures with the TE, we have to provide the appropriate PPE used for the test being performed. In terms of choice of cardiovascular testing, we have to look at the test individually and look at for appropriate testing for each test, as well as thinking about the alternative tests with similar accuracy and have a less concern in terms of safety for COVID. This is just to show you the exposure risk and need for PPE during cardiovascular imaging, the COVID eras. And basically, TTE is a first-line imaging test that we do, and echo tech need to get a close contact with patients, and they need appropriate PPE for that. And basically, at least surgical mask, face shield, and glove is needed. And if those technicians need to go in and do some scan with the COVID patient, they need the gown as well in order to fully protect it. In terms of TE, which is aerosol generating procedures, the N95 and N99 mask and face shield is required, or you can use reusable PEPA to replace those. In terms of imaging of choice, cardiac CT has been shown to be very useful among the pandemic, COVID pandemics, which is CT can be used to rapidly evaluate multiple forms of cardiac disease, as well as able to identify non-cardiac cause of chest pain, can also help in terms of expedite discharge from the ER, as well as in some case can help with evaluation of intracardiac thrombus in the case of precardial. And it can also be used to assess the pulmonary finding in the patient who is high risk for COVID. So in terms of multimodality imaging in the patient with COVID who may have cardiovascular complications, this can be simplified as a 4-case scenario. First case is patient who come in with chest pain and abnormal EKGs. If the patient have a clinical EKGs and suspect ST elevation in my patient should be directed to invasive angiography. If the suspicious equivocal for acute coronary syndrome, echocardiography should be first imaging test, and coronary CT angiogram may be used in the patient with no known coronary artery disease. And if the patient has CAD, stress test can be helpful to further risk stratify the patient. In the second case scenario, if the patient have hemodynamic instabilities, echocardiography can be helpful in terms of assessing the left and right heart failure, as well as assessing if the shock is come from cardiogenic or distributed. And also sometimes can give some fluid to patient and pulmonary embolism or not with the RV strain. If the patient have new left ventricular dysfunction, again, the first line imaging test, echocardiogram, can be helpful in those situations. And if there's some concern about ischemia, coronary CTA can be done. As I mentioned earlier, it's fast and efficient in terms of rule out ischemic etiology of LV dysfunction. And if there's some concern about myocarditis, again, cardiac MRI can be used. In the fourth case scenario, if in the subacute and chronic phase of the patient with COVID, our imaging tests can be done at the time with less concern about infection, contagious part of COVID. So in that case, especially the patient with abnormal echocardiogram when they are sick with COVID, so the follow-up need to be done in order to make sure they recover, or if they have any progressive disease. For example, myocardial scar can be assessed by cardiac MRI, and also the test can be done to assess if there is any consequence from venous thromboembolism. And this is just to show you the systematic echo study, basically looking at the patient who hospitalized with COVID-19 infection. About a third of the echo that was done have a completely normal echo, but 2/3 of them, and most commonly we find that patients will have some RV dilation or RV dysfunction, and just only 10% of them have RV systolic dysfunction. In the setting that patient with COVID who have troponin positive or sign of myocardial injury, kind of in the same number and ballpark that if you do echocardiogram, approximately 2/3 of them gonna have some abnormalities. And again, it just showed the same information here that RV dysfunction is the most common finding, and a little bit more common LV systolic dysfunction, up to 20% in this patient. And it has shown that patients who have COVID and myocardial injury, if they have abnormal echo, they have worse outcome compared to patients who don't have any echo abnormalities or don't have any myocardial injury. And if and you can see that is an independent predictor of the in-hospital mortality. If a patient who have COVID and have cardiac injury with echo abnormalities, compared to without echo abnormalities, they don't have significant association with mortality there. So, and again, echo is helpful in terms of assessing RV function. And in this study, basically looking at the patient with COVID who have an echo and looking at RV, specifically RV dilation and RV dysfunction. Almost a third of them have RV dilation in this COVID patient, and 15% of them have RV dysfunction. And as you can see here, the patient with RV dysfunction or RV dilation have a worse outcome compared to patient with a normal RV function or no RV dilation. And this RV assessment on the echo also give an additional risk stratification on top of the cardiac marker troponin here. In terms of assessing RV function, you can do a lot of things, but one of the things that has shown to be the most accurate in terms of predicting in hospital mortality, and in this study, it showed that right ventricular longitudinal strain has been shown to provide a better accuracy compared to fractional airway change and TAPSEs assessing RV function in terms of predicting mortality. As you can see here, that patient with RV longitudinal strain less than -23, they have a worse outcome compared to a patient who have normal RV longitudinal strain more than -23. And the echo has, doing an echo, the information that we have, it has shown to impact the treatment. Almost a third of them, when they have echo data, it can impact the specific therapy for patient with COVID or hemodynamic support or changing the level of care. So even normal echo, it has some implications. So echo is really helpful in this COVID management with overlapping cardiovascular disease care. So you already heard a lot about ATHLETE, but I just want to show this study just to emphasize the role of cardiac MRI in terms of diagnosing myocarditis. And basically in this study in ATHLETE, before return to play in Big Ten study, and UCF Iowa is part of it, and basically show that using the T2 mapping, which is related to inflammation or edema, or LGE, which again, it can show you increase of fibrosis or edema sometime if in the face of acute inflammation. It can improve the detection rate of myocarditis. And in this study, it should show that if you do cardiac MRI on all of the all-comer in terms of athlete before they go back to play has shown to improve the detection of myocarditis almost 7-fold from 0.3 to 2.3%. Moving on to coronary artery disease, basically, this just to show you the benefit of coronary calcium in terms of further re-stratify the patient. And in this setting, basically aspirin, the role of primary prevention for atherosclerotic disease is unclear in the intermediate risk populations. And as shown in this study, basically, as you can see that the higher the calcium score, and they stratify by no calcium score, 1 to 99 and more than 100, the higher the calcium score, the higher the bleeding event as well as ischemic event. And aspirin is clearly benefit in the patient who have high cardiovascular ASCVD risk more than 20%, and not in low risk or intermediate risk. Coronary calcium score may be helpful in terms of identifying the patient who may be benefit from aspirin for primary prevention if they have low bleeding risk and if they have a high calcium score more than 100 in terms of intermediate risk population. If they have high risk and they have low bleeding, high risk ASCVD risk, but low bleeding risk, aspirin is clearly benefit there. But the patient with high bleeding risk looks like aspirin is not indicated in this setting because they always provide net harm in terms of bleeding over the ischemic prevention. In terms of coronary CT angiography, has been this part of the verdict trial, basically sub-study looking at cardiac CT angiography in the patient with NSTEMI. And basically they are testing to see if CT coronary angiogram is going to be able to exclude, rule in or rule out coronary artery stenosis that obstructive. In this case, they define as more than 50% stenosis. And basically it's shown in this study that CT coronary angiogram in setting of NSTEMI is able to provide a high negative predictive value, almost 91%, with sensitivity of 97% if it's negative, and also is provide a positive predictive value of 88% in setting of positive CTA. That is kind of correlate with invasive angiogram. And it just showed you that here in the same study, same researcher group, basically comparing the prognostic value of identifying patients who have obstructive disease, more than 50% stenosis. There's a curve separation between obstructive or non-obstructive disease, and CTA and invasive coronary angiogram is kind of similar. So basically it's provide a similar prognostic value compared to invasive angiogram in the setting of NSTEMI. In terms of valvular disease, cardiac MRI can be used to identify the diffuse myocardial fibrosis by using a T1 mapping. And basically with the contrast, gadolinium contrast injection, you can calculate the extracellular volume. And in this study, it showed that in the patient with aortic stenosis, diffuse fibrosis or the marker of elevated ECV has been shown to be predictive of all-cause mortality as well as cardiovascular mortality. And in this study, kind of same researcher kind of looking at machine learning algorithm, identify the markers of cardiac MRI, and they are able to identify 4 cardiac MRI markers, mainly looking at diffuse fibrosis with the ECV, as well as RV function, LV volume, and looking at delay enhancement, which is kind of a marker of the scar replacement fibrosis. So they are able to identify that if the patient have and able to form the score, if the patient have all of these risk factor markers from cardiac MRI, they have a higher risk for mortality. So it can be helpful and need to be further investigated if in the future. It can be helpful in terms of selection of patient who can have valve replacement or have a better outcome in terms of valve replacement early or not if they have a higher score. So for the CT here, it can be used to detect subclinical leaflet thrombosis, basically hypoattenuation leaflet thickening. And this study has been done because FDA kind of mandate CT study to understand the natural history of this finding and difference between transcatheter and surgical valve. And looks like the transcatheter valve early on at 30 days, look like they have a higher incidence of subclinical leaflet thrombosis. Interestingly, is up to 10% at 30 days and up to 24%. People with valve replacement have subclinical leaflet thrombosis, but there is a spontaneous resolution of 30-day. Approximately 54% of this patient at 1 year, the finding or thrombosis is gone, but there appears to be a new thrombosis that happened during that 1 year, about 21%. So this is kind of new information, and we still have to work on what to do with this finding. In terms of heart failure, there's in terms of imaging, there's a randomized trial using strain guide management for potential cardiotoxic cancer therapy. And basically, they randomize patients who are going to have anthracycline chemotherapy using strain guide surveillance or EF guide surveillance, and in order to trigger the use of cardioprotective therapy. And they are able to identify that people on the using strain guide strategy is able to kind of trigger and have more trend to use the cardioprotective therapy, including beta blocker and ACE inhibitors. And patient on the strain guide arms has less cancer therapy related cardiac dysfunction. So this is a kind of paper that just came out this year, and I think is still need to be worked on further if that gonna have any implication on the cardiotoxicity field or not. And this is cardiac MRI. Basically, we routinely use cardiac MRI. We use cardiac MRI in terms of diagnosing of cardiac amyloidosis, but currently we use gadolinium contrast in order to see if there is any enhancement pattern that suggests cardiac amyloidosis. But in this case, the researcher has shown that without the contrast, they are able to demonstrate ruled in or ruled out cardiac amyloidosis with the high positive predictive value and high negative predictive value up to 98%. And if the non-contrast T1 is in the middle, which is approximately 58% of population, the contrast may have to be used at a time. So, and with the high accuracy. So this last slide here, just to show you in terms of electrophysiology, this is the study that was trying to improve risk stratification of ventricular arrhythmia and sudden death in a patient with non-ischemic cardiomyopathy. Currently, the ICD implant indication is still EF less than 35%, which is doesn't really pan out in terms of mortality reduction. And this study was trying to see if using the cardiac MRI, identifying late gadolinium enhancement, are able to further re-stratify this patient a little bit better. And they come up with the new stratification algorithm using the MRI guided divided stratified patient to have scar or delay enhancement or without, and able to further re-stratify EF to less than 20, 20 to 35 or more than 35. And they come up with the new algorithm with the patient who is high risk, basically if they have LG positive and delay enhanced EF less than 35%. And if the patient is low risk, if they don't have LGE, and even though their EF is low, but more than 20%. So this is kind of coming in the last year. So I would like to thank you and stop here.
Thank you very much, Dr. Suksaranjit. That was an excellent update on the imaging portion of cardiovascular imaging. So we'll be moving on to the next topic, and in the meantime, we can address any questions in the chat box. So our next talk is going to be by Dr. Ernesto Ruiz. Dr. Ruiz is currently a clinical assistant professor with internal medicine in the cardiology department at University of Iowa Hospitals and Clinics. Dr. Ruiz pursued his medical school at University Lisandro Alvarado University in Venezuela. And then he completed his internal medicine and cardiology fellowship in Venezuela, and then pursued his advanced heart failure and cardiac transplant fellowship at University of Iowa Hospitals and Clinics. Currently, his interests include advanced heart failure as well as cardiac transplant, and he'll be providing us an update as part of this Keeping Up with Science session. So Dr. Ruiz, handing it over to you.
Thank you, Doctor, for the introduction, and thank you for Dr. Ashworth for the invitation. It's a pleasure to me to be here sharing this panel with this expert. My first question, can you see my screen right here? Can you
yes.
See it? Yes.
We are not able to see your screen. We are seeing your video right now. So.
Oh, see my video only? Okay, so how can I share this?
Yeah, man, we only see your beautiful face, not your screen.
So I disagree with you. It's not a beautiful face. I'm trying to change this to a better one. Okay, I don't have the option right here to change.
Oh, Dr. Suksaranjit, can you make sure you stopped your share screen? That way, maybe Dr. Ruiz can.
I think I already stopped it.
Okay, thank you.
Yep.
So I have here a speaker, and then I don't, when I go to views, I don't have the option as I was before to share my screen.
It should be the green button in the bottom. Ernesto.
Yeah, at the bottom of your screen, there should be a green button.
Okay. This one.
Yep, now
Can
it's
you hear me now?
Yeah, we can see it now. Thank you.
All right, perfect. So I'm going to try to talk about heart failure and what have happened in the last year to 2 years ago. And we know that since the last guideline for heart failure that we have new medication for that we can introduce as a guideline medical therapy for heart failure, mostly for the reduced ejection fraction. And since the Paradigm trial came in 2014, we have been using a little bit more the introduction of the sacubitril valsartan, the Arrhythmias, and most recently we have new evidence that the medication that we have been using for diabetes, like sodium glucose transporter 2, the SGLT2 inhibitors, are demonstrating benefit on patients with heart failure, either reduced ejection fraction, preserved ejection fraction. Most recently, this year we have 2 trials. the Victoria trial and the Galactic trial with vericiguat and omecamtiv. That we're going to talk a little bit later about those medications. But despite of this evidence that we have, and that can improve rehospitalization for heart failure and mortality, we are still facing a lot of death and rehospitalization for heart failure in the real world. And we know for this registry of CHAMP-HF that is here in the US that have been enrolling around more than 3,000 patients, this first publication in 2018 showed that, we are still underusing the guideline medical therapy for heart failure. And as you can see here, 59% of patients were treated with ACEs, ARBs. ARNI was barely introduced at that point in 2018 with 12%. And beta blockers in the 60%, and the aldactone or spironolactone on eplerenone were around 30%. But more concerningly is that we haven't not reached the high doses of recommended that have demonstrated that decrease mortality and decrease heart failure readmission. So as you can see here in the red one, less than 50% of the patient, or more 60% of patients were not in the high doses of either ACEs or ARBs. The same thing here for beta blockers and ARNI and eplerenone. So the same registry published later this year that once the patient is admitted for heart failure, we tend to change doses, and either we try to introduce guideline medical therapy for heart failure, we try to increase doses for those medications, and sometimes we tend to decrease the doses or either stop medication for guideline medical therapy. And then they have realized that when we do that, the mortality, all cause of mortality in those patients, when we follow up in the future, increase the risk for mortality. So as you can see right here, when we compare the discontinuation, the escalation of patients with guideline medical therapy during that admission, increase the risk of mortality compared when we use maintain the doses or either increase the doses. And you can see here that actually was better when we introduced ARNIs or sacubitril valsartan in this particular population. So when they did cross the analysis of this new medication coming for heart failure, the emphasis with eplerenone, paradigm with sacubitril valsartan, and DAPA-HF with dapagliflozin, compare the conventional treatment that we have been using for years for heart failure, actually we were able to do better. We are able to decrease the mortality, the hospitalization for heart failure and all cause of mortality, comparing with the old treatment that we have for heart failure. So this year, we have an effort for the societies for cardiology and heart failure around the world. This is a update of the consensus expert from the ACC. We have the guidelines for the European Society of Cardiology, and more recently here, this new definition of heart failure among different societies around the world. And in order to try to understand why, even though we have new medication coming, new data is coming, we still are facing a lot of complications with patients with heart failure, regardless of the ejection fraction. So the new definition that I'm trying to see or propose in my mind is that this patient with heart failure stage C, where they already have symptoms, we need to try to introduce guideline medical therapy in terms to recover the ejection fraction or reverse the problem the patient may have. And actually we have some data that we need to maintain that the medication, even though we have been able to recover the ejection fraction. And the advanced heart failure, stage D, is not only when the patient have symptoms at rest, when your patient is having severe symptoms or recurrent admission for heart failure, and you haven't been able to increase doses for guideline medical therapy, this might be a sign of that your patient is in advanced heart failure and probably might need a referral for a center where they have the capability to offer advanced therapy as a transplant, mechanical support, or probably offer them palliative care because the patient is not a candidate for those kind of therapies. So when we compare these two guidelines, we have in top these, for example, the European guidelines, they have these 4 new medication that have to be introduced for heart failure regardless. They don't have any preference for that. We need to just introduce all of them. And from the ACC, we can see right here that they prefer actually when the patient is in ACEs or RVs trying to switch the patient to ARNI. Since we have the evidence for that, and then we can continue trying to introduce the rest of the medication. Depend of all the patients are not the same. We need to individualize the patient and see when we can introduce the rest of the medication. For example, we are missing here the hydralazine isosaride that we know that are better in patients with African American population. And the ivabradine is a good tool with patients with heart failure, maximum doses of beta blocker that we cannot maintain the heart rate as the goal that we want. So we can introduce the ivabradine. So this new expert, consensus of the expert are trying to see what are the problems that we have or we're facing and why we're not successfully introduced guideline medical therapy and actually reach the goals of the doses of those medication. And they have recognized some problems right there. So we know from the titration trial that was published after the paradigm trial, this is 2018, they were trying to see what was the problem in terms of the blood pressure. Remember from the paradigm trial, one of the complications with hypotension was hypotension. And then they were comparing to see if using a conservative way or more aggressive way to introduce the sacubitril valsartan, and those patients may change or may have some benefit. And then they decided just to try to reach the maximum doses in 3 weeks compared to 6 weeks. And as you can see right here, when your blood pressure actually is high, you probably will not see too much difference between the outcomes right here, which is reach the high doses of the sacubitril valsartan. But when your patient is on borderline blood pressure, remember that the cutoff to start this medication is systolic blood pressure above 100 millimeters of mercury. Then you can see that if you are more conservative, trying to titrate the medication up to 6 weeks, probably you can successfully achieve that doses, and the patient can tolerate better the introduction of the sacubitril valsartan. Then we have the Pioneer HF, which they were trying to see if we can introduce the medication earlier when the patient is admitted for acute heart failure. So they decide to put as a primary outcome, not clinical outcomes right now. They decided just to put if you can decrease the NT-proBNP as a marker of remodeling of the left ventricle or of the heart. And then they successfully decreased the NT-proBNP in the first week. But remember that these patients were stable. The blood pressure was about 100 millimeters of mercury and were about to be discharged. So basically this medication was introduced right after the patient was stabilized for the acute setting. So we are not treating acute heart failure with sacubitril valsartan, but was safe to introduce the medication when the patient was about to be discharged. And actually we were able to decrease the rehospitalization for heart failure when we did that, not mortality. And then you can see right here that one of the strategy that they use to try to reach the high doses of the medication was targeting the blood pressure. If your blood pressure is going up, you might be able to increase the doses. If your blood pressure remain low or is not changing, probably you need to be a little more conservative and delay or wait a little bit more before you're going to be able to try to reach high doses of the your medication, either the ACEs or sacubitril valsartan. Then we have the transition study, again with sacubitril valsartan, and they were trying to see if either introduce the medication pre-discharge or introduce the medication post-discharge, it may have some difference. Remember that the previous study, Pioneer, was here in the US only, and this study was among patients in Europe that include more countries. So we have more patients right here. And there was no different. When the patient the medication was introduced before or after, actually there was no different. So it was safe to introduce the medication before. And then, but if you can see some tendency that is better, probably start the medication a little bit later. However, or the predictors that you can have right here to see when you are going to successfully reach the doses is when your patient are not so old, less than 65%. Your kidney function is stable. Your blood pressure actually is very good, at about 120. The novel heart failure is probably one of the predictors that you successfully might reach guideline medical therapy. History of hypertension and no atrial fibrillation. And if you're able to start at least the intermediate doses of the sacubitril/valsartan, the chances that you can reach the high doses is higher. Obviously, it's going to depend on the blood pressure and how frail is your patient. But as you can see right here, the majority of the patients were started on this medication right before discharge or the day after they was discharged. So probably it's this a few days of difference. So I don't think that we can compare this as a pre-discharge or post-discharge. We have this live trial that was recently presented in the ACC, I think, in 2021, and was a negative trial in patients with heart failure, acute heart failure. So they were trying to introduce the sacubitril/valsartan in patients having symptoms. Actually, the patient were having more problems with hypotension and hyperkalemia. So far, this study was stopped earlier, and because the pandemic last year. And so far, we cannot say that we can use this medication as an acute heart failure in the phase when the patient is decompensated. So then we have the Paragon trial for sacubitril/valsartan in patients with heart failure and preserved ejection fraction, and ejection fraction was above 45%. And this study was not strong, demonstrating that you can reduce readmission or mortality with sacubitril/valsartan in patients with heart failure and ejection fraction above 45. But it was close. So some post-hoc studies showed that potentially if the patient is recently discharged from hospitalization for heart failure, might have some benefit rather or compared if the patient is far away from the admission of heart failure. So, and also recently this year, after the Paragon trial was reviewed, and FDA decided to approve that those patients with preserved ejection fraction, let's say that the ejection fraction is above 45%, we still have 5% between 40 and 45 that we don't know, but probably that kind of population that is mid-range or mild decreased ejection fraction might receive the benefit as well to use sacubitril/valsartan or guideline medical therapy for heart failure, and the cutoff probably is going to be the 45 to 50% or less than 60%. So the
Dr. Ruiz, sorry to interrupt. Just in the interest of time, a reminder, we'll have to move to the next talk in a few minutes, okay?
Okay.
All right.
So SGLT2, let's move a little bit fast. The Emperor trial was a study with SGLT2 in patients with reduced ejection fraction. We were able to decrease the readmission for heart failure, and actually we were able to improve the kidney function. Not in the first weeks, actually the kidney function get worse, but in the long term, the kidney function get better. And actually the benefit you can see introducing this medication in patient with stable heart failure or outpatient phase. So we were able to see the benefit of that, and you can see that it was prolonged in the time. And also you can see the improvement of functional class in the first few weeks. So the benefit was regardless of the use of other new medication for heart failure. You can see here, it was regardless of the use of Arrhythmias and MRA. So this study is the same medication, empagliflozin, and the acute phase of the compensated heart failure. Again, is not a treatment that they use for acute heart failure, was in the phase when the patient was stable during the acute decompensation. And it was safe, no complications. And the secondary outcomes of the incidence of hospital worsening and death and hospitalization actually was better in the future, but not in the primary endpoints that they have for this study. We have this year the publish of the Emperor Preserve trial that they used empagliflozin for patients with heart failure and ejection fraction above 40%. and we were able to decrease the rates of hospitalization for heart failure, and then there was not difference between the mortality. And this study was published this year, and again, ejection fraction was above 40%, and the benefit was around patient with 40 and 60%. With the patient were above 60%, probably the benefit it was not significant. Again, the benefit was early in the first few weeks that we started the empagliflozin in patient with ejection fraction above 40. And this is the new trials coming basically in the settings of the acute heart failure that we don't have too much evidence if those patients are safe to introduce the new guideline medical therapy and how. When we compare both new medication that we have, the SGLT2, actually there is no difference regardless if the patient have diabetes or no diabetes. And one tip or tips that we can use to introduce this medication are if the patient is euvolemic, probably we need to decrease or stop the loop diuretics that we're using. If your patient is still volume overloaded, we can decide if you keep it or decreases a little bit. And definitely if the patient is hypovolemic, it's not a good idea to start at this point. In regards to the kidney function, empagliflozin, it was safe to start when the eGFR was about 30. We have evidence for the dapagliflozin when the eGFR is about 30. And then a caution in patient with chronic urinary tract infection and peripheral vascular disease. Moving forward, patients, the monitor of the pressures in the lungs. We have the previous study, Champion, that showed that we can reduce the rate of hospitalization. We have this new study, GAT-HF, published this year. As you can see here, they introduced more patients with function class 3 and 2. The previous study was only 3. And as you can see, the patients were not so decompensated. You can see here, the wedge pressure was around the 17s. So the study was negative at the beginning. They were not able to demonstrate the composite of all mortality, heart failure, and hospitalization. But when they did an analysis pre-COVID, the study was positive. And you can see here that the amount of guideline medical therapy of those patients were actually better compared to the previous study of Champion. So basically, following the patient with heart failure with this technology is good if your patient is compensated, but where it's going to decrease the rate of the compensation of heart failure is your guideline medical therapy. We tend to use more medication when we are following the patient with a PA catheter, and that's why probably we're going to be able to, in the future, to see better results of this technology. We have 2 new medications, the Virosy-Watt with the Victoria trial. Remember that this medication is competing with guideline medical therapy that we have so far, and we were able to demonstrate that we can decrease death and rehospitalization for heart failure introducing the Victoria, the Virosy-Watt. We don't know for sure in the real world how can we use this, because our first therapy that we have did not include the Virosy-Watt, but I think in the future we're going to see, we need more experience to see when and how we can introduce the Virosy-Watt in patients with heart failure and reduce ejection fraction. Omecamtiv is the new medication, is not FDA approved as well. The study was positive for the primary composite of cardiovascular deaths and hospitalization for heart failure. This medication is a myotrop. You can increase the contractility of the myocardium. And then again, we don't have real experience of using this medication. We don't know how and when we can introduce, but again, these new medications are probably reducing the risk residual of patients with heart failure. So we're going to see in the future more, or I'm expecting that we're going to see better results if we're able to introduce guideline medical therapy for our patients. When we don't need to use this approach, obviously patient with the life expectancy is less than 1 year and you are facing the end stage of heart failure, or patient with inotropes or going to hospice. When we need to refer the patient for heart failure specialist, I will say that when your patient is, you're not able to reach the high doses of the medication, because hypotension, worsening kidney function, or your patient is not improving, probably it's going to be a good idea to send the patient to the heart failure specialist, not because we're smarter or you're going to have better medication. It's because the team behind the physician is bigger, and probably we're going to be able to follow this patient closely and offer probably advanced therapies in the future if we're not going to be able to reach or introduce guideline medical therapy. Again, this is a final slide. We are comparing here that in meantime, we're moving forward. We're using more and more guideline. The percentage of patients are in more better doses and medication for heart failure. So it's going to be hard to demonstrate good outcomes in the future. But again, this trial, Victoria and Galactic HF, were able to demonstrate some benefit on the heart failure rehospitalization, competing with this good medication for heart failure. Thank you, and I'm happy to answer any questions.
Thank you, Dr. Ruiz. We'll go to the next talk, and if you come up with questions, maybe after the next talk, we'll hand over. We'll discuss any questions that come up accordingly. So next talk is going to be Dr. Panache, who will be giving an update about interventional cardiology. I'll hand it over to Shelley, who will be doing his introduction.
So Dr. Sid Panache is an interventional cardiologist. He completed his structural fellowship at Mayo Clinic, and he has been a clinical associate professor at the University of Iowa for about the last 5 years. He's the program director for structural heart disease at the university, as well as the fellowship program director for interventional cardiology. Thank you for speaking for us today, Dr. Panache.
Thanks, Shirley. How much time do I got, Ketan?
How much time do you want, Phil?
I was like, he was stopping Ernesto. I was like, should I go fast? All right, alrighty, so you guys can.
Yes, we can see.
Let me see. All right, gotta switch, right? You guys are seeing my presenter screen right now?
Yeah.
All good?
Yeah, we can see it. Yeah.
Perfect. All right. So thanks for having me, Mahi, and everyone, Ketan, and all the Shelley, everyone who's involved with this. You know, heard a few talks. Great. So I hope I can give you a little bit potpourri of what is up in interventional cardiology. As in cardiology, you would all know is in interventional cardiology, especially, there are more papers published in aortic valve disease in a month, alone, and then probably in whole of other specialties. So it's crazy. So I mean, it won't do justice for 20 minutes, but I'll just try to give you a flavor of what's going on and what we're doing at University of Iowa, and so hopefully that'll be helpful. So got nothing to disclose, just an outline. So we'll just talk about a little bit about, we'll touch some points on 3 of the major valve disease that we specifically see in our adult population. I'll touch a little bit about left atrial appendage occlusion. Dr. Lucky Reddy already did a fantastic job on that. So kind of crosses path between EP and interventional. So I'll talk just a little bit about it, just to kind of give you a flavor of what we're doing at the University of Iowa, what we're involved with. And then we'll talk about just a few topics. Again, it's so much to cover in piece, in the interventional world. So I just thought about like maybe some of the things that might be helpful for the fellows. We've got some astute audience, so you probably already know a little bit about this, but I'll just touch topics that have importance for everyone in cardiology, not just interventional. So starting off initially with aortic valve disease, I present this, which is now a couple of years old, but just to bring everyone up to speed, aortic valve that started off, initially got approved all the way back in 2013. Actually 11, I'm sorry, 13 was MitraClip. 11, all the way back in 11 has, for high and prohibitive risk surgery patients, is now FDA approved for all risk categories. And this was the last nail where data from both the SAPIEN and the core valves was presented. The SAPIEN primary composite endpoint was included both death, stroke, and rehospitalization, which resulted in actually superiority of TAVR at 1 year over surgery, primarily driven by low rehospitalization rates. The core valve group had non-inferiority statistically because it did not include rehospitalization. So their primary composite endpoint was death and disabling stroke, but they were able to achieve non-inferiority, even though, if you had rehospitalization, you get a very similar result. So, again, at 1 year, at least, both core valve and the SAPIEN, the two commercially available valves, were able to show non-inferiority or superiority with respect to their primary composite endpoint. So it's FDA approved for every risk category. Now there are nuances to all of this. I think the one thing that we have to remember in this is that when we refer patients, even though it's approved for everyone, you have to realize that these low surgical risk patients, the median age was around 70 years. So when we're talking about these 40, 50-year-old bicuspid patients, very young, low-risk patients, these patients weren't included in these trials. So always be wary about this. We try to, when we get patients referred and they're really young and low risk, people realize they come in with expectations, and I'll be really honest, you'll agree that nobody wants to get their chest cracked open. So if you have minimally invasive options, people always want that, and they would want you to do that, but we have to be realized as we have to be cognizant of the fact that these trials did not include that. So we don't know really what would happen if we started doing TAVRs. We don't know, we don't have full data on how these valves do 10 years from now. So that, just keep that in mind. But again, that's where our team comes in. We have a collaborative approach with our great cardiologists, our surgeons, and, group as interventional cardiologists. So we try to do that as a heart team approach. So that's where it comes in. So what's the next step? Now we come over to asymptomatic severe aortic stenosis. Now this is a paper back in 2008 that was published out of Mayo Clinic, over 600 patients. This was more of an observational study where they looked at more than 600 patients. And they divided, they found about 120 patients that had no symptoms whatsoever. And so they just followed them, over the period of time, it's all the way out to 15 years. And so basically what they did was they saw their survival, and you see the worst survival is obviously in patients who are symptomatic and do not get aortic valve replacement. But even in patients that you would see the dotted line, if patients who do not have symptoms and you don't do aortic valve replacements, they fare significantly poorly than people who had no symptoms and still ended up getting aortic valve replacement. So these patients, all the way back in 2008, even from prospective data, we knew that, these patients, even though they don't follow in the guidelines, and, and when you read Braunwald's and, from the famous words of Dr. Braunwald's, we always have kind of shied away from people who are asymptomatic and, shied away from doing any surgical data, doing any surgery on these patients. But, we know that they don't do well if you don't do anything in them, especially aortic valve replacement, right? And so more recently, the recovery trial was published in NEJM, and this was a good trial that they followed these patients for a very long time. Again, 145 asymptomatic patients. They selected patients at the age of about 20 to 80 years. These patients were, again, with actually very severe aortic valve stenosis. So it wasn't the cutoff was 0.75 centimeters square, 4.5 meters per second of aortic valve velocity, and mean gradient of 50 or more. So they were very severe. So not just 40 and 4, but 4.5 and 50. So that was one caveat, but they were all asymptomatic, and they randomized these patients. So this is a randomized study where they randomized these patients to surgery or conservative care. And out to 8 years, the operative mortality or operative mortality or cardiovascular mortality was lower, much lower, 1% in patients who received surgical aortic valve replacement compared to 26% at 8 years in people who underwent conservative care. So, this kind of gives you an idea. This was, a very important trial, which shows you that surgery actually is, beneficial in people in asymptomatic aortic stenosis patients, and kind of lays the groundwork for further investigation into this asymptomatic population. Now, again, there's a caveat. As I said, these were usually very young people, 20 to 80 years. The median age was less than 60 in these. They were very young, healthy patients. And they chose very severe aortic valve stenosis. But the most important thing was that these patients were not subjected to any sort of stress testing. And we know that, there could be a lot of undiagnosed symptoms in patients with aortic stenosis. And so, taking on further, based on this, now the data that we have, this is the most current valvular heart disease guidelines that came out from ACC/AHA. You would notice that AVR, SAVR, or TAVI kind of gets similar recommendations in symptomatic aortic stenosis. If you've got asymptomatic aortic stenosis onto your right side of the screen, you see that if your EF is low, it's you could get SAVR or TAVR. And TAVR probably would get a little better recommendation. If you're getting other cardiac surgery, then you're just a no-brainer, you're going to get TAVR. And then basically in patients who have other things, you have a lower recommendations for SAVR based on data. We don't have data for TAVR at this point. And so where's that data coming out? It's the early TAVR trial. Most of your fellows and our faculty who's working here knows that University of Iowa is participating in early TAVR. We are randomizing and enrolling patients in the early TAVR trial. And what that is a one-to-one randomization of completely asymptomatic patients to TAVR versus clinical surveillance. And very important is that if it's just not based on what the patient says. Every patient who says that they're asymptomatic and agrees to enroll in the trial gets subjected to a modified non-protocol stress test. And if they only if they pass the stress test are they considered truly asymptomatic and go randomization. So that's the difference from the recovery trial, is that we are not only taking subjective evidence, but also objective evidence via a stress test before these patients get randomized. So yes, this is ongoing. So please, if you have asymptomatic patients with aortic stenosis, please consider sending them to a structural heart clinic for randomization. Next, what's bicuspid valve? Why this is important? Because none of those trials, as I initially mentioned, enroll those younger patients, which mostly have bicuspid valves. So, the bicuspid valve was excluded from all the partner and the core valve trials. So, most of them didn't have, they never got randomized, but we do by TAVR and bicuspid. So what's the data? So the data is, if you just look up the data, there is so much data, and even our group has published on this, and I'll go over this in a couple of slides. But recently, this year, 3 big studies got published. One from Dr. Mucker's group, which was basically a registry from STS and TVT, where they showed that people who got they basically compared TAVRs in bicuspid and tricuspid valve from the STS TVT registry, and they found absolutely no difference between the 2 groups in terms of mortality and or stroke. So there's no randomized data between TAVR and SAVR, but what we've done is we've seen whether you do in TAVR in tricuspid or bicuspid anatomies, is there any difference? And these guys found that all the TAVRs that have been done, they did a propensity match on these. They had more than 3,000 patients after propensity matching, and they found absolutely no difference in terms of mortality, as well as any incidence of stroke in these patients out to 1 year. Then last year, Dr. Forrest's group had published this data out of their core valve, low-risk core valve study at 30 days, where they'd shown that at 30 days, in about 50 patients that they had enrolled at that point, that there was, very low risk of stroke, mortality, or any other of the other, adverse events in this patient population that they enrolled. And again, this was specifically low-risk patients with bicuspid aortic valve stenosis, not 70, 80-year-old patients with, other comorbidities, but, young, low-risk patients that they did, primarily core valve on. And as you notice, the only major thing is, the permanent pacemaker requirement is as you would expect, a little higher with core valve itself, but in bicuspid is about 15%. They came out with their 1-year data at the TVT this year, and then did a full-on comparison between. Again, this is not a randomization. This is a prospectively enrolling study. So they, at 1 year, they show that there was no significant difference in terms of death, mortality, bleeding, pacemaker implantation, rehospitalizations, or any other endpoints between people who got TAVR for bicuspid versus tricuspid anatomy. This data is from the other valve that we know, the SAPIEN valve, that was presented by Dr. William and Webb's group from the Partner 3 bicuspid registry. Again, the Partner 3 did not randomize trial, but they had a registry for people who had bicuspid valve who were getting the SAPIEN valve. And they basically, again, showed that the composite endpoint of death, stroke, or rehospitalization was no different, again, up to 1 year between people who received TAVR for tricuspid or bicuspid valve. So should we start doing, bicuspid and all? Well, the FDA does approve it. The FDA approves both the core valve and the SAPIEN valve for bicuspid anatomy, even in low-risk patients. So yes, you are an FDA, you do have FDA approval for bicuspid valve anatomy. But again, we're physicians, we have to look at different things, right? We just don't follow guidelines. So what do we know from, different registries? So again, it's a topic all in its own. I could give you a 30-minute hour lecture on this, showing me a lot of my studies. I just wanted to show you the big, random prospectively enrolling studies that have been done. But what we do know is that, yes, it's feasible and it's safe if you select your anatomy right. The 1-year mortality is very similar to what we've seen from surgery in these patient groups. As you saw, most of them was less than 1% and tricuspid valve anatomies. If you look at studies that have compared newer generation with older generation valves, we know that the valves are improving as we speak, the TAVR valves, I mean. And if you use CT scans and you actually choose your anatomy right, and what do you mean by anatomy is that, these valves, bicuspid valves, are much more calcified. And when we talk about these Sievers type 1 classification, the raphe are heavily calcified, and then sometimes they won't adapt to the circular anatomy, or they won't fracture. So the valve won't expand, you won't get good hemodynamics, or there's a chance of annular rupture. And so, CT scan is very important for your sizing. They're not usually sometimes sized according to the tricuspid valve, which is again a topic on its own. And so, we saw that in the 3 studies that I presented, there's a very low risk of stroke, but we've done a meta-analysis of these studies. There have been other meta-analysis published. There have been, other observational registries. And so there's different mixed data where there is maybe a signal for higher risk of stroke. Again, that would be very, it'll be typical if you think about it. They're much more heavily calcified, and when we're doing these valves and these very, very heavily calcified bicuspid valves, you could imagine that because of the calcification, there is somewhat of a little bit higher signal of, stroke. There is a little higher risk of permanent pacemaker implantation compared to surgery, which is true for tricuspid valve anatomy as well, but is a little more true for bicuspid. These, again, are not panning out in these low-risk studies that I just presented, so things are improving. There is low, but a little bit, again, higher risk of annular rupture, so that is very important when we actually look about what kind of anatomies are you going to be doing. There is, again, a little bit higher risk of mild paravalvular leak than tricuspid valve anatomy or surgery. So, you have to consider all of these. Is where I go back to the first green boxes. You have to plan these out on the CTs, pre-plan a heart team approach. We talk to our surgeons. And again, this is my bias, but, when people are 40, 50 years old, or even 60 for that matter, and they've got bicuspid anatomy and they can have easy surgery, low risk, I'd rather, send them to surgery. But when they start getting into their 60s with, some comorbidities and they're a little higher risk, and then especially when they start getting into their 70s and their anatomy is much more suitable for a TAVR, then yes, I don't see any reason for them to get not get a TAVR. So that's where, like, heart team approach comes in. And so, we always end with saying that, we need more studies, randomized trials, but to be honest with you, there is nothing on board, and I'm not really sure with FDA approval coming in for TAVRs and all these prospective studies showing that TAVR would work okay in suitable anatomies, that we're actually going to get a actual trial in these patients. What's next? What's the other thing? Cerebral embolic protection. I'm not going to present the sentinel data that came out from Dr. Kopari's group, the actual trial that was done, which was pretty much negative, but it did get an FDA approval for cerebral embolic protection. The uptake of this technology has been a little bit, varied across the country just because the data wasn't there. This was the biggest study out of, again, the registry, the combination of different registries, the Medicare data that came out from Dr. Cohen's group. They basically showed that in over 120,000 patients from almost 600 sites, once they did not see any difference in terms of stroke between using and not using in their initial primary evaluation or statistical analysis, but once they did a propensity scoring based model, as you would see right here, I've circled it out, there was a statistical significant difference favoring cerebral embolic protection. Again, this is an observational registry, so we don't have any randomized data. So how to get a randomized data? We have ongoing protected TAVR trial. So we are actively enrolling people at University of Iowa as a part of this protected TAVR trial, which is being, again, nationally run across multiple sites. And what we're doing is, if patients agree, we are basically randomizing these patients, all comers, no exclusion criteria unless their anatomy is not favorable for putting in a cerebral embolic protection of the sentinel system. And we're basically trying to see whether this reduces the peri-procedural risk of stroke. So this is an ongoing trial, again, one of the trials that we're participating here at the University of Iowa. All right, so shifting gears to mitral valve disease, I'll start moving a little faster. This you already know, I won't go into details. This is the main MitraClip, or primarily the one approved transcatheter therapy that we have. I won't go through all this data again for the sake of time, but we basically know that there are more than 1 million implants worldwide since its approval back in 2013 for degenerative mitral regurgitation. The COAP trial, just wanted to touch base on the fact that this was, one of the landmark trials, as you all know, that basically showed that people on optimal medical therapy, again, within the nuances of following the COAP criteria, that once you actually MitraClip was, significantly reduced mortality, hospitalizations, named the endpoint, and basically it was favorable in terms of MitraClip. The most important thing was the number needed to treat to get a mortality benefit at 24 months, or primary composite endpoint at 24 months was 5.9. And those, Ruiz presented the heart failure data. This is better than any beta blocker, ACE inhibitor, anything out there. I mean, this is like almost unheard numbers to treat at 24 months. So, I mean, this was, one of the landmark trials. Again, you have to, follow the COAP criteria very strictly. I mean, these people were on optimal guideline-directed therapy, had CRT if they needed and stuff. And so, they did benefit eventually. And so the current valvular heart guidelines actually give MitraClip a higher recommendation in these patient population. And so what, I keep saying that there were the COAP criteria. So basically in patients with chronic severe secondary MR due to LV systolic dysfunction who have persistent symptoms, tricuspid edge-to-edge repair, which is the MitraClip, is reasonable in patients with an appropriate anatomy, which means that, you have EF between 20 to 50%. So we're not talking about burnt out ventricles with an EF of 5 or 10%, and LV and systolic diameter of less than 70. Again, not a burnt out, very large ventricle, and a PS systolic of less than 70. So, once you meet these criteria, you're not dealing with burnt out again, people who are going to need advanced cardiac therapies or LVADs and stuff like that. this gets a 2A recommendation, and while the surgery in similar patient population will get a 2B recommendation. The surgery gets 2A recommendation only if you're going to do surgery for some other things. The reason for that is we don't have any trial data to say that surgery works in these patients populations, and these are high-risk patients to begin with low surgical risk. And a very important thing for everyone to realize is that you actually do not need FDA approval came in, and you do not need a surgeon to say that the patient's high risk. There's no mention of any risk category in these patients. Whereas as in degenerative mitral valve regurgitation, what you need is people who are high risk for surgery. So while in secondary MR, it is a heart team approach involving heart failure team and obviously interventional cardiologist, but the heart failure team, which has to determine optimal guideline-directed therapy. And once they determine that, it's the responsibility of the interventional cardiologist, obviously, the interventional cardiologist, to determine that they fit the COAPT criteria, that they're not burnt out, and the anatomy is suitable, and you can proceed. So these are not just high-risk surgical patients. What's next? Repair MR trial after a million trials. Now this is again an ongoing trial. We are not participating in this trial, but basically this is an ongoing trial across multiple sites in not just US but Europe as well, where now the MitraClip is being compared. This is back to the Everest days, where we're basically comparing MitraClip to surgical repair in patients with appropriate anatomy in both intermediate and high risk. So actually pretty much intermediate risk, I take my words back, not high risk, but intermediate surgical risk. So we're kind of moving along the aortic pathway where the MitraClip system is now going to be compared in lower surgical risk patients or intermediate surgical risk patients. We are participating in University of Iowa in the other version of the MitraClip, which is the clasp, which is a Pascal device from Edwards. There are little, small differences between the two edge-to-edge repair devices. So this clasp 2D and 2F is a two-arm trial where we are randomizing people in either degenerative or secondary or functional MR. So both of them will be compared, the Pascal device will be compared to MitraClip. If the patient has degenerative MR, the patient has to be non-surgical or high surgical risk. If the patient is secondary MR, then again, it's randomizes against MitraClip, but based on the COAPT criteria where the patient is on optimal medical therapy. So we're not comparing against surgery, we're comparing against MitraClip in non-surgical degenerative MR or people on optimal medical therapy in secondary MR. So this is an ongoing trial again. If you have people, please do refer them, obviously. And there are some benefits that we discuss. Some other studies that are going on. There's a 10-9 valve, which is a transapically inserted valve. It's through transapical route with an apical tether and a locking pad. It's multiple studies or multiple, it's an ongoing randomized trial that is comparing this valve to surgery. And there's also the Intrepid Medtronic valve that is being also, this is a transapical valve, but a transeptal route has been developed, and an ongoing again trial, the Apollo trial, that is comparing. I take my words back. This Apollo trial is actually comparing it to optimal medical therapy rather than surgery in these patients, high surgical risk patients. So there are these valve replacements that have ongoing trials as well. And I'm not going to go through all of them. I had a huge, but this is the amount of repair and replacement technologies that are ongoing right now. So shifting gears to tricuspid valve disease, if you thought that the aortic valve is a highway like that, the mitral valve, the tricuspid valve is like this. So tricuspid valve gets way more.
So I'm sorry to interrupt, but maybe in the next 5 minutes, you might have to wrap up. And then
all right, well, we'll limit it to valvular heart disease then, I guess.
Thank you very much.
Yeah. So, tricuspid valve disease is very complex, as opposed to, if you thought, as I showed you, mitral is more complex than aortic, tricuspid valve gets more complex. Why? The anatomy is much more challenging. These are much more thinner leaflets. They're like wafer thin leaflets that again, you call it a tricuspid valve, but there's actually, so many anatomical and echocardiographic studies where we know now that it's actually not a tricuspid valve in all patients. In patients, you can have quadricuspid valves, you can have 5 leaflets. Basically, there's like new nomenclature coming from Dr. Hahn's group where you can have 2, the anterior split into 2 leaflets, just like we have scallops for, anterior and posterior mitral valve leaflets. The posterior can be split into 2. So there's a whole nomenclature which makes, which makes the whole transcatheter repair more challenging on how you're going to approach these things. The quantification is different, right? It's, the quantification just changed from mild, moderate, severe to include torrential and very, very severe and torrential grade, or industrial grade, if you will. So you've got the quantification that's, work in progress. The imaging is difficult, as we all know. It's an anteriorly located valve, which is not as easily seen with TEE, with, shadowing from different places, pacemaker leads, prior valve replacements and whatnot. And most importantly, these patients present late in the disease process. We've all been guilty as cardiologists and physicians and actually managing these patients. I always still hear about these patients, hey, the guy's not too bad, right? But what happens? You basically see a tricuspid regurgitation, the RV starts dilating, tricuspid annulus dilates a little bit, patient's fine, you walk around, the RV still keeps up, still a little bit dilated. Then you start seeing phase 2 dilation. You see RV is a little more dilated. The tricuspid valve is not coapting. Some of us will actually start, pull the trigger at this point, but most people will wait till this point. The people now have pulmonary hypertension. The tricuspid RV is distorted. The valve leaflets get tethered, and the surgeons for ages have been crying about the fact that they get people referred at this stage. And to this point, again, I'll skip over this study. We know that once you have severe TR, these are 2 different studies where basically your survival is poor, is really poor, and it kind of goes along the grading. So mild to moderate is, to severe TR, you have a graded worsening in mortality if you just medically manage. And what's medical management in these patients? Diuretics, right? You give Lasix to these patients. You might give spironolactone to these patients if they have hepatic congestion, but that's pretty much it. What else? Nothing. You really don't have anything else to give these patients. And irrespective of whether they have RV dysfunction, whether they have pulmonary hypertension or not have pulmonary hypertension, basically, if you have TR, your prognosis is poor. And what do? Our guidelines give tricuspid valve surgery a class 1 recommendation only if you're getting a left-sided valve surgery. And again, we can talk about, the data on this, but I mean, that's the only class 1 recommendation. Everything else is class 2A. Even class 2A is only for, people with primary, and how many people see primary TR, mostly secondary TR. And so you're basically seeing these people with class 2B recommendations. So that's like really poor recommendations. I mean, all of us know that class 2B recommendations are made over with lack of data, or what I call is over a tea party. So, it's not really much of a recommendation, is it? There are over 1.6 million people with tricuspid regurgitation. See how many people get surgery? 5,500. That's the amount of people with TR surgeries. And how many people get MR surgeries? That about 50,000 people get MR surgeries. So out of 1.6 million people with TR, you're getting 5,500. There has been a study. This is a paper that was published by one of my junior fellows from Mayo, along with Dr. Nishimura, where there has been increase in surgical volume steadily, but the mortality, as you see, is consistently 8.8%. Once you cross 8%, that's high surgical risk. So that has been a consistent over the last decade. That has been the mortality, surgical mortality for people with isolated tricuspid valve surgeries. So, this obviously brings us to the point, as you guys probably think, leaning towards the transcatheter technologies, because right now we don't have, this is a tough place. I feel bad because, the surgeon, it's not easy to say the surgeons have always gotten these patients late, but, the surgical mortality is high in this patient population. So, there are different transcatheter technologies. These are the 2, the MitraClip and the Pascal device, that are currently undergoing actual randomized trials and are proceeding really fast. We are involved at the University of Iowa in the Pascal device. This is, again, I mentioned that is the same Pascal, just like a MitraClip. The MitraClip is being evaluated by the TriLimited trial that has different sites, and we are part of the Edwards trial, which is the tricuspid arm. The same clip, just like the MitraClip, the same clip with a different delivery system gets used in the tricuspid arm of the CLASP trial. How it's different from the MitraClip is the presence of a central spacer, which is, again, in theory, improves coaptation and kind of fills that area to reduce the MR and any leakage in between the clip arms. So we are participating as, again, in the class 2 TR, which is a 2-to-1 randomization in people against optimal medical therapy group. And it's very important, both the TriLimited and the Pascal or the CLASP studies are randomizing against optimal medical therapy. Why not surgery? Because I just showed you, you can't randomize against surgery when your mortality is 8+% to start off with. The only thing that actually works in these patients, if anything, is optimal medical therapy. And we're looking at all-cause mortality, durable ORVAT, tricuspid valve surgeries through 24 months, heart failure hospitalization, and so on and so forth. So I will just stop there for the sake of time. Yep, as I've been always asking everyone, please be cognizant of your tricuspid regurgitation patients. Send them for evaluation and send them early. Do not wait for them to get a TAP or be on 140 of Lasix or something before, because get what they go into stage 3, they're not going to be randomizable at that point of time. Nobody wants to randomize these people in any trial phase, and then at that point they're going to be in optimal medical therapy alone. Thanks.
Thank you very much, sir. Sorry to interrupt. Ketan, go ahead.
No, I was just going to say thank you for that said, and if any questions we'll address or as things go, but just in the interest of time, I think we have to move on to the next session, which is going to be the Jeopardy section. But thank you to all the speakers, Dr. Panache, Dr. Suksaranjit, Dr. Laki Reddy, and Dr. Ernesto for your excellent talks on keeping up with science.
Yeah, clearly a lot of preparation has gone into this.
Yeah, I mean,
really,
I feel like we need to have more time for all these talks next time. I mean, there's so much to discuss, and I feel bad to interrupt the speakers, but.
Right, I completely agree. I think this has definitely got a lot more than time that we allotted for it. So, hopefully we can keep that.
I expect one patient out of everyone for the tricuspid trial for interrupting.
Absolutely. No, that was very educational. I mean, I myself learned a lot about the indications as well. So thank you.
Sounds very good. So I think in the interest of clinician well-being, we should give at least a 10-minute break for everybody.
Yeah.
Grab some lunch or grab some coffee or whatever, stretch your legs, and we will plan to regroup at 1:30, and we will go ahead with Jeopardy at the time, followed by the negotiations talk, and then we should be able to wrap up our conference.
Okay.
Thank you again, and look forward to seeing you all at 1:30.
Thank you.
Can I get verification if the Jeopardy participants are here at this time? I can see the University of Iowa team. Can I have the Mason City and the Des Moines team please turn on your cameras? Please feel free to message me. I think I see Tunke on the chat. Tunke, can you turn on your camera? Just make sure that we can see you and hear you. And Justin. Ketan, I don't think I see your team.
Yeah, I'm just messaging them to check what's going on.
Okay.
Hi. Hi, Dr. Mai.
Okay, I think they're there.
Is that the Mason City team?
No, that's Tunjai. I'm from the Mercy One, Iowa Heart.
Okay. Thank you.
Yep.
One on your camera. I think I can actually see the Mason City team, so that's awesome. So
Yeah, and you guys might have to unmute when you come on. Right now, you're muted. Okay.
it's good. So Tunke, as long as you have your cameras on and stuff, I think we should be ready to get started at 1:30.
Okay, we need to have a camera.
I think it would be ideal if we can see you guys.
Okay.
Just
Okay.
so we can make sure you're there, and
Sure. Sure.
and we want you to be around and available. So. So while everybody else is taking a break, Mason City, I really like your background, but I can't see everybody. So I'm going to just put in some information on in the chat window to kind of help you guys join into this, and we can test your buzzers at the same time. Please go to this website. The game code is this. Okay, whenever you can. I want you guys to label yourself, the team names, as University of Iowa, as your program names, Mason City and Des Moines.
And I want you to send me a buzz so I know that that your buzzers are working.
Dr. Ashwa, can you hear me?
Yes, I can hear you. And I can see your screen. So in the interest of time, I think we will try to keep going reasonably fast, Roy.
Yeah, I decided not to harp too much into the educational point, otherwise we won't be able to finish in time. So we'll just keep moving.
Yep. I got the buzz from the University of Iowa. I don't have it yet from the other Mason City program.
How we are going to get that website you said, Dr. Maya? I missed that point.
So you go to ccg.buzz. I kind of typed it in the chat box.
Okay. But we are not together though. We have a little bit.
And that's fine.
Okay.
You want to put it that way, that's fine if you want to be separate. But if somebody can turn on the camera, that would be helpful for you guys. So I have one buzzer from Mason City. Did you guys try more than one or just one? Just one? Okay. Sounds good. Is that Anthony, Sagar, and Chris?
Yes, Anthony, Sagar, Chris.
Okay, perfect. Tinky, I don't have any buzz from your guys yet. Can you just check the system? Make sure we work.
Game code?
It's typed in there. It's all caps, KPRY.
Okay.
Keaton and Jason, I'm going to request you both to be judges in case there's any dispute about any questions or answers. If that works for you both.
Yes, that is fine.
Tinky, I don't have any buzzing from your team yet. Yes, I got it now. I'm going to turn it off and turn it on. If everybody can try it again, please try buzzing again. I got all the three programs. Just remember, your speed of buzzing is going to be very important. I'm just going to go over the rules while we wait for everybody else to join in and the program to restart. You have to answer, this is like real Jeopardy, so you have to answer with what is. For instance, if your answer is aortic stenosis, you have to say what is aortic stenosis, otherwise you will lose a point. You have to be, so when the question comes on, Roy will read the question. At the end of his reading is when I'll turn the buzzers on. So you can keep buzzing in between, it will not go through until I turn the buzzer on. And once I get the buzzer on, then I will call on the team. The team that gets called on is the one which has to answer. If you're unmuted and you respond and you're not the team called on, then some other team can use your answer. Just be mindful about that. There will be daily double. Daily double is only, it's only an option for the team that has clicked on the daily double to answer. The others do not have any chance to answer the daily double. You can wager up to the maximum amount that you have, or you can wager up to whatever the maximum is for that question. Do you have any questions? All right, let's try buzzing one more time. All right, sounds good. Again, I'm getting the University of Iowa buzzing in first. So I'm going to encourage the other two teams to be fast with your buzzing. You can try logging in with multiple devices, multiple iPhones, whatever else, but the speed is important here.
If I don't call on you, then you will lose your option. So I'm just letting you guys know. So if you want to log in with other devices and stuff and enter it and keep buzzing, somebody keeps buzzing in the back as soon as you think you have the right answer, then feel free to do so. There is negative scoring, so be mindful about that as you buzz. Any questions? All right, Roy, I think we can go ahead and get started. Apologize for the sound. We're having roof work done, so I'm going to mute myself.
All right, so I have divided this into two sections. The first section would be singles and the second would be doubles. So each section has 5 different categories and each category has 4 questions. So this would be the first section and with 5 categories. Know your history, try the trials, find EP, drug, which basically pharmacology, and heart success or cardiomyopathy. Dr. Ashwath, do you?
I would just start with know your history 100. For everybody, I think you all know who Roy is, but who you don't know, Roy he's an interventional fellow at the University of Iowa. He was actually my first fit chair when I started my term as governor. He kind of was my right hand, made my life easy significantly. So, and he has contributed a lot to the Iowa chapter. So really appreciate everything he has done. I do want to mention that all questions are confidential, even though we are both from the University of Iowa program. None of the questions have been shared with other participants. And we had quite a few other faculty kind of contribute to the questions too. And also the winner of this tournament will be representing Iowa chapter at the national ACC. As of now, that's planned to be a virtual competition. That's planned to be a live ACC in DC in April. All right, Roy, go ahead.
All right, so we'll start with our first question. Know your history, $100. He was the first person to perform human cardiac catheterization.
University of Iowa.
What is Mason-Sons?
That is a wrong answer.
Anybody else?
Actually, I showed the answer by mistake.
I would go ahead, Roy.
Yeah. So it was Dr. Werner Forsman. He was the first person to do a cardiac catheterization. I'll go back to the board. Dr. Ashwin,
go ahead with 200.
Okay. This person has patent for mitra clip.
I don't have any responses. I think I would move on, Roy.
That is Dr. Mehmet Oz.
Let's try out the trials for 100, maybe.
This trial failed to show that percutaneous mitral valve repair was superior to medical therapy at preventing adverse events.
University of Iowa.
What is Everest trial?
Sorry, I didn't catch your answer.
Can you hear us?
Yes.
Yeah.
What is Everest trial?
That is not the correct answer.
Mason City.
What is mitra for?
That is correct.
Yes.
Mitra for trial.
Mason City, you get to pick the next category.
Drug 100.
This monoclonal antibody is used to reverse the effects of an oral direct thrombin inhibitor.
University of Iowa. I'm sorry, could you repeat?
What is idarucizumab or Praxpine?
That is correct.
University of Iowa, you have the board.
What did you say? Which category?
Drugged for 200.
This drug, due to its bulky structure, binds reversibly to P2Y12 receptor and elicits a conformational change that disrupts ADP-induced signaling.
University of Iowa.
What is ticagrelor?
That is correct. That is ticagrelor.
University of Iowa, you have the board.
Same category, 300.
This drug inhibits the aggregation of amyloid fibrils and disassembles mature amyloid fibrils.
Mason City.
Is tafamidis?
That is incorrect.
Des Moines or University, you want to try? All right, Roy, go ahead.
The answer is doxycycline. What is doxycycline? All right, I think University of Iowa gave the last correct one.
Same category, 400.
Daily double, you have 300 University of Iowa, so you can wager up to 300, or you can do a max of 400. You can just tell your wager.
200.
I'm sorry?
200.
200. Okay.
This drug is a cardiac myosin inhibitor.
What is mavacamten?
That is correct. All right. University of Iowa, you have the board.
Trials, 200.
This type of heart valve system was studied in partner trial.
Chanke?
What is Safin Edwards valve?
That is correct. Edward Sapien heart valve system.
You have the board. Des Moines.
Continue with trial. 300.
Okay, trial 300. The Plato trial compared these two drugs in patients with acute coronary syndrome.
University of Iowa.
What is a ticagrelor versus Plavix?
Yeah, that is correct.
Same category, 400.
This trial showed that the use of class 1C antiarrhythmic agents, flecainide and encainide in patients following myocardial infarction with LV dysfunction increases the risk of death due to arrhythmia and shock.
University of Iowa.
What is CAST trial?
That is correct.
Mason City, you are behind by a second. So just so you know, the buzzing is important.
University of Iowa, you have the board.
Heart success, 100.
This class of inotropic agents increase myocardial contraction by targeting myosin, actin, and associated regulatory proteins or other structural elements of the sarcomere through calcium-independent mechanisms. Omecamtiv mecarbil is an example.
University of Iowa.
What is levosimendan?
That is incorrect.
Any other takers? Okay, Roy, move on.
So basically, the question asked what was the class. So these class of medications are called cardiac myotropes or just myotropes. So you can have mitotropes, which are cholinergetics. You can have calcitropes, which work on calcium flux, and then you have myotropes, which work on the sarcomere. All right.
Dr. Ashwath, quick thing. We can't see the screen properly. Can you tell us the scores? It's very blurry.
Yeah, the screen is not very clear, but I can tell you the scores.
Now it's actually pretty clear. Thank you.
I have Des Moines at 200. I have Mason City at -100. And I have the university at 1100.
Thank you.
So I think last correct answer was University of Iowa.
Heart success 200.
It is estimated that up to 40% of cases of familial dilated cardiomyopathy have an identifiable genetic basis. Pathogenic variants in this large sarcomeric protein are implicated in most, approximately 20% of these patients.
Mason City.
What is lamin A/C?
That is incorrect.
Any other takers? I would move on, Roy.
And the answer is Titan.
Same category 300.
This prospective randomized trial examined the effects of phased withdrawal of heart failure medication in patients with clinical imaging and biochemical evidence of recovery from dilated cardiomyopathy. It showed a 40% relapse rate of their dilated cardiomyopathy within 6 months, with most patients relapsing within 8 weeks of their last medication intake.
Mason City.
What is TREAD-HF?
That is correct.
Mason City, you have the board.
Heart success for 400.
Success for 400. The presence of this hemodynamic finding indicated by the red arrow in patients with heart failure referred for heart transplantation is associated with a higher incidence of post-transplant right heart failure and overall mortality.
Sorry, I just turned the buzzer on. No takers?
All right, I'll move on.
Yeah.
So what is Kussmaul sign or Kussmaul physiology? So it's basically a paradoxical inspiratory rise in the RA pressure in contrast to normal fall during inspiration. And in patients who are referred for transplant and who have these physiology are more likely to experience post-transplant RV failure and death compared to those without. I think Mason City answered correctly last. You have the board.
Mason City, you have the board.
Know your history for 300.
The first catheter-based approach to balloon aortic valvuloplasty was developed by this person.
I don't have any responses. Any takers? Roy, I would move on.
It's Dr. Alan Crepier. He also did the first tower.
we just round out that category?
Know your history 400. Here you go. Inge Edler and Karl Helmut Hertz are considered father of.
I have no takers. Roy, I would move on.
What is ultrasound cardiography? I would have even given for echocardiography. All right.
We do EP 100.
This is the target for ablation of typical AV nodal reentrant pathway.
Mason City.
What is fast pathway?
No, slow.
Oh, what is slow pathway? What is slow pathway? Slow pathway.
I think we'll give you that.
Okay. All right, that is correct.
Mason City on the board.
200.
200. There you go. This is the structure you would find at the apex of triangle of Koch.
Mason City.
Coronary sinus. What is coronary sinus?
That is not correct.
University of Iowa, Des Moines, you want to try?
No.
All right, Roy, take over.
What is compact AV node?
Mason City, you have the board. Mason City, you have the board.
300. Sorry.
Block in this phase of action potential accounts for periods of prolonged paroxysmal AV block and can be seen after extrasystoles.
University of Iowa.
What is phase 4 block?
That is correct.
University of Iowa, you have the board. Go ahead. Yeah.
One question. 400. Someone with continuous atrial fibrillation for the previous 18 months would be considered to have this form of atrial fibrillation.
Sorry, was that us?
Yeah, that's Mason City.
Is long-standing persistent?
Yes, that is correct.
All right, that finishes the first round of Jeopardy. I have University of Iowa at 1400. I have Mason City at 300 and Des Moines at 200. The next one will be double Jeopardy, so higher values. Did you want to do the audience question
Yes,
now?
yes, we'll do the audience question now.
We have a question for the audience. The winner might get a gift card. So
this is a tough one, actually. All right, here you go.
you can just put it in the chat box, or you can send it directly to me in the chat or on text, however it works.
Management of a patient with end-stage non-ischemic cardiomyopathy who is admitted with lightheadedness and near syncope. Upon presentation in the ED, ICD cannot get interrogated due to electromagnetic interference between the LVAD and ICD. Name the type of LVAD, type of ICD, and technique to overcome EMI, electromagnetic interference.
I think we'll give 1 minute for the audience. We have a lot of strong EP and heart failure people. All right, I think this is way too tough for the audience. 30 seconds here.
Should I go ahead?
I have another 30 seconds, I think.
This question is not from me though.
Okay, we have what is heart failure, Medtronic ICD, and reduce LVAD speed? Is that right? Right?
Yeah, partially. I think there's a second answer which I think is correct.
I have another answer about hardware, Biotronic, and Shield LVAD.
Yeah, I think that's
Which one would you give, the first one or the second one?
second one.
Second one. All right, Jason Myers is our winner, and he'll get the $25 Amazon gift card. Congratulations, Jason.
So, so this is what is called a span method. I've actually seen this once, but yeah, this because the electrolyte inference you cannot really get and interrogate the biotronic devices. So you just have to look for a pan to kind of cover that. Very good.
All right, I think we can continue on with the second part.
All right. So this is the double section. You have arrhythmia and arrhythmics, physical exam. Pictures are worth 1,000 words. It's all in the genes and hemodynamics.
So again, the screen is very blurry, Dr. Ashwath. Can't see anything.
It's Roy. I don't know what I don't know what it's going on, but yeah, some of the screen gets a little blurry, Roy. I don't know if there's anything you can fix there or.
Let me share screen again, maybe. How about this?
Yes, that's good.
Okay, all right. I actually lost track who
had the last question. I don't remember. I think Mason City had the last question, actually.
Yeah.
Sure.
Let's see at the board.
Yeah, we could see it.
Yeah.
Can we start with hemodynamics 200?
All right. The diagnosis is
University of Iowa.
What is my tricuspid regurgitation, severe tricuspid regurgitation?
That is incorrect.
I have Des Moines, Tinke.
Yeah. What's aortic insufficiency?
That is incorrect.
University of Iowa is trying to buzz again. You cannot buzz again. Mason City, you want to try or no? No, they give up. All right, Roy, take over.
All right. So this is severe mitral regurgitation. The tracing was capillary wedge pressure with massive V waves. And you have to distinguish it from arterial tracing and from the RV tracing because it has peak appearance and it is peaking at or after the T wave. So I can go back and show it again. All right, in the interest of time, I will move forward.
Mason
Sorry,
I did not catch that.
Mason City, you still have the board.
Physical exam for 200.
This is a classic auscultatory finding which suggests severe mitral stenosis.
Tinke?
Early opening snap.
I will give it. What is short A2OS gap? Do you agree, Dr. Ashwin?
Yeah, I agree. All right, Tinke, you have the board.
Picture are worth 1,000 words.
You want 200?
Yeah, 200, sorry.
Okay. This chest X-ray was done after a procedure.
Mason City?
What is pneumopericardium?
Very good.
Right.
Mason City, you have the board.
Gotta talk.
A pix is worth 1,400.
This patient has myeloproliferative neoplasm with FYP1L1 PDGFRN mutation and presented with stroke. What does the imaging show?
Note takers? University of Iowa fellows are not attending the MRI conferences. I'm just kidding. Go on, Roy.
The answer is what is endomyocardial fibrosis. This patient has a hypereosinophilia because of this mutation. And I would actually let Dr. Ashwath discuss the MRI finding.
Yeah, no, I think in the interest of time, basically it kind of shows the subendocardial scar, which you get because of this eosinophilic change and kind of the inflammatory response eating up the myocardium, causing the scar. And inside the scar is where you have the thrombus, because it's very procoagulant over there. And that's why you see a lot of strokes in this population. You see this with the hypereosinophilia, with Chagas, and all these variants. But go ahead.
Pictures for 600.
This patient with severe aortic stenosis is likely to have this life-threatening complication immediately after TAVR.
Mason City.
What is suicide left ventricle?
That is correct.
Mason City, you have the board.
800. Pictures for 800.
You have the daily double. Your score is 900, so you can wager up to 900.
Uh, 200.
Okay.
The echo in a patient who underwent a prior cardiac surgery shows a rare complication.
What is Gerbode effect?
Yes, that is correct.
Yeah.
That's where you have the LV to the RA shunt. Very good. All right, Mason City, you have the board.
We can't see it very well.
Again? Okay.
Yeah.
I don't know. It's
That's fine. You could just click whatever.
Just read out the categories, Roy. I think somehow it's getting blurry in between. Yeah. Yes, that's good.
Let's give antiarrhythmics a try for 200.
These are the three main mechanisms of cardiac arrhythmia.
University of Iowa.
What is automaticity, triggered, and re-entry?
Sorry, I did not. There was some.
What is automaticity, triggered, and re-entry arrhythmias?
Yep, I think I'll give that. Yes. Sorry, my microphone was. My headphone was just running. Yeah, that is correct answer.
University, you have the board.
CM 400.
Arrhythmia 400.
Yeah, same category for 400.
This is the mechanism of this proarrhythmia.
University of Iowa.
What is bidirectional VT due to
Ditch toxicity.
Dish toxicity or CPVT?
yeah ditch toxicity over CPVT? It's a delayed early report.
I think this will probably have to go to the judges.
Yeah, we have 2 EPs as judges, so
Yeah.
I think it's reasonable. They did
Yeah,
polarization, right? So I think
I would give that. Yeah.
Yeah.
Okay.
Yeah, I think that's reasonable.
Same category 600.
All class 3 antiarrhythmics show reverse use dependence except this drug.
Mason City.
What is amiodarone?
That is correct.
Mason City, you have the board.
800, same category.
This class of drug is used to treat the algorithm.
University.
What is verapamil for fascicular VT?
I will. Rashid, what do you say? I think we can give it. We'll ask for.
Ketan and Jason, what do you think?
Yeah.
The question is on class of drug.
I mean, I think it's reasonable because, calcium channel blocker.
Yeah, and usually, verapamil, it is considered verapamil sensitive VT.
Yeah. Okay. University of Iowa.
Hemodynamics 400.
Above right atrial waveform is due to this disease.
University of Iowa.
What is severe TR?
That is correct. This basically shows ventricularized eye pressure waveform. All right. University of Iowa at the board.
Same category 600.
Above simultaneous LV and wedge pressure waveform is due to this condition.
University of Iowa.
What is constrictive pericarditis?
That is correct. I think my next slide is a little jumbled up, so I will not look at that, but that's the correct answer.
All right, University of Iowa, you have the board.
Yeah, so 600 is gone.
Same category 800.
The tracing of IFR or DFR across left main arteries is to show this condition.
I have no takers so far. Tanke?
On non-significant CAD.
That is
atherosclerosis.
That is incorrect. So I will go ahead.
Yes.
What is significant osteolymphatic disease? This tracing basically shows IFR when the Titus is engaged. So you're having ventricular pressure waveform, and IFR is falsely high. So when you disengage, it will change.
Go ahead, Roy.
University of Iowa.
It's all in the genes 200.
Supravalvular aortic stenosis and stenosis of the main pulmonary artery is associated with this syndrome.
University of Iowa.
What is Williams syndrome?
That is correct.
Same category 400.
Truncus arteriosus is associated with this genetic syndrome.
University of Iowa.
What is DiGeorge syndrome?
That is correct. University of Iowa.
Same category 600.
This is the gene with mutation in Marfan syndrome.
University of Iowa.
What is fibrillin gene mutation? FBN1.
Yeah. University of Iowa.
Same category 800.
This is the aortic size cutoff above which preventive aortic surgery should be done in Lewis-Dietz syndrome.
Mason City.
What is 4.5 centimeters?
That is incorrect.
University of Iowa. Sorry.
What is 4.2 centimeter?
That is incorrect.
Okay.
There's two different criteria for CT and TEE. So I don't know which.
4.2.
Yeah, it's a
But it's
4.4 or
4.2,
4.2. Based on which modality you use.
What is your answer, Chinke?
4.2.
5. I was thinking to say 4.5 or 5.
That is incorrect. So the answer which I have is 4 centimeter and more.
I actually could test that because actually this is as per authentic ACC SAV website, and basically they say 4.2 centimeter. But I mean, I think it depends on the modality.
This is from a Mayo Board review. From what I got. So we can.
All three teams got this incorrect, so we can either throw out the question or we can take out 800 for every team. So it essentially makes no difference either way, I think.
Okay. All right. University of Iowa, you have the board.
Physical exam 400.
This condition causes a systolic murmur, which increases with expiration, amyl nitrite inhalation, and standing, and it decreases with inspiration, hand grip, and squatting.
Mason City.
Hypertrophic cardiomyopathy.
That is incorrect.
Aortic stenosis.
Sorry, University of Iowa.
What?
Do you answer?
So you said our name, right, Dr. Ashwath?
Yes.
What is mitral valve prolapse?
That is correct. University of Iowa, you have the board.
Same category 800.
This is the only right-sided heart sound which gets softer with inspiration.
University of Iowa.
What is pulmonary ejection click in pulmonary stenosis?
That's correct. All right, so we have one question left.
600.
This condition is known as and is caused by.
Mason City.
What is pulsus alternans from failing LV?
That is correct. So I think we have finished the board. Dr. Ashwat, do you want to
Yeah.
check? And after that, we will do the final.
So I have Des Moines at -600, and then I have Mason City at 1900, and I have University of Iowa at 6000. So you can text your wagers directly to me, or you can put it in the chat to me, either way. Azim, I apologize for the delay. The whole schedule kind of ran late the whole day. I really appreciate you waiting for us. We should be wrapping this up soon, and we should be able to move on to you.
Dr. Ashwat, can you repeat the scores one more time? Sorry.
I have you guys at 6000, and I have Mason City at 1900.
Thank you.
There will be only 2 teams participating in the final Jeopardy. Roy, you want to tell them the category? I got the wager from Mason City. I need the wager from you guys. Shishi. All right, I got the wagers from both teams. You can go ahead.
This is an anomalous vessel.
I have the response from Mason City. Okay, I have the response from both teams. You want to show the final answer, Roy?
Answer is what is persistent left SVC.
Mason City gets it correct. And, they called it persistent left SVC. University of Iowa called it anomalous coronary sinus to PA. So University of Iowa is at 5,900. They wagered $100. And Mason City is at 2,100. They wagered $200. So very good job to all the 3 teams. Great competition and great responses. University of Iowa will be representing Iowa chapter at the National ACC. The winners will be given Amazon gift cards. We'll have those sent over to you along with a certificate, and we'll also send you a cup in recognition for all your participation in the Iowa chapter. The same goes to the second team. The second team will also get an Amazon gift card along with a congratulations certificate and a cup with the Iowa chapter logo on it. Des Moines, thank you very much for the participation, and we will send over a cup to you guys too.
Thank you, everyone. I really want to thank Dr. Ashwat, Dr. Myers, Dr. Hannah, and Dr. Bire for sending the questions. And thank you, everyone, for participating.
Thank you very much, Roy. That's a lot of hard work you put into it. Really appreciate everything you do for the chapter.
Thank you, everyone.
Having us, guys. We appreciate it. Good game.
Yeah, thank you, guys.
We're going to move on to our next session. And again, I apologize to Azim for the delay in the talk. He's going to be talking to us about negotiations, not just in contracts and stuff, but in general, in regular life too. I'm going to let Vikram and Paul, our fellows, cardiology fellows, to take over with the moderating of this session. But just to mention a word, Azim was my professor and my lecturer when I was doing my EMBA, the executive MBA course, and he taught the negotiations topic for us. And he was always recognized as the best teacher for the whole session. So I let Vikram and Paul take over from here. Thank you very much, Azim, and I appreciate your patience with us.
Thank you so much for your patience, Dr. Ahmed. It's our pleasure to introduce you. Dr. Ahmed is a clinical professor of emergency medicine and adjunct clinical professor of management and entrepreneurship at the University of Iowa. He completed his medical training at University of Iowa here and his residency at Butterworth Hospital in Grand Rapids, Michigan. He serves as the Division and Fellowship Program Director for the Emergency Medical Services in the Department of Emergency Medicine and Medical Director of Kinnick Stadium and Carver Hawkeye Arena, as well as the Medical Director for the Bureau of Emergency and Trauma Services, Iowa Department of Public Health. In addition to his clinical duties, Dr. Ahmed is very passionate about his education, not only as a clinician in his role as faculty in the emergency department, but also is heavily involved in leading the dynamics of negotiation class within the University of Iowa Tippie College of Business. He has proficiency in negotiating in a variety of situations within the healthcare system between organizational units, human resources, and business development. He provides seminars and negotiation strategies, tactics to a variety of business and healthcare organizations regionally and nationally. And to reflect his expertise in teaching and education, he was recognized by the Tippie Executive MBA Iowa City classes of 2015, 2018, 2019, and 2020 as a Great Instructor of the Year. In 2017, Dr. Ahmed was selected by the Tippie Executive MBA Des Moines cohort as Great Instructor of the Year and also nominated for the President and Provost Teaching Award. He's a member of the Academy of Management Professional Organization. We're really honored to have Dr. Ahmed take time out of his busy schedule to speak to us, and we look forward to learning about the techniques of negotiations.
Well, thank you, Dr. Lee. I appreciate that. Let me share my screen. Are you all able to see that okay?
Yes.
All right. Well, thank you again, everybody, for having me here. And I also learned some things during the cardiology Jeopardy, so I appreciate that. So it's always good to learn. But I'm here to talk to you about negotiations. And so we have about an hour to go through a topic that is quite complex. As Mahi says, so Dr. Ashwath was a student in my class when she did her executive MBA program. And so I'm really excited and honored to be here to discuss negotiations at a high level and how some of these concepts that we're going to be talking about are very pertinent to the work that you do, not only in your professional life, but also in your personal life as well. And so I'll begin. If you have any questions, please unmute yourself and ask, and I'd like to keep this as interactive as I can. I don't have any significant disclosures. I have no financial relationships with the author or the publisher of this book. This is the textbook that I use in the class when I teach at the Tippie College of Business. But again, I do not have any financial relationships with the author or the publisher. So a few opening comments that I want to make regarding negotiations are as follows. So there are many different contexts in which we negotiate, and they're too numerous to count. There are matters that are small and often large. And so there's this entire spectrum of things that we negotiate in. Now, not everybody has received a formal training in negotiation. So we as physicians are asked to negotiate patient conflicts, conflicts among colleagues, negotiations for resources, but very few of us have received formal training. And hopefully today will open your eyes to some of the concepts that are out there when it comes to negotiations. Certain situations are not amenable to winging it. And so oftentimes people negotiate, and if they negotiate the same thing over and over again, you're able to spontaneously negotiate and do relatively well. But for the most part, most negotiation scenarios are not amenable to winging it. We're going to be talking about some basic constructs and terminology. I'll share with you the importance of the bargaining template by Shell, who's the author of the textbook that I use for my class. And then hopefully this will stimulate you to study further when it comes to negotiation. So there are many different definitions given to what a negotiation is. And I think the one that I teach my students in the business school is that a negotiation is an interactive communication process that may take place whenever we want something from someone else or another person wants something from us. Now, that is my functional definition of a negotiation. So you can think of how many times during the day, whether it's in your business or personal life, that you negotiate. And there are other acceptable definitions, but this is a definition that I truly like because it truly encompasses in my book the spirit of what a negotiation is. And a key point that I want you to remember from all of this is that it's not always about money. So people think negotiations are just about money and contracts and deals. To some extent they are, but just always understand that it's not always about money. And so I'll talk a little bit more about that, but that's why it's so important to understand what's important for your counterpart. Just don't assume that because it's important to you, that it's important to the other person. And that's something that I've learned the hard way along in my negotiations career. So what negotiation situations could you face in your life? And this is just a list that I just assembled, and it may be very pertinent to you as you're going through fellowship, going through your early part of your practice career. These are situations where you might find yourself negotiating. So salary and benefits. And so in training, you have very limited capacity to negotiate your salary and benefits. But as you graduate and move forward in your career, the ability to do this becomes a lot more active. Clinical commitment. And so as you look to your practice careers, how much are you going to be working? Medical directorships. If you're called upon to take leadership roles in your organization, what are the negotiations that are surrounding that regarding remuneration, protected time? What does that mean? Administrative release time. This is something that is negotiated. CME and professional development opportunities are oftentimes negotiated as you look to take up attending roles. And then partnership opportunities. So whether it's partnership in the business of your practice or partnership when it comes to partnering with other practices, other hospitals, things like that. So there's a lot of negotiations that go along with that. So whether it's a satellite clinic, there are contracts that have to be signed in regards to that. And there are things that I call the life contracts. So things like home purchases, car purchases, any other situation where there's an exchange, negotiations are important. And so these are just some situations. There are many, many more that I'm not covering on this list, but as you can see, it's very difficult to get through your professional and personal life without negotiating. Some terms that I want you to understand, mainly on the left side of this slide. So aspiration level, oftentimes called the target point, is what you would like to ideally achieve. And so this is important because studies have shown in the management literature that when people actually define what their aspiration level is, and also what the reservation price, often called the resistance point, people tend to do better. So if you frame out and if you outline what you're trying to achieve, what's the least that you're willing to take, that allows people to focus their negotiations better and thus have a more successful strategy. And we'll be talking about this term called BATNA, which is also known as the best alternative to a negotiated agreement. And this is a very important concept in negotiation, and we'll learn what this means. Namely, people that tend to have a BATNA or alternatives tend to have leverage. And so that's a very important concept that we'll talk about. There are 5 different negotiating styles. You may not have known that, but hopefully this is something you can take away from this presentation. There are 5 different styles, and they're known as avoiding, compromising, accommodating, competing, and collaborating. And so just on this list, they may not mean much to you, but on the slide, you can see how important they are when it comes to understanding what your goals are in a negotiation and which negotiation style that you should employ. And so if you look at this slide, on the right side here, if you have a high focus on outcome and also a high focus on relationships. So the deal is important, but also maintaining your relationship is important. You can see that the recommended negotiating style is collaboration. Now, on the other side is if the outcome of the negotiation is very important and you really don't care about who you're negotiating with, or the relationship is not important, then competing is the recommended style. And so the main point, and so on and so forth. So you can see how the different negotiating styles map out on this graph, which essentially graphs what your focus is on the outcome versus what your focus is on the relationship. Now, the reason this is important is because all of us have an intrinsic negotiating style. And that's great. But what the slide really emphasizes is that skilled negotiators will apply different types of negotiating styles based on what the situation requires. And so again, there is danger if you're a competitive negotiator by nature, but if the situation requires collaboration, there could be some challenges in your negotiations because you're applying a style that is inappropriate for what the situation is. And so again, to emphasize, we all have an intrinsic negotiating style, but the skilled negotiators will apply the appropriate style, even if it's not their strength, they'll apply the appropriate style to the appropriate situation. And so this slide is extremely important. I know Mahi had to know this for her final exam because I asked multiple questions from this slide on the examination that I gave her when she was my student. Now, there are multiple tools online that you can use to identify your negotiating style. And so this is just one tool that I pulled from the internet. It takes about maybe 10 minutes to complete. This is a tool that gives you some self-awareness. It is not set in stone because, like I said, skillful negotiators are able to move from one negotiation style to another based on what the situation requires. But I do encourage you to take the 10 minutes to find out what your intrinsic negotiating style is. Another concept that's very important when it comes to learning about negotiations is reciprocity. So reciprocity is a major life force when it comes to negotiations. So I don't like to read oftentimes from slides, but I'm going to read word for word what reciprocity is based on Dr. Alvin Goldner. So reciprocity are duties that people owe one another, not as human beings or as fellow members of a group, or even as occupants of social statuses within the group, but rather because of prior actions. The key word is actions. We owe others certain things because of what they have previously done for us, because of the history of previous transaction we have had with them. Action, transaction. So what this is saying, what Goldner is saying, is that reciprocity, we reciprocate. We've heard that term. We reciprocate not because we feel that we should do something because we like somebody, but it's based on the actions. So they have given us something or they have agreed to something, and then we want to reciprocate because of that action. And this is extremely important because the normal reciprocity, what Goldner's talking about, is what allows you to negotiate with people that you like, but also with people you don't like. And so if this normal reciprocity did not exist in negotiations, it would be impossible to have prisoner of war exchanges or hostage negotiations, because oftentimes you're negotiating with people you don't like, but you have to conduct the deal to get your citizens back or get the hostages released. Well, oftentimes in those negotiations, they are conducted because of reciprocity, not because I like you, but because I want to reciprocate for things that you have done. So you have given us our people, so I'm going to give your people back to you. And so again, this reciprocity is very important. Now, there's dangers in reciprocity because skilled negotiators understand how important this life force called reciprocity is. And so negotiators that are not your friend can use this reciprocity to place you in a trap. And so I want to share with you what a reciprocity trap is. And so oftentimes it happens if you trust someone that you don't know very well too quickly. And you're caught up in this exchange, and you feel that you're going to be getting some great reciprocity from this individual. But if it's an individual that you don't know well or may not be your friend, you can find yourself mired in what I call a reciprocity trap. And so basically a reciprocity trap is a ploy to trigger this reciprocity. And oftentimes the person you're negotiating with will give you something relatively small in value, something that's not costing them much, but they'll ask you for something much larger in return. And it's the classic example. This may or may not be occurring as much, but oftentimes you get free address labels in the mail. And again, I'm not criticizing the charities that sent you that, but oftentimes you get free address labels. And you might be wondering, well, why did I get these free address labels? What they're trying to do is they're trying to attach some reciprocity. And so by giving you these address labels, which may cost 10, 15 cents to print, they're asking for you to reciprocate. So even if you give them $1 towards their charity, and these are very good charities, they have made money towards their cause because they've used this normal reciprocity where they've sent you address labels, and you feel obligated because of this normal reciprocity to give something back. So again, I'm not being critical of the charities, but that's why you get free address labels. There's also things called consistency traps that are used in negotiations. And this is where your counterpart, your opponent, will use standards that you have agreed to or professed to in the past to gain leverage to better align kind of what you've said with their position. And so the classic example that I give to my students is, so somebody will come up to you and ask you, do you like to see children starving? And of course the answer is no. And so you say, no, I don't like to see children starving. Fantastic. So remember, it's a negotiation. So they want something from you. And so they ask you, do you like to see children starving? And when you say no, they basically at that point, it's an opening for them to say, well, for $25.95 a month, you can help feed these children. Can I sign you up? And so just to review what happened. So they're using a standard that you're agreed to or profess to align their position with what you said. So they are going to ask you, do you want to see children starving? You're going to say no. So now they're going to ask you for money, and it's consistent with what you said because you don't like to see children starving. So we all like to be consistent. No one likes inconsistency. And so they want to make it uncomfortable for you. You've said that you don't want to see children starving, but now you don't want to give money to help them? I don't understand. And so that's how a consistency trap works, is that again, if you agree to a standard, that standard in the course of a negotiation, especially if you're negotiating with somebody who's not friendly, may be used in that negotiation to strengthen their position. And again, I'm covering a lot of concepts. Please feel free to stop me and ask me questions if you'd like. Let's talk about leverage. And so leverage is so important that in the graduate course that I teach in the business school, I devote one class period to only talk about leverage. And so I love this quote from Archimedes: give me a lever long enough and a fulcrum on which to place it, I shall move the world, which is true. If you have leverage, you can move the world. And so I really appreciate this quote from Archimedes. So what is leverage? So people think leverage is all sorts of things, but let me share with you what the scientific business literature definition concepts of leverage are. So leverage is the power to reach an agreement on your terms. And so with leverage, average negotiators can fare pretty well. And if you're in situations where you lack leverage, this is where you need somebody that has more skilled as a negotiator to get the deal done. And so leverage is something that is essentially the holy grail in negotiation. So people that are able to assume leverage tend to gain the higher ground. Part of leverage is showing your opponent that no deal is bad for them as well. And so oftentimes when we're negotiating with people, we see the negotiation through our lens. And so if we don't get this deal done, I have this to lose. Oftentimes, and to gain leverage, I will show my counterpart, my opponent, that not getting a deal done is not just bad for me, it's actually bad for them too. And so to continue motivating them to stay engaged, you're able to continue the conversation and continue the negotiation. So people just don't realize that not coming to an agreement or not working towards making an agreement is not only difficult for myself, but it's going to be difficult for you. And so there are ways to show your opponent that there's going to be pain involved for them as well. And so this is oftentimes where good negotiators are able to get leverage. So they'll say, listen, if you help me solve my problem, most likely we can help solve yours as well. But if you don't want to help me solve mine, then most likely your problem is not going to get solved either. A few other things about leverage that I want to share. So we talked about BATNA, the best alternative to a negotiated agreement. Just understand that the better your BATNA, the better your leverage. And so if I have multiple options that are available and acceptable to me, then my leverage in this negotiation is stronger, because if I'm not able to come to an understanding with you, I can come to an understanding with somebody else. The counterpoint is the fewer options that you have in a negotiation, the less leverage that you have, because now you have to stay in the game and you have to be able to come to an agreement at all costs. Otherwise, you're not going to get done what you need. So the more alternatives that you have, the better leverage that you have in a negotiation. So there's a few things that you can do to improve leverage. So if you look at your situation, you say, well, I don't have much leverage, what can I do? Well, these are some things that you can do. So one is gaining more information about what the situation is. And often this is done to see how I can help solve your problem. Because if I have a solution to your problem, or a solution or an answer to what's happening, then the more motivated you are to continue negotiating with me. So I will gain more information to see if there's ways that I can help solve your problem or help you, because helping you is most likely going to help me. And so gaining more information. That leads to the second point, figure out what they want or need. Oftentimes we're so fixated on what we want and what we need that we just neglect to ask other people what they want or need. Think about negotiations that you've done and how many times you've asked your counterpart, what does a win look like for you? What do you need out of this negotiation? Most people don't do it because they're too fixated on what they want. Acquire more power to make the other side worse off. So again, leverage is not power. Please understand, leverage is not power. But you're able to acquire power through allies or having people join your side, especially if they have authority, you're able to get some leverage by having powerful allies. Using normative principles and consistency arguments. So if you have normative principles, are oftentimes statements from national organizations or some things that are in code. And so whether it's promulgated by JACO and things like that. If you have position statements and legal code or statutes or industry standards that support your argument, that helps build your leverage, because oftentimes those things can't be disputed. Gentle, steady pressure tends to have people gain more leverage because your counterpart may become tired or bored or distracted, and this allows you to gain the higher ground. And then I talked to you about BATNA. So if it looks like this situation is not going well, a good way to increase your leverage is to come up with alternative agreements that are also acceptable to you. And so that's a surefire way to increase your leverage. A few things, leverage is not power. So leverage is a situational advantage. And so please understand that leverage is not power. Some of the least powerful people can have tremendous leverage. And so don't confuse the two. It will be very detrimental to your negotiations. Leverage is also not constant. Remember, I said it's situational advantage. situations change. And so the dynamics of the negotiations change. So it's very important that when your leverage is peaking, that you advance the negotiation. And so skilled negotiators can sense when they have good leverage, and that's when they move the negotiation forward. And so if you're lethargic, if you're waiting too long, if you don't have good situational awareness, you may attempt to move the negotiation forward at a time when you lack leverage, and that could be detrimental to what you're trying to do. And finally, leverage is not fact dependent. So the perception I'm giving you of the leverage that I might have, or the allies that I've gathered, may not be true. And it's very difficult for you to ask proof for every single thing they are telling you. And so part of this negotiation strategy is to understand that the impression of the leverage that you're getting from your counterpart, it may not be based on reality. And that's why gaining more information, asking questions, verifying certain inputs is very important, because leverage at times is not fact dependent. It's the perception that you're getting from your counterpart. There's 4 steps in a negotiation. All 4 steps occur in a negotiation. Equivalent amounts of time may not be spent in each of these parts, and they may not occur in this order. This is the standard order, but there's times where they occur in different order, and that's okay. But these are the 4 components that tend to happen as you go along. So first is preparation. Without saying, the most skilled negotiators prepare, and they prepare a lot, because they want information. They want to ask the right questions. They want to understand what you need. They want to go ask other people about how you are and what type of negotiator you are. Are you trustworthy? Do you share information? Skilled negotiators prepare, and they prepare, and they prepare. The actual negotiation for them is perfunctory. It's the end of the road for them. The bulk of their work has been done in the preparation phase. The next is you have to go back to that graph I showed you and decide where you are. Is the deal more important than the relationship? Is the relationship and the deal very important? Is the relationship more important than the deal, or do you not care about any of it? And so you have to decide where you're at. The reason you have to decide where you're at is because that determines or suggests which type of negotiating style that you should use. And so if you're concerned about the deal, but also the relationship, then you use collaboration and compromise. If you're not super concerned about the deal, but you're only concerned about the relationship, you want to preserve that relationship, that's accommodation and collaboration, so on and so forth. And so as you're preparing, you have to know where you are on this chart. Because if you go into a negotiation and you've not picked where you are on this chart of what's important to you, then you have not prepared properly, and this most likely will not be a successful negotiation for you. Exchanging of information is very important. It's hard to negotiate if you don't have information or what's going on. And so some people will try to hoard information to use it as a situational advantage to gain leverage. And that may work initially, or that may work for aggressive, competitive negotiators. But for the most part in healthcare, we are not in competitive negotiation situations. We oftentimes collaborate and we compromise and we accommodate, but we rarely are competing. And so hoarding information and trying to use as leverage may give you an initial short-term advantage, but it will be long-term injurious to your reputation because in healthcare, we tend not to engage in very competitive negotiations. We use the other styles because that's the nature of the work that we do. And finally, closing and commitment. This is all great. We've prepared. We've understood what type of negotiation we're in. We've exchanged information, had dialogue. But unless you're able to commit to an agreement, all this is for naught. And so understand that an agreement is not a commitment. The commitment, the term commitment, is the gold standard when it comes to negotiations. Agreements are great, commitments are where it's at. That's why I ask for a commitment, not an agreement. So the final part of my presentation I want to go over is introducing you to this concept of the information-based bargaining template by Shell. And so this template frames out your preparation for a negotiation. And so do you have to use this for every negotiation? Absolutely not. Should you use it to help you frame out moderate to more complex negotiations? Absolutely. And so I've really encouraged my students over time to really use this template to help them prepare for a negotiation. This could be in your professional life, but I've had students use this template for their personal matters as well. So let's begin. So initially is that you have to develop and define what your problem statement is. The problem statement is what you're trying to solve or what you're trying to come to an agreement about. And so other ways to think about it are, what's this negotiation about? It is very, very important at this stage to clearly define as best as you can what this negotiation is about, what you're trying to get, because if you do not have a good understanding at the beginning, then this negotiation is going to become like an unguided missile. It's going to end up somewhere where you don't want it to. And so very important that you spend the time in this initial phase defining what that problem statement is. You have to think, again, what are my goals and who are the people involved in deciding? So we talked about the aspiration level. You should write down what your aspiration level is, the high expectation. My high expectation is this is what I'm going to get out of this negotiation. It's important to note what your resistance point is. What is the most or least that I'm willing to take? And what's the least or most I'm willing to tolerate? If you do not frame out by writing down what the framework of your negotiation is, it's very difficult for you to negotiate. If you do not have a predefined aspiration level or a resistance point, this is very difficult. Who's the target decision maker? Who am I trying to convince? Is it my counterpart? Or do they have to report to a boss? Do I have to report to a boss? Are there influencers? Are there people that I need to get initial agreements from in order to move this negotiation forward? Do I need allies? Whose backing that I have in this negotiation? And so you really have to think about what your aspiration level is, what your resistance point is. Do I need allies? Do I need to have smaller negotiations before I move forward? All very important. You have to define to the best of your ability what the underlying needs and interests of the parties are. Your interests are very easy because it's about you. To know that what you want, it's very easy. But oftentimes we rarely think about the other party. You rarely think about the other party because we tend to look at life through our own lens. But I want you to think, are there ways that I can help solve what they're trying to get done as well? What pressures do they have? Do they need me to help solve what they're trying to do? Do they care about me? And so it's very important that you try to not only think about yourself, but try to identify your counterpart's needs as well. We talked about leverage. Think about your leverage. What do I lose if there's no deal? Can I improve my leverage? Do I have an adequate alternative in this negotiation? And what can I do to limit my loss? So I think, what happens if this doesn't work? Am I just kind of out of luck? Are there ways that I can kind of force or will my counterpart to do the things I want them to do? What if they don't agree? Do I have alternatives? So you really have to think about this as part of the preparation for your negotiation. What's their leverage? Same questions. What do they have to lose if there's no deal? Can they improve their leverage? Do they have alternatives, or am I the only person that can do a certain thing, whether it's a procedure, whether I control some type of resource? Do I have specific knowledge that nobody else has? And what can they do to limit their exposure? Think about leverage. Then you have to come up with possible proposals. These are the actual negotiating points. These are things that you want to ask them. These are things that you're willing to give them. You have to start thinking about these offers and these maneuvers that you're going to do. You want to scrutinize them. You want to practice them. Remember, this is all about preparation before the actual negotiation. So you may ask one of your colleagues to play the part of who you're negotiating with. You'd much rather poke holes in your own arguments in the practice phase as opposed to actually on game day when you're doing the negotiation where they can poke holes in your arguments. So again, this is why preparation is so important. Are there standards and norms that I can use to bolster my argument? Are there statutes? Are there legal precedents? Are there position statements from the American College of Cardiology? Are there things in the bylaws of the institution? Are there things codified in the department? Are there standards and norms that I can use to my advantage to advance my argument, but also to repel things that other people may be using as part of the negotiation? Third parties, are there others that I can bring on board to bolster my position? So are there patients? Are there patient advocacy groups that I can bring on? Are there nurses that can join me in bolstering my position? Do I need an audience? Do I need to have some type of town hall as part of this negotiation? Do I need to build a coalition? Do I need other doctors to join me? Do I need the chair's endorsement? Do I need a letter from the chair or the president of your group? So these are all things that you have to think about as part of the preparation for your negotiation. You've seen this slide before, and you're going to see it again. So am I using the proper negotiating style? Remember, if you just use a style that you know how to use, you better hope that you're in the right quadrant to use that style. So if you're a competitive negotiator, then you better hope that this is a transaction. But unfortunately, if this is a balanced concern where the relationship and the deal is important, but you come in competing because that's your natural style, that's going to be a problem. And so again, you have to match the situation with a strategy and apply the proper negotiating style. You have to think of the best modes of communication. Is this something that's done face-to-face? These days, wearing a mask? Or is this through teleconference? Is it better for me to meet with them on Zoom or Google Meet or whatever you're using? Is a telephone call better? Email? Or should I use an agent? So should I send somebody else? If you're negotiating other things, do I need to hire an attorney? They're an agent. A realtor is an agent. And so you have to decide, A, am I going to do this negotiation myself? And if I am I going to do it face-to-face, teleconference, telephone, email? They all have advantages and disadvantages. And that's something I covered extensively in my class, the advantages and disadvantages of these various styles. Or is this something I'm going to give to somebody else? Because A, I may not be good at negotiating this, or B, there's too much emotion involved. The investment in somebody else doing it is worth it because they're going to be able to get me more than I can get myself. That's why, for the most part, people who are getting a divorce don't negotiate their own divorce settlement. They hire a lawyer because they're often able to get more because lawyers are lawyers. And so you have to decide, am I doing this or an agent doing this? And then finally, all of this work that you've done, all these inputs you've looked at, all this thinking, You have to be able to summarize this into what I call a positioning theme. It's a short statement that sums up the purpose of the negotiation. And if you're not able to sum up this purpose of the negotiation in a crisp statement, then you need to focus more. So a crisp statement may be, I will be negotiating with the John Deere dealer to purchase a riding lawnmower at a price that I find acceptable. That's a positioning statement. And you've done all of this prep beforehand in purchasing a lawnmower. Are there other lawnmowers that I want to buy, or do I have to have a John Deere? What are they selling for in other communities, et cetera, et cetera? Do I want to compete on price, or do I want to have a friendly relationship with this dealer because I might have to come back for servicing? How many mowers do I think they've sold? Am I buying it in the fall when there's not going to be a lot of mowing going on because the prices are better? But it might be this year's model, and I really care about lawnmowers, so I want to come back next year to get the New Year's model, but it's going to cost more. So these are all the things that kind of go into the preparation of your negotiation. So I'm going to leave you with some keys to success. And this is what I hope that my students take away from my class at graduation. And hopefully you'll take this away as we conclude this didactic session. So one is willingness to prepare. Preparation is key. And this is where you conduct the research. This is where you perform introspection. You practice and practice and practice. High expectations. People that tend to have high but reasonable and defensible expectations tend to do better. People that have very lackluster and ho-hum, kind of very sad expectations tend not to do well over time. But people that have energetic, high, but realistic expectations tend to do a lot better. Patience to listen. Some of the best negotiators that I've ever met don't speak that much. They listen, they gain information, they look at your body language, they take notes. Oftentimes people are hyper competitive negotiators are too busy listening to themselves speak. So they don't want to listen. They don't hear the problems that they can solve for you because they're too busy competing with you. And that's a problem. Ask questions, summarize, test for understanding, listen. That's who the best negotiators are. And then finally, personal integrity. Skilled negotiators prize their reputations and their reliability. Nobody wants to negotiate with people that are not reliable and truthful. That does not mean that you have to be a pushover or an unskilled negotiator. Some of the most skilled, successful negotiators that I've ever met are some of the most reputable people. They prize their reputation because it's their most expensive or most valuable currency is their reputation. So there'll be a tough negotiator. They may extract exactly what they want. It may cost you, but they're going to do it above the table because they have integrity and reliability. So with that, I'm going to end my presentation. And this is my contact information. If you'd like, you can contact me via email. I'm also on Twitter. But I'm also happy to answer any questions you might have here this afternoon.
Great. Thank you so much, Dr. Ahmed. That was a very informative session. I personally learned a lot, and it was, I don't really think about negotiation as a resident, as a fellow, but there will come a time where I will have to sort of use this information and knowledge to negotiate for a better position. I'll open the floor up for any questions. I don't see any comments at this time, and I'll just give it another couple of seconds for people to chime in. If not, then I will ask one of my questions.
Absolutely. So before we do that, I'm going to ask Dr. Ashwat. So Mahi, did you hopefully use my class? I made you guys work very hard in my class. And so hopefully, Mahi, you're able to use some of the skills I taught you over those 8 weeks.
Yeah, I think I enjoyed the whole MBA thing, but I think the best part of it was negotiations, I would say, because accounting and financials and stuff, you kind of listen to it and you learn it, but it goes away. But negotiations, actually, not just contract negotiations or even negotiating for a position or something, but it's something you just use every day and it becomes part of your life. And also, like Azim went over the different styles of negotiating. I think that was an eye opener for me because subconsciously you think everybody negotiates like you, everybody thinks like you in a way, but then you realize the different styles that people have and what your style is and how can you overcome that style and be a better negotiator. So I was a very accommodating and making sure everybody is okay kind of a negotiator, where I always valued relationships over outcomes. So that was an eye-opener for me in terms of realizing there are lots of different styles, and I would encourage everybody to kind of think of those. So that was a great talk, Azim. Thank you very much. And that was a great lecture series that I had from you too. So that was very helpful.
You're welcome. That's a great point that that Mahi makes, is just because it's your style doesn't mean it's your counterpart's style. And just because it's important to you doesn't mean it's important to them.
Yeah, I think Dr. Ashwath, mentioned a good point that, and I think Dr. Ahmed also mentioned, is that, as physicians, I think we sort of lean towards that sort of compromise, accommodating, and sometimes avoidance sort of negotiating style, because that's our culture. I feel like, as physicians and medical students, we're taught to sort of compromise and listen to the other team and try to appease the stakeholders, and so that kind of puts us at a disadvantage. Also, a disadvantage in the negotiating table. Also, the fact that we're not able to practice sort of negotiating styles, given that we go through years and years of training where we're residents and fellows and we don't get to negotiate or use our have any leverage or little to no leverage. And so once we sort of get into that a stage of negotiation, we're quite at loss in terms of what to do, where to go forward with, talking to our negotiating opponents. I guess that you can put them as opponents, but do you see this as a general sort of trend, as you sort of train different physicians and people in the MBA program? Do you see that a lot of the physician MBA students kind of adopt this sort of negotiating style? And how do we move forward from this? How do we change the culture to encourage future physicians and trainees to adopt a more quote unquote aggressive negotiating style, if at all possible?
Yeah, so I think that, I see changes, in the various, physicians that I've trained in the MBA program. So Dr. Ashwas was in the program, and then Dr. Mike Edmond was in that program, that same class. So Mike went on to be the chief medical officer at West Virginia University. And so, yeah, so as a trainee, you have very little leverage. It's just the nature of how training is. You have very little leverage because, well, your program director has pretty much all the leverage. I'm a program director, and essentially, the polite way to say is that, well, if you don't follow the program, then you're probably not going to graduate. And then all this work you put in kind of evaporates. And so there's very little leverage, and you get conditioned to that, right? In medical school, you're just trying to get in a residency, in residency, you're trying to get a fellowship, and then you become kind of conditioned. I think that as you're progressing through, there are ways to practice and get better at negotiation. So, I think whether it's even within kind of your interactions within the fellowship program and things like that. So if there's a problem that needs to be solved, and somebody comes to you and wants you to solve it or wants you to get involved, it is okay. Like, let's say that there's something that was also kind of that this could help solve something for you as well. It is okay to engage in a respectful dialogue in regards to that. You only get better by practicing. And so if there are things, whether it's scheduling, oftentimes you guys, if there's people on here that make schedules, there's a lot of negotiations that go on in schedules. Like I can't work then, and can you take a call here? And then all of a sudden it just becomes this kind of moving people around. And so scheduling and things like that, those type of bureaucratic things where you have to navigate are good times to practice your negotiations. But especially as you're getting towards the end of your training and it's time to become an attending, you really, really, really have to slow it down. You have to hopefully use some type of template, because what happens is you're so conditioned to just kind of moving on to the next level that I'm just happy to be here. Like in medical school, I'm just happy to be here. In residency, I'm just happy to be here. In fellowship, I'm just happy to be here. And then oftentimes people have that mentality when they are negotiating their attending contract that I'm just happy to be here. And that could be detrimental to that initial step in your career. And so know that you're bringing something valuable to the table. Know that if you did not have something that the other people wanted, then they wouldn't be inviting you to that interview or negotiating with you. And so understand that, because we're so used to just being happy to be here that all of a sudden you burst onto the stage of getting ready to attend, being attending and negotiate that contract, but people still have this I'm happy to be here mentality. You have something of value. It's something that they want to participate in or want to have you do what you do with them. So be respectful,